Sunil, you can mute everyone, right?
We are live.
So welcome to the third Global Neuro-Ophthalmology Case Festival 2023. The recently concluded G20 meeting at Delhi had its motto, One Earth, One Family, One Future. The Neuro-Ophthalmology Special Interest Group, NOSIG, originated in India 8 years ago for the sole purpose of case discussions in neuro-ophthalmology amongst members from all countries. Neuro-ophthalmologists are being trained at this very moment in several clinics all over the world, and special interest groups in neuro-ophthalmology are coming up in different countries. The participants of the first and second Global Case Festivals insisted on the third festival. With inputs from all members of NOSIG, the program has been put together and will be moderated by 6 of us over 2 days. All questions for the cases can be typed in the chat box on the web link and can be taken up for discussion. So here's wishing 6 episodes and 2 evenings of splendid entertainment along with science. Let me introduce the moderator for the first session. Dr. Padmavati, she is the Neuro-Ophthalmology Services at Arvind Eye Hospital, Tirunelveli, Tamil Nadu, India. She is in charge of the postgraduate section in the INOS Times. She is an avid neuro-ophthalmologist with 18 publications in international, national, and state. Areas of interest are disc edema, supranuclear palsies, OCT, and neuro-ophthalmology. Over to you, Padma, for starting the first session. You can share your PowerPoint slides.
Thank you, Dr. Satya, for your kind introduction. I think it has always been me as the opening batsman, okay, for the session. Yes. I have with me 3 panelists who will be there along in this session, along with the 5 speakers. So the first panelist who is going to be on board with me is Dr. Meenakshi. She is the professor of ophthalmology at Amrita Hospital, Faridabad. She has more than 200 publications, and she has presentations at national as well as international level. Her main areas of interest include multiple sclerosis, IH, visual fields, OCT in neuro-ophthalmology. The next person whom you are seeing is none other than Dr. Satya Karna, who's been instrumental in organizing this case festival. He is the director in the Department of Ophthalmology at JP Hospital, Noida. He has more than 25 years of experience in neuro-ophthalmology. His key areas of interest include neuroimaging, teaching basics of neuro-ophthalmology. He has authored the Shankar Netralaya Atlas of Neuro-Ophthalmology edition. He is the joint secretary of INOS from 2018 to 23, and also he is a reviewer in the Indian Journal of Ophthalmology. The next panelist is Dr. Rashmin Gandhi. He is a consultant and director of neuro-ophthalmologist at Center for Sight in Hyderabad. He is also the managing director for Sight Worldwide. And also his experience is more than 20 years. His keen interest is in development of new technology in ophthalmology community reach programs. He's a research scholar at IIT. He's also an adjunct faculty at IIT Madras. And the IIT Shankar Netralaya team, which he was instrumental who developed the mobile eye surgical units. He has also organized and conducted outreach programs in Zambia, Kenya, and Botswana. He's a member of the ICO. Apart from that, he has many honors and awards, which I couldn't include in it. Sorry, Rashmin, for that. I could interview because it goes for pages. So with this introduction, I stop for you. The first speaker, the international speaker who is going to speak, is Dr. Clement Tan. He is the associate professor and consultant ophthalmologist at National University Singapore, and he is also associated with the National University of Singapore. His areas of interest include neuro-ophthalmology and cataract surgery. He oversees the provision of training and assesses the postgraduate medical education in Singapore. He is also instrumental in implementation of policy and provision of eye care services across the western region of Singapore. The first case is going to be hungry eyes. Over to you, Dr. Clement.
Thank you very much, Dr. Padma. And if I may just share screen and we can start. Thank you to the Neuro-Ophthalmology Special Interest Group and all friends for inviting me and for organizing this this wonderful opportunity to share our cases. I have no financial disclosures that are relevant. The patient I'd like to present is a 12-year-old boy with no previous medical history who presented earlier this year to the emergency department with what was described as a 1-week history of blurring of vision in the right eye. And the right eye at the time of examination was no perception of light. There was, of course, an afferent pupillary defect. The eye pressure was normal. And the left eye, although the vision was 6/9 and the color vision was full, there was, as you can see, a very mild inferior largely inferior visual field defect in that eye. Both eyes, with the eye of faith, you can see that perhaps the inferior part of the disc was a little bit, of both discs was a little bit swollen. Neither was pale at this point in time. And on the OCT RNFL, you can see that there's possibly just some mild optic disc swelling. He was thought to have a bilateral optic neuropathy with mild disc swelling and underwent MRI of the orbits and anterior visual pathways. There was no contrast enhancement of the optic nerves, but what was noted was that there was mild T2 hyperintensity of both optic nerves. The MRI of the brain was normal. In respect of the rest of the initial investigations, the usual aquaporin 4 and MOC antibodies were negative. It was thought that he might have Leber, but later on, the blood came back as being negative for the 3 major mutations. He had a just borderline low hemoglobin, turning out to be a normal chromic, normocytic type of anemia, and he was noted to be a little bit underweight. So we sent him for electrophysiology, and unsurprisingly, the pattern VEP in the right eye was undetectable. The left eye, it was quite significantly delayed in the pattern VEP, although the amplitude still looked quite all right. But what was surprising was that the ERG, although indicating normal cones, you can see from the absence of the A waves, there was no detectable rod function. At that time, the electrophysiologist gave me a phone call and said, I wonder if this child has a vitamin A deficiency. And so we promptly brought the child back and asked him the history again. This time he said, well, he had been, the parents and the child said, well, he'd been wearing glasses since he was about 4 or 5 years old. And at a routine refraction last year, he was told that he had a bit of a lazy eye. And he himself started to notice that the vision was a little bit blurred in the right eye at the end of last year, but took no further notice of it until on the day of presentation in January this year, he happened to close his left eye and noticed that everything was dark in the right eye. Because of the suspicion of a vitamin A deficiency, we asked him for his diet, and we discovered that he practically eats nothing other than fried rice and potatoes, no vegetables, no meat. Maybe twice a week he'll have some eggs or tofu. The blood investigation showed that his vitamin A was virtually undetectable, but in addition, copper and zinc were both quite reduced. Liver function showed a mild transaminitis and raised bilirubin, but otherwise the other vitamins were normal, and he was again admitted for these investigations, and the lumbar puncture showed that the CSF opening pressure and the CSF composition was normal. So this is a child with multiple vitamin and trace element deficiencies. At that time, this is almost 2 months after his presentation. You can see that the ganglion cell layer in the right eye is very much thinned out, and the left eye is beginning to thin out. He was placed on multivitamins and enhanced milk formula, and what worried us was that over the next couple of months, as we started to treat him, his visual fields in the left eye did not seem to improve very much, although his visual acuity remained at 6.9. We repeated his electrophysiology and found that, well, in the right eye, although his visual acuity had improved a little bit to hand movements from no perception of light, but the pattern VEP was still flat. What worried us even further was that the pattern VEP seemed to be even more delayed in the left eye. By that time, though, although he had, and by that time, though, he had been on supplementation for quite a while, and the ERGs had begun to show improvement in the rod function in both eyes. So the vitamin A seemed to be working for him, but the optic neuropathy and the retinopathy seemed to be getting better, but the optic neuropathy did not seem to be improving. At our last review, which was just a few days ago, his diet is still poor. His parents are unable to get him to eat anything more than the rice and maybe just a little bit more. They've tried giving him vegetables, but he refuses it. So he's still really much supported by milk and multivitamin supplements. But what is a bit more of relief is that although the right eye is not really improving a whole lot, but the left eye's visual acuity is back up to 6.6, and his visual field defects are beginning to improve. So what we've learned from this, well, children and parents are not always the best historians, especially sometimes in the acute setting. Early electrophysiology is indeed very helpful, because without that, we might not have even jumped in the right direction. You would hardly expect a child in very prosperous Singapore to have a deficiency of some sort, but these things just pop up and bite you on the behind every once in a while. The visual system is really highly dependent on micronutrients, B vitamins, vitamin A, copper, zinc, and the deficiencies may not be obvious. Now, we are all aware that autistic children, for example, if you have an autistic child, that would certainly raise alarm bells for nutritional deficiencies, but this child was, for all other intents and purposes, quite normal, and had we not dug further, we would not have found out why he was so deficient. And the eye can certainly go hungry, even in a very prosperous city like Singapore. So thank you very much for your attention, and happy to take questions.
Thank you, Dr. Clement, for the wonderful presentation. Vitamin A deficiency, even in developing countries, it's still very rare. I would like, the questions I would like to pose to you is, could you classify this as a case of nutritional optic neuropathy?
Yes, I think this is a case of a nutritional optic neuropathy. I do regret that we didn't get to this child earlier, but his visual loss, if you look back at the history, started more than 2 months before, probably 2 months before he presented. And with time going on, sometimes the losses are irreversible. Where I'm hopeful that we'll still reverse some of the losses in the left eye, and at least we'll stabilize it and it'll not get any worse. I'm less hopeful for what's happened with his right eye. At least it's gone from NPL to hand movements, but not much better than that, I'm afraid. Yeah, so I would say this is a case of a nutritional optic neuropathy.
In case, if you're commenting this is a nutritional, the presentation usually would be a bilateral rather than a unilateral.
Yes, and so that's why we were initially not really certain, and we continued to dig around for inherited retinal disease. I know I presented the labor mutations right at the beginning, but we did take them, but it did take a while for labor to appear. We searched for all the other inflammatory optic neuropathies. All the other tests were negative. I'm certainly open to further suggestion of what else we might be looking for, because as you say, it's rather unusual to be so asymmetric in its presentation.
Clement,
yes, go ahead, Rashmin. Yeah, sorry.
Clement, so there were no other signs of nutritional deficiency?
Yes, that's the other thing I forgot to mention. He had none of the other no skin signs, no other neurological signs, no other eye signs of vitamin deficiency. And that was a bit, that's the part that we could not completely reconcile. But there being no other other information that we could adduce, and we ran this trial through nearly everything. We're down to just this last bit. We're down to this, and so yes, it is a bit surprising that there was nothing else other than the visual system that was affected in this case,
And
despite his vitamin A levels being so horrendously low.
I have a basic question. Would you recommend an ERG in all these cases? Because usually the usage of VEP in case of optic neuritis is a bit minimal in our country, but your usage of VEP with pattern, ERG also was there. So that made you clinch the diagnosis.
So, if it were possible at all, I would love to have the full electrophysiology for all of these cases at the outset, right at the diagnostic stage. That would really help to tell you whether or not you you have a largely retinal problem or an optic nerve problem. And I think this case was ordered because the ERG was ordered because the initial MRIs did not show anything that was suggestive of an acute optic neuropathy. And I think I think there was a question about what the MRI findings show. Well, I've asked the neuroradiologist a few times before in the past what T2 hyperintensity means. And the answer is, well, it means that there has been past damage to the optic nerves. So that should have told us that whatever was happening to his optic nerves, it was going on for a while, probably going on for a while already. And that is my assumption for this. In terms of the update on what his fundi look like right now, well, the right disc has gone pale and the left has now showing some temporal pallor. There's no more swelling at this point in time.
Is there any role of IV methylprednisolone in such cases? Would you recommend that? Yeah, because there are two schools of thought where one people in nutritional, they just give the nutritional supplements. The other group gives the nutritional supplements with IV methylprednisolone. Yeah,
I did think about that, but I think in discussion we decided that we'll just stick with the nutritional supplement. There's a question about the ICP. The opening pressure was normal.
Satya or Dr. Rashmin or Dr. Meenakshi, any other comments you would like to give?
Genome sequencing. Yeah, there's a question on genome sequencing from Ambika, and yeah, that would certainly be the idea. I mean, are you would you be thinking of the other mitochondrial, the secondary mitochondrial ones, right? So that's the other thing we have to pursue, I suppose, with the family, and it's not so straightforward for us to order genetic tests because they have to go through a long consultation with the geneticist. But that is certainly I think that's a really good idea, and I will moot it to them to say, well, you have to consider whether it might be other things. Though I'm not sure. The question they will ask is, well, how will that add to the treatment? And I don't have a good answer for how unless we give the I'm not sure about how many of you believe in those mitochondrial cocktails that they are giving out these days, and they're giving out quite a lot of them for any mitochondrial disease that they find. Maybe there's some benefit from that. Yes, Stefan has a good point. The other eye would have gone blind if it were labor. But there are other mitochondrial diseases that sometimes get picked up where and some of the, I think the other genetic deficiencies, mitochondrial genesis, they may not go completely blind, but who's to know?
Okay, if there are no questions, I think we can, if any other inputs, please give your comments in the chat box. The next will be an interesting case of, does lightning strike twice? The presenter is going to be Dr. Carmen Chen. She is the Chief of Service and Consultant Ophthalmologist at the Department of Ophthalmology and Visual Sciences at the Chinese University, Hong Kong. She is associated with the Hong Kong Eye Hospital, Chinese University of Hong Kong. Her publications are literally more than 70 papers in peer-reviewed journals, and she is on the editorial. She is on the editorial board of the Journal of Neuro-Ophthalmology, Asia Pacific Asia Pacific Journal of Ophthalmology, on the Hong Kong Journal of Ophthalmology. She is the convener of the Hong Kong Neuro-Ophthalmology Interest Group, a council member of the Asia Pacific Neuro-Ophthalmology Society, and she is also a member of the NANO's International Relations Committee. Over to you, Dr. Carmen.
Thank you, Dr. Padma, for the kind introduction. So let me share my screen. So my title today is Does Lightning Strike Twice? And hopefully by the end of this presentation, you will know why the title is as such. So I'm going to present to you a 54-year-old Chinese lady who is a clerical worker. So she presented originally to us in March 2020. So she presented with a 5-day history of right eye infratemporal scotoma. She must be obviously quite a perceptive lady, because some people don't really notice these kind of scotomas if their central vision is not affected. So it's painless. There was no preceding URTI, upper respiratory tract infection, vaccination, or COVID, although this is the beginning of COVID. She enjoyed good past health, except hypertension. She's a low myope, but she does give a history of bilateral optic neuritis when she was age 20 in 1987. I mean, amazingly enough, she actually brought along a photocopy of a letter from 1987 giving us the details, but she was seen by a neurologist. So the ocular findings and the visual acuity were not really, they were really not too well documented, but the rest of the clinical history was quite detailed. So she presented with right eye decrease in vision with scotoma and found of both eyes swelling. So she underwent extensive investigations, well, by the 1987 standards. So she had a CT brain orbit with contrast LP and VEP, were all normal, and MRI was not done at that point. She was treated with a short course of steroid with complete recovery. So she was well until 30 years later. So when we first saw her, her central vision was not bad. The Ishihara was full and fast, normal intraocular pressure, mild right relative aberrant papillary defect. The extraocular movements were full with no pain or eye movement. There were no intraocular cells. The fundus, I'm sorry that I do not have a fundus photo because it looked so normal. There was really nothing much to photograph, but there was a little bit of blurred disc margin. So when you actually ask her, so what is wrong? And if you gave her an Amsler chart, she'll tell you that there is a scotoma in the right eye as documented on this Amsler chart here. So in fact, so we proceeded to do a Humphreys 30-2. So the left eye was completely normal, and in the right eye, there was an enlarged blind spot. So we also did, because OCT is my favorite tool, so we also did an OCT of the optic nerve head, which did show very mild diswelling in the right eye. The left eye, 111, is almost within normal limits, but the right eye certainly a little bit abnormal. So some baseline investigations were done by the residents who were ordered by the residents who saw this patient first. Really nothing too remarkable, but except the ESR was a little bit raised, the ANA is a little bit raised, but once again, non-specific. But I'm amazed that the resident did an NMO antibody before anything else, but the chest X-ray was also normal. So maybe at this point, I would like to hear your thoughts about what the diagnosis is. If you already know the diagnosis, so don't shout it out. So any offers from anyone? I think in a patient with a previous episode of optic neuritis and now RAPD with a mild swelling, of course, the first thing which comes to mind is optic neuritis. However, well, the Ishihara is full. There was no pain or eye movement. I mean, this itself does not rule out optic neuritis, of course. But but there was another clue. Let me see whether we have another clue. So what would you do next at this point?
Carmen, there's a question.
Yeah.
So
okay.
The earlier episode of so-called optic neuritis, was it before the ONTT or after the ONTT?
ONTT was 1991, right? This was in 1987.
Okay.
Yeah. So any other questions? So by that time, the resident who saw this patient referred the patient to the neuro-ophthalmology team and was seen by my fellow. So my fellow is a really bright guy. So he actually took a better history. So in addition to scotoma, in fact, if you look at the Amsler chart, he actually wrote here, there was also photopsia in this area, as remarked here. So what now goes through your mind? So photopsia is not a sign of optic neuritis. So, and it's a retinal symptom. So he very astutely went on and did an OCT of the macula. So when we looked at the red free of the right eye, you can see something quite a little bit normal. There's some question. Yes, as Dr. Clementine suggested, yes, OCT of the macula and autofluorescence, precisely. So there are these blotches on the macula, and if we look carefully at the axial scan, the outer retina looked a bit abnormal, and there's a little bit of diswelling. So, in fact, this outer retinal abnormality is more marked if you compare the right eye with the left eye. So, and it was associated. So the left eye, you can see very nicely the ellipsoid zone and the interdigitation zone, but the right eye, it looks a bit mangled. So at this point, our provisional diagnosis was acute zonal occult outer retinopathy, AZOR, versus acute idiopathic blind spot enlargement syndrome, or AIBES. But the differential diagnosis can include multiple evanescence white dot syndrome. It's possible that there were white dots. It's just that it's possible that the resident who first saw the patient may not have spotted it, or because they can be quite subtle. So the patient was offered oral prednisolone, but the patient did not take it because the symptoms were relatively mild. So a full field ERG was ordered to rule out general retinal dysfunction. So in the subsequent month, so the patient was observed without treatment. So by the next month, when she came back, the scotoma and the photopsia was already improving, and so was the diswelling. So in fact, when we repeated the visual field in May, the enlarged blind spot has resolved, and the diswelling was noted to be resolving as well, but not completely normal in May. So everything was going fine. And we actually went on and did a full field ERG as well. So at that point, the full field ERG was normal and symmetrical. So at this point, we thought that this is more likely to be AIBES rather than AZOR, because AZOR is more likely to be associated with the diffuse retinal dysfunction. But it could also be, by the time we managed to do the full field ERG, the symptoms have almost resolved. So it could be that it was abnormal to begin with, but it has already is resolving or resolved. So, but she came back a few months later, so 6 months after the initial presentation. The right eye symptoms have completely resolved, but now this time she has a left eye central scotoma for 1 week. Painless again, and this time with reduction of left eye visual acuity and color vision. And it was remarked that she had no ROPD, but I don't know how carefully this was checked. And on fundus examination, there was the right eye disc was normal, but there was minimal left diswelling with mild RPE mottling. So this is the OCT, right eye, March and September. So you can see that actually it's quite nice, because in the right eye, all these blotchy things in the macula have resolved by September, and also the outer retina structure has normalized in the right eye. Whereas in the left eye, you could see in March it was completely normal, but by September, the outer retina structure is the ellipsoid zone and the interdigitation zones are both, well, ill-defined, shall we say. Oh yes, there's a question. Can I highlight the differences between the two? So I'll come to it in the discussion. So that those are the abnormalities. So in fact, the medical photographer also did a macular scan on the optic disc, which is quite useful in this case, because what it showed is that in the right eye, the mild swelling back in March had resolved, whereas this time, whereas it was normal in March in the left eye, by September, in fact, there's slight, only minimal swelling, but it is swollen compared to March. This is something that only OCT can tell you. With the naked, well, with clinical examination, this is very difficult to make out. So at this point, the impression that this is recurrent AIBES, or because it's slightly more extensive, is this azure instead. So she was given a week of prednisolone, a medium dose, is neither here nor there, well, actually low dose, and she subsequently had slight improvement. Whether this was spontaneous or as a result of the prednisolone treatment, we don't know. So subsequently, she had further gradual improvement, and by only 1 month later, the vision has improved back to 20/30 with normal color vision. So this was the serial OCT. So in all of the left eye in September, so you can see the outer retina is quite abnormal. By November, you can almost see the lines coming back, and by 1 year later, this has completely resolved. So any infective workup, I'm afraid we only did Hep B surface antigen. I agree with you that infective workup would have been useful, especially syphilis, because we should always do syphilis. There were no cells in this case. So 1 year later, symptoms have resolved. The vision has returned to near normal, Emerson chart was normal, and the Ishihara was full, and her symptoms have not recurred ever since. So I'll just give you a very brief overview of recurrent or brief overview of AIBES or azure. So AIBSE was first described by Bill Hoyt in 1988, and azure was first described by Don Gass in 1992. So of course, Bill Hoyt was a neuro-ophthalmologist, and Don Gass a retina guy. So there's always a debate as to whether these two diseases are in fact different spectrum of the same disease, and whether AIBSE is just a milder subtype of azure. And in fact, apart from these two entities, there are also other disease entities that ophthalmologists tend to group them together as the white dot syndrome. So all of them have the distinct demographic distribution. In fact, they all affect young women more than men, or well, young people and women more than men. AIBSE, BSE, sorry, and azure usually have near normal fundus to begin with, at least. And abnormal fundi includes those with, for example, multifocal choroiditis, punctate inner choroidopathy, and acute macular neuroretinopathy. And MUs, I put it in the middle because if you see them soon enough, you will see the white dots. If you see them 1 or 2 weeks afterwards, it's possible that the white dots would have disappeared already. Okay, they usually affect young market women, and they present with zonal field loss. So these patients have to be quite perceptive to notice them, because some people don't really notice zonal visual loss, especially with both eyes together. So studies have shown that maybe in about less than half the patients, they may have some vitreous cells. And usually there's no fundal signs, but in this age of OCT, I suppose if we do OCT on all of them, we'll find that at least a proportion will have at least mild swelling, which is not detectable on clinical examination, but would be detectable on OCT. So with chronic or more severe patients, you may get retinal or choroidal atrophy, especially in azure. So in our patient, she actually recovered completely with complete resolution of all physical signs and symptoms. That points to either a very mild form of azure or AIBES. So classically, they're associated with viral illness and vaccination, but in her case, these were not present. So the diagnosis, the previous gold standard was multifocal ERG, and there would be a focal reduction of first order responses, which correspond to the visual field defect. So this is not of that patient, but this is of another patient with azure stroke AIBES. So left eye was normal, right eye, you get this selective loss of first order responses. Nowadays, in fact, the gold standards has shifted to spectral domain OCT. So what it does show is that, so this is another patient because this OCT looks better. So basically what it does is that it shows disruption of the photoreceptor ellipsoid zone and also the interdigitation line. So the ellipsoid zone is previously known as the ISOS junction, and the interdigitation line is previously known as the cone outer segment tips. So if there are neurologists amongst our audience, let me just expand this a little bit. So basically the outer retina is made up of the outermost layer is the RPE Brooks membrane. The next layer, so the sandwich in between, is the interdigitation zone. Then the most obvious line is the ellipsoid zone. And this faint line is the external limiting membrane. So in this patient, you can consider this side of the macula is normal, and this side of the macula is affected by azure. That's why all these four lines are kind of merged into one, but very clearly demonstrated. So there's a trend towards multimodal imaging nowadays. So in the acute stage, fluorescein angiogram is likely to be normal. In autofluorescence is a very useful tool. So so actually Dr. Andy Lee remarked that he always tells his resident that the most common cause of acute blind spot enlargement is the acute blind spot enlargement syndrome, which is very, very correct. So because once you diagnose it, in fact, you don't really need to do many more investigations. You can save the patients from costly investigations and potentially harmful treatment as well. So anyway, so in fundal autofluorescence, for severe and chronic azure, it can give you a trizonal pattern. So basically, in zone 1, which is the normal zone outside the affected zone, is normal. Then in the active zone, where there's active azure, you can get a speckled hyperautofluorescence, whereas in the inactive zone, where there's choroidal atrophy, you get hypofluorescence, hypoautofluorescence. So as for the distinction between AIBES versus azure, to be honest, I've read a lot of references, and really, most papers do not make a clear distinction, but it appears that AIBES is maybe a milder and more localized form. And therefore, so in these cases, I won't do a multifocal ERG, but I would actually do a full field ERG so that I could actually distinguish between the two better. So I would expect a full field ERG to be normal in AIBES and abnormal in azure. So treatment, there's no proven treatment. However, I mean, if the visual loss is severe, for example, in fact, if you look at so this patient, as you can see with eventual choroidal atrophy, is obviously much more severe than the patient we talked about just now, who's basically recovered spontaneously. In these patients, I would always try a course of steroid just to see whether it works or not. If it doesn't work, so be it. So perhaps steroid or immunosuppression may be indicated more for severe forms of white dot syndrome or recurrent or progressive. Recurrence is unusual and is in about less than 25%. That's why, so hence the title actually, because AIBS, azure, or mutes are relatively uncommon, so it's just like lightning. But having it recur more than once in the other eye is even rarer, so it's like lightning striking twice. So the most important for us and our residents to know is that this can be a mimicker of optic neuritis because of the RAPD and the milder swelling. But notice of the painless nature, the photopsia is quite a telltale sign. The central color may be normal, but in optic neuritis, color vision may be normal as well. And as many of the panelists have pointed out, it's important to look for anterior chamber and vitreous cells, because if these are present, this will really point to a white dot syndrome type of picture. So if in doubt, do a macular OCT. So I don't do a multifocal ERG anymore. And if the retinal abnormality is demonstrated, no need to proceed with other investigations like an MRI. And there's no proven treatment. So I think that concludes my my presentation. So I see that there are quite a few comments here. So let me just stop sharing. So Dr. Andy Lee remarked that they have been admitted as retrobulbar optic neuritis through the hospital emergency department. And yeah, so there's no OCT or Humphrey's visual field in the emergency department. So this is, yeah, this happens to us as well. It depends on who the patient presents to. If the patient presents to us, the eye department, then we can do an OCT, because OCT is relatively easy to do and we can just do it stat. And then if we make the diagnosis, we save them from being admitted. But if they present in the middle of the night through our emergency department up to our ward in the general hospital, because they would have been admitted with optic neuritis. So once I actually had to discharge a patient back from the general hospital to the eye department to have the OCT. And once the OCT demonstrated the abnormality, I discharged the patient. So yeah, so there's not much equipment that we can put in the ED precisely. So, but we have an eye ED emergency department. That's why we can do that here. And emergency electrophysiology, well, difficult because so at SNEC you have Professor Holder who can help you. For the rest of us, we just have to do a non-routine, well, we just have to do with non-urgent electrophysiology. So yeah, that's all from me. So any comments and questions from anyone?
Thank you, Dr. Carmen, for the wonderful explanation. Dr. Vinakshi, please take up the questions.
Actually, Dr. Chan has covered most of the things which would have come to my mind. But like they say that there is sometimes a gray zone around the disc. Did any of your patients have it? And what is your experience of seeing that gray zone around the disc in these patients? And primarily the pathology is supposed to be peripapillar. So when you're talking of all your macular scans, you talked of them being in the macula. Kindly comment.
Oh, okay. So yes, in this patient, there was no residual signs whatsoever. But in some other patients, when whether it's AIBES or azure, when they resolve, there's a little bit of, well, at least in my patients, they were not very marked CR atrophy. So not, because if they're really so marked, we would probably have labeled them as serpiginous as opposed to azure or AIBES. But this may be a continuum, and this may just be terminology. So they are peripapillary, but the problem is if we do, because we need the, if we do a peripapillary scan, I normally use Cirrus OCT, which I find not good enough to pick up the subtle outer retina. So so in terms of practical arrangement, I have to use the spectralis to do a macular scan, whether it's actually on the macula or on the optic disc. So you actually have to do the line scan to demonstrate the outer retinal abnormality. Otherwise, it's not of sufficient resolution to demonstrate those abnormalities.
Another thing, this was the COVID times. Could it be that she had an asymptomatic bout of COVID, which led to this this scenario?
I think is quite possible. I think in Hong Kong, because in 2020, in fact, the whole of 2020, not too many patients in Hong Kong had COVID. Our worst bout was actually in 2022. So it's more unlikely that she would have had, it's possible, but it's less likely because not many patients had COVID in 2020 in Hong Kong.
Would you like, there are sometimes changes in the retina as well in multiple sclerosis. So would you ever think that you would like to get an MRI done in such a case, or you would not consider it?
I think in this case, I have to confess, once I saw the abnormality, I did not proceed to do an MRI, and especially that the symptoms resolved. Yeah, I would like to ask the other panelists, would they have proceeded to do an MRI in such a situation?
So generally, those changes in multiple sclerosis would be around the vessels. Those pigmentary changes would be across the vessels. So I don't know whether it'll be like what this patchy picture that you had. One more, I mean, since I'm here, Carmen, would Azure lead to, I mean, after a point in time, reduction in vision? And would it improve so dramatically in a month, or would it lead to more destruction and ultimately loss of vision?
It can do. It can do. I think it's a spectrum. For example, the trizonal outer the trizonal picture we saw of the FAF. I'm sure the patient had loss of vision. So if it results in retinal or choroidal atrophy, it would definitely result in loss of vision. But I think it's a continuum, because in fact, so of the white dot syndrome, because some of the white dot syndrome do not recover completely.
Actually, in one of the classifications of Azure, it was the subgroup which says that it's the retina is normal, is where this AIB-SC would come in. So that will.
So I have a observation here.
Mm-hmm.
So I think everyone noticed the first case of AIB-SC was reported in 1988, and the first case of Azure was reported in 1992.
Yeah.
And this patient had her first episodes in 1987 before those two.
Yeah. Oh, yes. Yes. So it really would not have been diagnosed anyway. So yeah. So in fact, I'm sure these cases, although they have not been named or discovered, but I'm sure they existed before the publications.
I think another take home could be that whenever we see a slight blurring, we should go ensure that we get the AMSLR and the HFA done and not disregard it, even if the patient doesn't complain.
Yeah. So actually, just now when you mentioned that we need emergency electrophysiology or OCT and everything else, but I think that would have given us the definitive diagnosis. But even something as simple as an AMSLR chart can be quite useful in these cases too.
There is a question in the chat box. Can severity of vision loss differentiate RBN from AIDS?
Yes, because because RBN is retrobulbar optic neuritis, right?
Yeah.
Yeah.
Retrobulbar neuritis.
Yeah, retrobulbar optic neuritis really can range from a whole range of vision, from usually not NLP, but can range from LP to near normal. Whereas in AIBES, usually the visual loss is relatively milder. And something which you've just reminded me, because if the patient did have an episode of optic neuritis back in 1987, I would have expected her OCT RNFL to be somewhat reduced. Because as we know, even patients with complete visual functional recovery, they usually have some loss of OCT RNFL, but in her case, it's intact. So I think it really points to that. Maybe even in 1987, she did not have retrobulbar optic neuritis at that point.
But then this will become one of the first few cases to be reported as something where the recurrence happened 20 years, 2 decades later.
Yeah.
Very unique.
Yeah, unfortunately, we did not have spectral domain OCT, and we did not do ERG. the neurologist did a VEP as neurologists do, but did not do an ERG, which is if we had that, we could report it.
Because at 54, she is too old to have the first AI-BSc.
Yeah. Yes. And Dr. Andy Lee commented that in the ONTT, only one patient out of the 454 had an enlarged blind spot. Actually, this is a very useful fact. So if they have enlarged blind spot, it's most likely AIBES. Yeah. Okay.
Okay.
Shall I let you go on to the next case? Otherwise, we'll
Yeah.
overrun.
Yeah, thank you. Thank you for the presentation. The next case is an interesting case. Why did the dog not bark in the dark of the night? The presentation, it would be Dr. Umapati Tirunyanam. He's a senior consultant at Singapore National Eye Center. He's a great teacher. He has been teaching and serving at various hospitals in Southeast Asia, Middle East, and Africa over the last 15 years. He's a honorary visiting faculty of the Arvind Eye Care System also. He's a professor at Search and NGO in Maharashtra. He's a honorary professor of training at the Vietnam Neuro Association. His subspecialty interests include neuromuscular disorders, electrophysiology, autonomic nervous system, eye movements, and neuroimmunology. Over to you, sir.
Thank you, Dr. Padma, for the kind introduction. And Dr. Satya, thank you very much for, I must have done something right the last year because you invited me again. So, so today I've got three quick cases, and I would like to firstly thank my three excellent colleagues, Dr. Yo, actually four, more than four actually, a few of them. Dr. Yo Tion Rong, Dr. Sim, Dr. Fifi Go, Dr. Sean, and Dr. Vaidik, who actually made all the heavy lifting for these cases, made all the diagnosis. And I'm just the cameraman who took the pictures, edited it, and presenting it to you all. So credit to them. And for those of you who are watching it through YouTube, please respect the privacy of these patients because they were very kind to allow us to film these patients, film them. And then the last thing is apologize if the videos are suboptimal because it was all my fault. It's all my fault. And finally, if the internet is poor. Okay, so I start off with the first patient. It's a 69-year-old lady who presents to the hospital with subacute diplopia and unsteady gait that was progressing over a period of few weeks. So on first, off the bat, the first thing you can notice is that she has got a slight head tilt to the left and a slight hypertrophy of the right eye. Okay, and possibly some esotropy of the left also, but more importantly, the right eye is higher, the left eye is lower, and the head is tilted to the left. So consistent with the skew deviation. So straight off, you can suspect that this is possibly a brainstem pathology. And because of this famous mnemonic of Dr. Z, high, high, low, low. So this could be either pointing to the right, the eye that's eye higher could be pointing the side of the midbrain or upper pons, or the side that's low, the eye that's lower could be pointing to the side of the medulla and lower pons. So going back to this lady, she could either have a right midbrain or left pons, right midbrain upper pons lesion, or a left medulla lower pons lesion. Okay, so that's the information that we can glean from a still photograph. Then after that, we get her to move, and you can see that moving right and left, and as annotated below, she has difficulty with looking to the left and looking to the right with regards to abduction of both eyes. So reduce abduction of both eyes. And the rest of the eye movements were essentially normal. So the abduction of the eye, left eye slightly more than the right, and that would explain why we saw a bit of esotropia in the first video. Okay, then I'll go on to the next picture, which actually shows the only other pertinent finding in the rest of the cranial examination, which is bilateral lower motor neuron facial weakness. Mild, but nevertheless definite bilateral lower motor neuron facial weakness. The rest of the cranial nerves were normal. Okay. And then on closer inspection, we did notice that occasionally she has a few upbeat nystagmus, few bouts of upbeat nystagmus, and occasionally a few intermittent, inconsistent, gaze-evoked nystagmus on either side. Okay, the rest of the limb examination was remarkable for a presence of Babinski's reflex on both sides. The rest of the neurological exam was completely normal. So, the way we approach patients with cranial neuropathies is based on this 4+1 rule that was made famous by one of my teachers, the late Professor Long Sicheng. So we call it the 4+1 rule because basically it says that any cranial neuropathy, whether it's isolated or multiple, can be worked out based on this 4+1 rule. And it's based on a simple anatomy that, all cranial nerves except for the first and the second nerve start from the brainstem. So this lady's bilateral 6 and 7 could be in the brainstem because as you can see in this diagram, the 6th and 7th cranial nerve are very close together and the location would be the side close to, the cut close to the facial colliculus. Both the 7th nerve and the 6th nerves are coming close together. A bilateral lesion here could explain the cranial nerve deficits in addition to the skew deviation and in addition to the bilateral Babinski's reflex. Okay. The other rules of the cranial nerves suggest that the cranial nerves come together in certain locations. I call them the cranial nerve clubs. So cavernous sinus and orbital apex can't explain any of these lesions that we are talking about. A diffuse meningeal and skull-based disorder can explain this, but as you can see, the time frame, she has developed this over a period of weeks, without any fever, without any meningism, without any signs of meningitis. It's not suggestive of a meningitis. And finally, could this be some form of Guillain-Barré syndrome? Well, Guillain-Barré syndrome is well known for causing a peripheral neuropathy and together with cranial neuropathies, but it's a peripheral nervous system disorder, except that there is one particular variant of Guillain-Barré syndrome known as Bickerstaff encephalitis, where the patients have all the features of Guillain-Barré syndrome plus CNS features. So that is one possibility to consider, Bickerstaff encephalitis. Okay. So with that, we went ahead to do the imaging, and the imaging was remarkable because it did show that at the side of the facial colliculus, so the way I teach my medical students is that the facial colliculus is like where you can see two udders, just like the udder of a cow. You see two udders, and that's where the location of the facial colliculus is. And that's a very important location because the 6th nucleus is there, the 6th nerve is there, the 7th nerve is there, and then right in the center, you have the two MLFs. Okay, so that's a good location for neuro-ophthalmology. So she does have non-enhancing signal changes, mainly on the flare scans in this location, suggestive of pathology that correlates with the clinical signs. So then, once we have decided where is the lesion, the next thing in neurology is to decide what is the lesion. And for that, I usually go through a very simple checklist of 6 pathological categories. As you know, all diseases in humankind, or not just humankind, actually animal kind as well as plant kind, can be divided into 6 groups: genetic disorders, metabolic endocrine disorders, vascular degenerative disorders, neoplastic and paraneoplastic disorders, infectious and inflammatory disorders, and finally, disorders related to human activity, where you have to deal with trauma, sports injury, toxins, drug-induced problems, and all that. So if you go through that, what can cause bilateral signal changes, non-enhancing flare changes in a elderly lady with no other medical problems? Well, could it be a metabolic problem? Well, Wernicke's is well known to cause this kind of problems, but she has had no history of anorexia. She has no history of ethanol misuse. She has had no bariatric surgery or anything of that sort to suggest that. Osmotic demyelination is an important condition to consider, but again, there was no history of sodium abnormality, no correction of hyper or hyponatremia. And again, the time frame is not quite right, over a period of weeks. So what is the next group of condition to consider? Well, neoplastic. Well, again, if this was a child, a pontine glioma would be an important consideration. And in an older patient, you have to think about CNS lymphoma. But again, the signal changes that are seen on the MRI are not quite suggestive of a neoplastic lesion because they are just seen on flare changes with very little, with no contrast enhancement at all. And then infectious diseases, again, we always have to think about HIV and syphilis, the great mimickers. So that was considered in this patient. But the garden variety meningitis, acute and chronic, can't explain her clinical features as well as the radiological features. Well, inflammatory disorders are quite enticing to think about because if you think about diseases that the body is able to tolerate without much treatment for a period of time, it's often inflammatory disease because the disimmune process is often slow and often sometimes brewing in such a way that the body is kind of forgiving. It doesn't go on and cause much problems for a period of time. So inflammatory disorder was considered. What type? Well, as I said before, Bickerstaff encephalitis is something to consider. But Bickerstaff encephalitis, usually the brain scan does not show any changes. So not the type of changes that we are seeing in this patient. Often the scan is normal in Bickerstaff. MOGAD is a possibility, but she had nothing else to suggest a chronic MOGAD disease. Then with regards to systemic immune disease, what was very fascinating was that on system review, it was very clear that she had very prominent Zika symptoms. She was very much bothered by dry eyes and dry mouth. And with that, ENA antibodies were done relatively early, prompted by a good system review. Now, in terms of human activity, there was nothing to suggest any iatrogenic cause for her symptoms. So with that, results came back. ENA antibodies did come back very high. Her Schirmer's test, excuse me for the spelling error there. The Schirmer's test was very positive. She also had evidence of autoimmune hemolytic anemia, thrombocytopenia, renal tubular acidosis on further evaluation, which are all consistent with the manifestation of systemic Sjogren's disease. Now, incidentally, when we screened the gangliosides for Bickerstaff encephalitis, anti-GD1A antibody was positive, but we think this is a non-specific antibody because in Bickerstaff encephalitis, you should get a GQ1B antibody. So we think this is not specific. So the final diagnosis is a brainstem inflammatory disorder secondary to underlying Sjogren's syndrome. With that, she was started on treatment by the rheumatologist. She was taken over by the rheumatologist. Initially, my colleagues gave her IVIG, but the rheumatologist took her on and put her on more of the nuclear weapons of chemotherapy. And the patient, I'm happy to say, has done quite well. Neurological deficits have improved quite significantly. Now, the next two cases are very fast, quick cases. 51-year-old lady, again, with no significant past medical history, comes in with a 3-month history of progressive worsening diplopia, ataxia, some vertigo, and clinical examination is remarkable for the following findings. Okay. Now, if you think that the slowing of saccades is due to the poor connection of the internet, well, I must say it's not. It is really slow. And it was so remarkable that we all got excited. And because I've never really seen a patient with such severe isolated slowing of horizontal saccades. And you can see straight away by comparing it with the vertical saccades. Okay. As you know, the way to check saccades is to give 2 objects and ask the patient to look to one object and then the other. Normal saccades, it's defined by the eyeballs missing and appearing at the other side, missing and appearing at the other side. If you see the eyeballs actually moving, they are slow saccades. So in this case, it's remarkable that she has no other ocular findings except for slowing of vertical saccades. In terms of general examination, she had a very mild limb ataxia, okay, mostly in the lower limbs, manifested as gait ataxia. Okay, so with that, we localize the pathology to the brainstem, again, specifically to the pons, specifically to both the PPRF. But again, for somebody to have just pathology in the PPRF with nothing else going on with a bit of ataxia sounds very much like an inflammatory immunological disorder rather than a space-occupying lesion, because it's very difficult to get just the 2 PPRFs on both sides. And then with the system review revealing significant loss of weight, and and the discovery of a breast lump. Okay, cancer of the breast was diagnosed. So with that, we specifically went ahead and did anti-paraneoplastic antibody and found anti-Re antibodies, which explains the neurological manifestation of an isolated brainstem encephalitis. With that, she was started on immunosuppressive therapy. She responded very well, but because she is of Indonesian origin, she was here working on work permit. So she wanted to return to home country for treatment of a cancer, as well as a inflammatory paraneoplastic rhombencephalitis. The next case is also a very similar sort of patient who came within a few weeks of each other. Okay, this lady was seen because she was seen in the emergency department because she developed acute vertigo. But the acute vertigo was also associated with diplopia. Okay, now clinical examination was significant because again, she had skew deviation, which explains her diplopia. And she had a nystagmus, which was not quite gaze evoked, but not quite peripheral in nature. It was mostly a torsional nystagmus that was most obvious on looking to the right. Now, many of you are familiar that whenever a patient presents with acute vertigo, we use this acronym, acute vestibular syndrome. Why? Because there are two possible causes of an acute vestibular syndrome. Okay, you can have a very benign disorder like acute vestibular neuronitis, or you can have a sinister disorder like a brainstem stroke or cerebellar stroke that mimics vestibular syndrome. So it's important to sort this out because one is a life, limb, and license-threatening disorder, while the other one is a very benign disorder. So to sort that out, we have something called the hints. And if you apply the hints on her, her head impulse is negative. Okay, she has a nystagmus which doesn't really fit into a peripheral nystagmus, and she has skew deviation. So by the hints protocol, she has central disease. Okay, regardless of what the MRI shows. And correctly so, the emergency department therefore admitted her, even though the MRI was normal. And so we then started thinking, if the MRI is normal and the patient continues to have symptoms, okay, then what else could it be? So we were not quite sure. So we decided to just observe her in the ward. Okay. And over a period of time, over the next few days, she started developing more symptoms. Okay. She started developing downbeat nystagmus and cerebellar ataxia. This again told us, and again, the MRI was repeated and the MRI was still normal. So just like the second case, the absence of any finding on the MRI tells us that it cannot be a big structural lesion. It must be some sort of neuronal process, some kind of a channelopathy, some kind of neuronal process that most likely is inflammatory or disimmune in nature. So again, with this kind of a story, the managing team went on to do a spinal tap and showed that her cells were raised. So there is definite pathology in the brainstem. And then they did a system review. And again, just like the second case, they found cancer, this time cancer of the ovaries. And with that, they did a targeted antibody testing for paraneoplastic antibodies and found that she was anti-YO positive. Okay. But unlike the second patient, this patient has not done well. She's been escalated to various immune therapy, but she continues to progress unabated. So with that, I would like to summarize that so far I've shown you 3 cases of disimmune brainstem encephalitis. All 3 of them are quite rare. One is a brainstem manifestation of a systemic autoimmune disorder, Sjogren's syndrome. The other 2 were paraneoplastic antibodies, classically localizing to brainstem associated with cancer. And why did I mention, why did the dog did not bark in the dark? Why did the dog did not bark in the dark of the night? Well, you know, I promised Satya that I need to keep this interesting. So if you remember, if you watch episodes of Netflix or Amazon Prime or whatever TV series, you know that before the next episode, they always give you a trailer and leave you hanging so that you'll come back for the next episode. So if you really want to know why the dog did not bark in the dark of the night and why this is relevant and why there's a silver blaze story here, you must come for Satya's session tomorrow because Dr. Miller, I understand, is going to give a full explanation of this phenomenon. With that, thank you.
Thank you, Uma. It was an amazing talk. So I wanted to ask you, the first thought that we get as ophthalmologists when we see a patient with a brainstem-related ocular movement disorder is stroke. Acute onset, we think of stroke. So how would you differentiate all these three cases from stroke?
So I think the first two cases were fairly straightforward because the story was not acute, right? They were subacute to chronic. So there was no issue of stroke at all. But the last case was very tricky. So in fact, I was consulted by the team on this case because this patient had signs of central nervous system disorder, but the brain scan, and was very acute in nature, but the brain scan was normal. Okay, so there was evidence of a skew deviation, there was evidence of a central nystagmus, but brain stem was normal. Nothing at all. Okay, so not even on enhancing lesion, no flight changes, nothing. So again, the absence of finding also tells us that something is points to a certain pathology rather than a stroke. So rightly so, they decided not to discharge the patient, and in fact, very correctly, they observed the patient, and in 2 to 3 days' time, she decided to manifest herself with downbeat nystagmus and a progressive syndrome. Imagine if they had sent the patient home from emergency department and the patient deteriorates at home, we would have looked very silly for missing a serious disorder. So the absence of finding for a stroke for a patient that looks like a stroke was the reason why they decided to keep the patient, and things became clearer. And the CSF gave us solid proof that we are dealing with brainstem disorder. And then subsequently, they proved it by doing a good system review. So both times, the clinical evaluation was very accurate. You see, both the teams were very focused in the approach. You know, they didn't do a blunderbuss, investigate, throw the kitchen sink at the patient. Okay, they did a good clinical exam in both patients. Okay, and found, in fact, all three patients. First patient, system review revealed Zika. Second patient, clinical examination revealed breast cancer. Third patient, she had loss of weight, loss of appetite. So a very focused cancer examination revealed evidence of ovarian cancer. So I'm very proud of these colleagues of mine who did the right thing by not ordering too many investigations and accidentally stumbling upon the diagnosis.
Okay, I noticed in the videos that you sent me that there was a very long video for the patient where you were trying to check the ptosis, and you were looking at, you know, whether it's myasthenia or not. Of course, it's not a presentation here, but in any case.
So I think in the interest of time, I took it out because in fact, the lady with that slowing of saccades, there was a question about whether she had myasthenia because only thing she had was slowing of saccades. So I think Dr. Z had described it beautifully. He calls it glissades. So that means saccades that are slow because of the weakness, right? So that made us consider myasthenia. So we did ISPEC test, no improvement. And then there was some suggestion of ptosis, but it wasn't consistent. Okay. And then subsequently, the evaluation revealed carcinoma of the breast. So we abandoned the diagnosis of myasthenia.
Okay, so and the other thing is Miller-Fisher that we see in the casualty or the emergency once in a while. So any of these patients had features suggestive of Miller-Fisher to begin with?
Yeah, I'm glad you asked that, sir, because in the eastern part of the world where I work most of the time, actually Miller-Fisher is 1/3 of our Guillain-Barré syndrome patients. And so we have to be very careful about Miller-Fisher, and not just the Miller-Fisher, but the form fruits of Miller-Fisher. So that's the irony of it. It's a double form fruits, right? So Miller-Fisher is already a form fruits of Guillain-Barré. Then there is a form fruits of Miller-Fisher. So recently we had a patient with an isolated third and fourth with what looked like slightly reduced reflexes, that's all, you know. And my clever registrar did anti-GQ1B antibody, which is very specific, and confirmed the diagnosis of acute ophthalmoparesis version of it. So, but in these cases, the absence of anti-GQ1B antibody was useful, at least in the first case, but the other patients didn't have features of Miller-Fisher syndrome.
And the two elderly patients, the first thought we get is it a degenerative disease? Is it age-related? So what would be?
Again, time course. So that's why, you know, under the 6 categories, when we came to the vascular, I dismissed it because it was too subacute, and degenerative usually is a progressive. So in degenerative disorder, for example, in SCA2, which is a genetic degenerative disorder of the pons, in the old literature, sometimes they call it olivopontocerebellar degeneration. The PPRF is affected, and the patients have classically this slowing of saccades. But the story is many, many years of symptoms, not just 3 months. So that's why the time course was very helpful in this case.
So Ambika has an interesting question. How do you choose which paraneoplastic antibody, or do you run a panel?
Okay, so actually I'm from the old school. And the way I was trained was to describe the syndrome and think about the antibodies related to the syndrome, and then think about the tumor. For example, anti-Hu antibody is almost always associated with cancer of the lung in smokers. Okay, then testicular cancers are associated with certain types of tumors, certain types of antibodies. So it's good to think about the tumor and the type of antibodies. But my neuroimmunology friends tell me that this may not be rigorous enough in a high volume practice. If you see a lot of patients, this is not safe enough. So it's better to do a panel. So that's why nowadays most of these patients get a panel, because you can get a considerable overlap. So in this case, brainstem encephalitis, for example, can be anti-Hu, can be anti-YO, can be anti-Re. So if you just do one, you're going to get into a bit of a problem. But on the other hand, there will be instances when sometimes you get a non-specific antibody, like GD1A coming up in a patient with Bickerstaff encephalitis. We can dismiss it, right? So occasionally you will get an antibody like a low titer voltage-gated potassium channel in a patient with an unrelated condition, or get antibody in an unrelated condition. So these things we can dismiss. So to some extent, we do apply the general principle that think about the tumor, think about the syndrome, and know whether these antibodies have been associated with it. But we cannot use it 100% because there's quite a bit of overlap.
So Ambika says many times we don't know the primary. So do you do a PET CT scan and then do the panel?
Yeah, so yes and no. So in this particular case, for brainstem, we did the encephalitis, and then we went to look for the ovarian cancer. The second case, we found the breast cancer, and then we went to look for paraneoplastic antibody. So both ways is good, but I agree PET scan is good, but you must make sure that the PET scan does cover certain things that may not be routinely covered. Like in females, make sure the breast is properly covered and the head and neck is properly covered. In males, make sure the testis is covered, because these are important sites of cancer. So in case the PET scan misses these locations, then you can miss the diagnosis even with a PET scan.
Yeah. And Andrew Lee says that I tell our residents that normal MRI is bad with thromboencephalitis because we cannot see antibodies. And those antibodies could be autoimmune, infectious, paraneoplastic. Absolutely,
yeah. Yeah. So abnormal scan is as useful as or useful to the for diagnosis, but it could be as sinister as a normal. A normal scan can be as sinister as an abnormal scan.
Right. Any other questions?
I have a question, Dr. Umapati sir.
Yes, Dr.
Could you account drowsiness as one of the distinguishing feature of Bickerstaff encephalitis from other causes of thromboencephalitis?
Yes, ma'am. Yes, definitely. So almost all the Bickerstaff, it's not a common disease. All the cases that I've seen, they do have drowsiness. In fact, it's put into the diagnostic criteria. A patient who has what looks like Guillain-Barré syndrome peripherally, but is drowsy centrally, obviously centrally. So drowsy, then you consider Bickerstaff. So you shouldn't diagnose Bickerstaff in a person who is very alert. So in this case, that's why Bickerstaff wasn't very highly considered, and the absence of the specific antibody further ruled it out.
Can Wilson's disease be associated with Bickerstaff's like picture?
No, not that I know of, madam, because Wilson's, I think it's a chronic disease. So I not that I know of, yeah.
Thank you, sir.
Thank you. Thank you.
Thank you. I think we can move on to the next presenter. It's the next case presentation is blood is thicker. It is going to be by Dr. Stephen Hamann. He's a clinical research associate professor and consultant neuro-ophthalmologist at the University of Copenhagen, Denmark. His areas of interest include pathology of raised intracranial pressure, ischemic optic neuropathy, and optic disc drusen. He has 120 peer-reviewed scientific papers. In 2015, Dr. Hamann founded the International Optic Disc Drusen Studies Consortium, of which he is the chair. He is also chairman for Neuro-Ophthalmology of the European Reference Networks for Rare Diseases. Over to you, Dr. Stephen.
Yes, thank you. I'll just share my screen here. All right. Thank you very much for this kind invitation. Good morning, good afternoon, and good evening, everyone. Today, I'm going to move a little bit out of my usual comfort zone, as the case I'm presenting is not exactly in my area of expertise. So I'm an ophthalmologist by training, not a neurologist. However, I find this case very fascinating, which is why I wanted to take the opportunity to share it with this crowd of excellent doctors, including neurologists. So this is a case of a 70-year-old woman referred from neurology because of unexplained visual disturbances. She's generally in good health, apart from polycythemia, treated periodically with phlebotomies until November 2022. She's also known with acephalgic migraine, so she has episodes of visual migraine auras, but with no headache. She's had that for many years as well. And she approximately has one visual aura per month, not more than that. All right. So since January 2023, she notices an increasing frequency of the visual auras, from being usually once a month to now up to 8 auras per day in May 2023. So a huge increase in frequency. She also complains of additional near vision problems in between the auras. She goes to see a private eye doctor, and the private eye doctor describes that everything looks fine except for her optic nerves. These look worrisome. So the patient is referred to neurology. She's seen in neurology in May, and the blood pressure is elevated and an antihypertensive is given. This results in a slight reduction in aura frequency to about 5 auras a day, but still a lot. She's referred from neurology to neuro-ophthalmology because of the vision problems. One day in June, just before the neuro evaluation, she experiences an episode of 5 hours of horizontal double vision. She is admitted to the hospital, and an urgent neuroimaging procedure is performed. She is seen in neuro-ophthalmology, and the visual acuity is normal. Here is her orthoperimetry. There's some slight to moderate defects on both eyes, quite diffuse actually. Pupils, motility, color vision, IOP and slit lamp, all normal. This is her ophthalmoscopy. I apologize, it's with a non-dilated camera, non-mydriatic camera. But you can see that they look pretty much normal, these discs. Perhaps there is some slight segmental pallor. And this segmental pallor, it actually also corresponds to segmental peripapillary NFL thinning seen on both sides. So this is where we stand right now with the bilateral segmental optic atrophy, which probably corresponds to some previous optic neuropathy, probably of ischemic kind.
Yeah, thank you. Thank you, Dr. Stephen. So to summarize, here we have a 70-year-old female, a migrainer, a known patient of polycythemia who supposedly stopped the treatment and had an increase in her aura and has one episode of horizontal double vision and discs which look suspicious. So where do we go from here? Let me have a couple of comments from the panel before we go back to Stephen and have further on the case. And
opening pressure, take up a opening pressure, CSF.
All right.
So what were you thinking of since you suggested opening pressure?
I didn't get you. Could you repeat?
So what would be the thought behind taking an opening pressure?
Because it was are we seeing a case of cerebral venous thrombosis with papilledema, which has gone for an ischemic optic neuropathy?
Yeah, okay. It was not performed.
Any other comment? Ambika says on the similar lines, whether can we do MRV brain? So a polycythemia patient with polycythemia and increase in aura. These are the two operating words, and a known migrainer.
Yeah.
maybe Stephen, we can go ahead and.
Okay, we'll just move on because we had the MRI of the brain at the same time. It showed no current ischemia. There was some arterial time of flight with signal loss in the left V3 and perhaps some stenosis or occlusion. She also has a CT angiography of the brain and same day with some significant physiologic changes with stenosis of the right M1 segment and thoracic at several departures. There's also contrast filling of the left V3, V4 segment, although reduced compared to the opposite one. And we discussed it with the neuroradiologists. They say that perhaps there's a proximal stenosis or variance. So with this scan results, the patient is placed in treatment. Any idea for treatments from the panel or the audience? Well, okay, so she's placed on antithrombotic treatments, clopidogrel 75 milligrams a day, and this results in the magic appearing. So her visual auras, they disappear completely. I mean, from 5 to 8 auras a day to 0 auras a day after starting clopidogrel. So in summary, we have a 70-year-old woman with polycythemia and acephalgic migraine with visual auras. The frequency of the auras significantly increased from once a month to 8 per day after stopping the phlebotomies for the polycythemia. And the auras stopped completely after initiating antithrombotic therapy. So what goes on here? So let's go back to the polycythemia. It's a laboratory finding in which the hematocrit and or the hemoglobin concentration are increased in the blood. Both of them were increased in our patient. It can be absolute or it can be relative. The absolute polycythemia can be either primary, which is the polycythemia vera, or it can be secondary. And most of the health concerns that are associated with the absolute polycythemia are caused by the blood being thicker as a result of the increased red blood cells. Symptoms in polycythemia are usually a ruddy complexion or plethora, headache, transient blurry vision, and other signs of TIA or stroke. You can have dizziness, fatigue, unusual bleeding, nosebleeds, abdominal pain, and pain in hands and feet, itchiness, numbness, or tingling. It's a rather rare condition with approximately 50 polycythemia vera patients per 100,000 in the US. The secondary polycythemia prevalence is unknown. Management, of course, varies based on its etiology, but it includes phlebotomy, which reduces the hematocrit and increases the cerebral blood flow. It's unclear whether the patients with secondary polycythemia are at an elevated thrombotic risk. So how about the migraine with visual aura? Let's just look at a few facts. So the cortical spreading depression with progressive glial cell depolarization is considered to be the underlying cause. We know that migraine auras can be triggered by cortical damage, and then microemboli can trigger cortical spreading depression. We also know that stroke or subdural hemorrhage can trigger cortical spreading depression, and that a cortical spreading depression can lead to migraneous infarction. It is known from the clinic that when migraineurs are in their 60s and 70s or 80s, they can suddenly start to develop visual auras that they haven't had before. And this is considered to be potentially due to microemboli, and some neurologists advocate treating with aspirin. So let's go back to our patients. 3 months later, she has only had 1 episode of visual aura, and she had had no other visual complaints. This episode prompted the hematologist to take up again doing the phlebotomies, and they decided to do the phlebotomies only if the hematocrit exceeds 50. So let's put the pieces together of this case. We have a 70-year-old woman with polycythemia and migraine with aura. Stopping treatment of her polycythemia resulted in a significant increase in aura frequency and an episode of transient diplopia believed to be a brainstem TIA. Anti-thrombotic treatment caused immediate disappearance of all visual auras. We think it's plausible to say, given the temporal relation of events, that local occipital ischemia in the visual cortex, exacerbated by the untreated polycythemia, causing increased blood viscosity and decreased cerebral blood flow, was triggering the auras of our patient, analogous to small TCI episodes. Further, we postulate that polycythemia constitutes a real risk of stroke, causing hypercoagulability, which in turn affects the thrombocyte function, and that this was the cause of the glaring effect of the antithrombotic treatment in our case. The case supports a vascular neural hypothesis for cortical spraying depression, underlying migraine aura, and aspirin may be considered in otherwise healthy patients with frequent debilitating visual auras to prevent frequent recurrence, and regular antithrombotic medication should be considered when you have the rare combination of patients with combined polycythemia and migraine auras. And then I'll have two questions that I'd like to address to the audience. The first one, whether it should be prescribed to all patients, but including those with no vascular disorders, and if we should test for underlying vascular disorders in all migraineurs. So I'd like to hear the audience about this. Thank you very much.
Any comments from the other panelists? As Stephen mentioned, it's slightly out of the comfort zone of many ophthalmologists, but what do you think?
Usually we don't tend to see cases of migraine. The minute we see the migraine, it goes within the neurological domain. But a point to ponder that we also take up the blood investigations and work it up. That is what I could take the message from Dr. Stephen's presentation.
Yes, she had a full blood workup. She didn't have an infectious workup. There was no signs of, well, of course, she had normal infectious parameters taken, but not a full infectious workup. But she had her blood counts as regular through the hematologists that follow her on a regular basis also.
Can I raise a point?
Yeah.
So once the blood workup, as Dr. Padmavati said, would be the initial step to go forward. But unless the patient has any blood dyscrasias, as a regular treatment of migraine, the anticoagulants are not actually recommended, more like calcium channel blockers. So I think once we've done the blood workup, then the decision to whether start an anticoagulant or not should be taken based on that. And also maybe a hematologist opinion should be sought.
Yeah, I agree.
Andy mentions the point that we do CBC on all transient vision loss or change in character, frequency, or quality of migraine.
Can we have a comment from Uma? Okay.
All right.
Okay.
All right.
I think we are running out of time.
No problem.
No
Thank
problem.
you.
Fine. Any other points, Dr. Satya?
Now we can proceed to the next.
Yeah. We have the last presentation in this session. The case is a case of interesting. I'm sorry. The next speaker is going to be Dr. Reid Bahani. Excuse me if I have pronounced it wrong. He's a consultant ophthalmologist, neuro-ophthalmologist. He also does oculoplastic and orbital surgery. He is associated with the Insina Hospital, Kuwait City, Kuwait. He is also associated with the Al Bahar Eye Center. He is a clinical tutor at the Kuwait University. He has more than 30 publications to his credit. His interests include optic neuropathies and multiple sclerosis. Over to you for the unfinished poem.
Thank you so much, and thank you for inviting me to your wonderful meeting. So this is probably similar to the last case. I'm going out of, definitely going outside of my comfort zone. And I'm just presenting this case because I just found it interesting. And so this is a 43-year-old patient who was referred from internal medicine with 3-day history of headache and blurred vision and intermittent diplopia. Now, his past medical history actually showed that he has been complaining of weight loss and fatigue and difficulty walking over the last few months, which he himself admittedly neglected because he doesn't like to go to hospitals and see doctors. And he also had history of recurrent axillary region and groin pigmented lesion on his skin for the last 4 years. He also had history of suppurative hidradenitis for the last 15 years, for which he did not seek treatment. The rest of his surgical history and family history is non-contributory. His visual exam showed his vision was normal. He had normal color vision. Pupils were reactive with no afferent defect. However, he did have about 4 prism diopter of esotropia in both lateral gazes, but he was orthophoric in primary gaze position. His slit lamp exam was normal and his pressure was normal. And this is his fundus picture. So I'm just going to pause here, probably get maybe the input of the panel of what they think is going on.
Thank you, Reed. So here it looks like a patient with bilateral disc edema, what looks like raised intracranial pressure with contributing feature, but the patient profile, he's a 43-year-old male and complaining of weight loss. So what would panel do? I mean, surely atypical patient profile for somebody to have raised ICP. So what next? Any thoughts or comments from the panel, or we move on?
Is there a possibility of a malignancy?
Yeah, I mean, that's definitely in the differential. He's a 43-year-old male, and he's probably not, he wasn't that obese, so he definitely does not fit the typical profile of pseudotumor cerebri or IIH. So plus he had all these other constitutional symptoms and other symptoms in his history, which makes this presentation a bit atypical for, let's just say, an IIH case. So, sorry. So I was curious and I asked him about the pigmented lesion on his skin, and he showed me these lesions, and they were all over his arms and groins, and also on his legs. So this is his visual field, which just shows enlarged blind spots in both sides. And the OCT, spectral domain OCT, shows thickening of the nerve fiber layer on both sides, over 300. And this is the OCT just showing the deformation of the Brooks membrane and the papilledema. He also had a macular OCT, which was normal. So the differential diagnosis of papilledema and a pseudotumor cerebri syndrome is quite broad. I think we all agree that this is probably not a typical IIH, and it's probably a secondary phenomena. So things like venous sinus thrombosis, medication, medical disorders. I think the point of malignancy was raised, and in that context, probably hematological abnormalities and malignancies, and there's quite a broad differential for that. So all these things should be considered in the differential diagnosis. Now, he did have neuroimaging, which was normal, apart from some probably questionable brachiomeningeal thickening an enhancement in the frontotemporal region, which was deemed later to be non-significant. And CTV showed that he did not have venous sinus thrombosis. Now, he did have a lumbar puncture eventually, and of course, the opening pressure was not measured. And as you expect, sometimes in internal medicine, the opening pressure is not taken, but he did have high protein in his CSF analysis. So this is another red flag, if you like, just to confirm that this is not a typical pseudotumor cerebri-like presentation. Interestingly, also he had a positive oligoclonal band on his CSF analysis. Now, he did have quite an extensive lab investigation, showed he was severely anemic, and he had high platelets, he had high ESR and CRP, and he had low iron as well, and his albumin, total albumin, was quite low. The rest of his laboratory workup here was normal. And he did have rheumatology has seen him, and he thought he might have some kind of vasculitis, and he did have a workup for vasculitides, some entities, and these were all negative. However, serum immunoglobulin showed that he had quite high IgG. He also had slightly elevated IgA, and he had later immunofixation electrophoresis, which showed there was no evidence of paraproteinemia, and it was recommended to be repeated after 1 month. Tumor markers, he had some tumor markers because they thought they might have colon cancer or lung cancer or another type of cancer. These were all negative. And he also had an endoscopy and colonoscopy to see if there was any source of bleeding, which might account for his severe anemia, and that was normal. And he had a serum protein electrophoresis, which showed that he had total, quite elevated total protein. And he had alpha-1, alpha-2, which are probably non-specific and indicate inflammatory disorders or severe anemia. But he also had high gamma globulins, which is usually associated with monoclonal gammopathy. So he subsequently had a whole body PET CT scan, and this showed multiple lesions in the lymph node and his an uptake in the liver and the spleen, and there's also diffuse bone marrow activity throughout the axial and appendicular skeleton, which was suggestive of something hematological going on, most likely a malignancy, lymphoma, or leukemia. Or it was thought also that this could be just bone marrow activation due to severe anemia. And he was, it was recommended that he undergoes bone marrow biopsy. However, what he did have was a lymph node biopsy, which was negative for the markers for lymphoma. And the comment on the pathology report was that he had follicular hyperplasia and sinus histocytosis. So the patient was basically treated with Diamox only and was given ferritin injection. Now, his hemoglobin did increase to about 10, and he was feeling generally better, less sick, and his vision was normal. I had seen him maybe 3 weeks later, and I'm sorry, this is an Optus camera, but it does show that his papilledema is probably less than it was at the time of presentation. So his papilledema was improving. And I've seen him also 2 months later, and he was still feeling better. He was still anemic. His albumin was still low. And I did request that he try to get a serum VEGF done, but that was not available to the hospital. And his bone marrow biopsy was not done, it was deferred. So all in all, I think this was probably a case of monoclonal gammopathy with papilledema. And This falls in the entity of plasma cell dyscrasia. So what you have with plasma cell dyscrasia is proliferation of plasma cells, which secretes immunoglobulin, which is the M protein. And the M protein is usually composed of a heavy and light chain. So the heavy chains are either the alpha, the mu, the gamma, and the delta, the epsilon, and the light chain either kappa or lambda. So what happens with plasma cell dyscrasia is that you have infiltration and the body tissues of the M protein, but also you can get a paraneoplastic effect due to the cytokine effect and the hyperviscosity resulting from the malignancy. And these are the most common types of plasma cell dyscrasia. In this case, I think probably the two leading diagnoses would be POEMS, which is polyradicular neuropathy, organomegaly, endocrinopathy, monoclonal plasma cell disorder, and skin changes. The other differential is monoclonal gammopathy of undetermined significance. And of course, you can have multiple myeloma, plasmacytoma, and the other type of plasma cell dyscrasia. And for those of you who are probably want to read more about that, this is a really nice review that was published this year in the European Journal of Ophthalmology. They should go and look it out to learn about the ocular manifestation of plasma cell dyscrasias. Now, for this patient, personally, I think he had POEMS. And as you can see here, these are the diagnostic criteria for POEMS. He did have many of those features. Now, he did not have the polyneuropathy, which is one of the major criteria for diagnosis. However, he did have the plasma cell proliferation, and he had the elevated immunoglobulins. He did have bone lesions, and he did have skin changes, the hyperpigmented skin changes, which are characteristic of this disorder. And he also had papilledema and thrombocytosis. So he does have many of the clinical features and the diagnostic criteria for POEMS. And this is an article, this is a series from Mayo Clinic that was published probably 10 years ago. And almost 30 of those patients with POEMS have papilledema at presentation. And the cause of the papilledema is really multifactorial. Although high intracranial pressure is implicated, some of the other mechanisms of papilledema could be elevated CSF protein, vasculitis, infiltration of the nerve directly by the M protein, or the cytokine effect, which is increased VEGF levels and other cytokines such as tumor necrosis factor, interleukin-1, and interleukin-6, which lead to increased vascular permeability and breakdown of the blood-brain barrier and swelling of the optic nerve. Now, interestingly, also on those series, this series, 3 patients had horizontal diplopia, abducens nerve palsy from high intracranial pressure, which shows you that the mechanism of papilledema can be due to high intracranial pressure, as in this patient also had bilateral 6 nerve palsy at presentation. Now, POEMS tend to be more common in the Orient, in Japan particularly, and this is a large series that was published about 3 years ago. What they did is that they did a nationwide survey of all POEMS patients. And as you can see here, even in this series, not all patients had the whole criteria. Almost 11% did not have plasma cell proliferation, and not all patients had elevated VEGF levels. About 24% had papilledema, and 84% had skin changes. So this patient probably presumed POEMS, atypical POEM or unfinished POEM, if you like. And one of the, you could explain that he probably presented late and his disease was already in remission, therefore he did not manifest the M protein as you would expect, and the immunofixation electrophoresis. Some of the plasma cells may not secrete antibodies. In fact, it's not really unusual for even bone marrow biopsies to be normal in this disorder and not to show the clonal plasma cell proliferation. And additionally, the M protein sometimes is too small to be detected even by available assays, even immunofixation electrophoresis. Therefore, you have to make the diagnosis by the characteristic signs and the clinical presentation. Now, elevated VEGF levels can be helpful. Unfortunately, it was not available at this facility. So this is something that will help you to confirm the diagnosis. Now, as far as the treatment of POEMS for localized disease, radiation. However, in this patient or in disseminated disease, usually need to use systemic chemotherapy along with steroid and autologous stem cell transplantation. Sorry for the typo there. So in summary, this is a case of bilateral disc edema, bilateral papilledema in POEMS. You really need to suspect this in someone who has papilledema with other features and multi-organ involvement with hematological abnormalities. The pathophysiology of papilledema is multifactorial in POEMS, and the diagnosis is often delayed because some of these patients can develop endocrine changes and such as diabetes, and then they could be diagnosed as diabetic peripheral neuropathy, CIDP, and even IIH. And the pathological diagnosis of POEMS can be difficult sometimes, and sometimes you have to make the diagnosis just based on the clinical findings. So this is the end of my presentation.
Thank you. Thank you so much, Dr. Reed. That was a fascinating case. And I think Dr. Umar had given quite a few of comments. I don't know whether he's online. We can give comment on camera. He mentioned about the Castleman's histology being consistent. Yeah. Yes, Dr. Umar.
Yeah, so,
yeah, thank you. Yeah. So I think, basically I was just trying to say that, it would be useful to look for other features of the condition. And sometimes the lymph nodes may be wrongly labeled as reactive, but actually it may satisfy criteria for Castleman's. And that's why it may not be like because Castleman's it's a slightly different disorder from the classic myeloma-like illness that is seen in other forms of POEMS. So it may be a bit more difficult to diagnose, and that's when the lymph nodes are useful. And often in these cases where the index suspicion is high, we often do a skeletal survey, including a CT skeletal survey, to look for lytic lesions to find pathology going on. And like you mentioned, VEGF levels are useful. And but because it's a syndrome, if you look at that paper by Dr. Dispensary, she has written out all the major and minor criteria. So like you said, incomplete POEM, because there are many forms of this POEM syndrome. But we do see in Asian patients, Chinese and Japanese patients, the prominent swelling of the disc without any signs of either raised pressures. Even when you do a spinal tap for these patients, the pressures are normal, and it's not optic neuritis, obviously, because they have no visual symptoms. And if you do a contrasted scan, often this is also associated with diffuse pachymeningeal enhancement. So this is, I think, part of that edema, the swelling aspect of POEM syndrome. As you know, the O stands for edema. So I think the optic disc is swollen as part of the diffuse vasoendothelial dysfunction that is causing exudation of fluids. So this is, for some reason, it seems to be more common in Asian patients. There's this swelling, less reported in the Western literature. Over. Thank you.
Thank you, Umar. And I'm not even going to attempt what Andy has written, a tongue twister of POEMS. So,
I would request Andy to explain what he has written. We can't understand it on a message.
Yeah, so I think the most important thing is the POEMS people almost never have the full poems. They're like PO or POM or EMS or PMS. So even though it's POEMS, it can be any combination of those letters. And so that's really the important thing, is otherwise you'll get that POEMS thing in your head and you'll think you have to have all. It's like it's poetry with incomplete letters. So it's an alphabet soup of diagnostic criteria, and you don't have to have all the poems to have POEMS.
Okay. Thank you.
Yeah, and this is true. And I think this patient probably was probably not worked up fully. I'm not sure if a bone marrow biopsy would probably he did not have it. He didn't have it done, so that would be something to do probably. And he's still not treated as POEM. He's just being treated with supportive therapy for his anemia, and he does not have yet a conclusive diagnosis. So it's still not. I think he probably needs more workup and more thorough, more investigations to confirm the diagnosis. So.
Any other comments or suggestions?
When would I have a question? Would you suggest an electrophoretic assay? Because based on the immunoglobulins, does an electrophoresis has any role?
Yeah, I mean, this patient had serum electrophoresis, which showed high elevated gamma globulin, and he did have immunofixation, which is should be more sensitive than serum electrophoresis, but this did not show the M protein. So maybe it will be repeated. And for the other reasons that we mentioned, it could be just below the detection level of sensitivity for the, so we just gonna have to repeat the test probably. And sometimes you really don't find the M protein, and you just have to make the diagnosis based on your clinical, both on the clinical presentation.
Thank you. Dr. Satya, any comments?
You're muted.
No comments.
I think we come to the end of the first session. We'll just move on to I hand over the podium to the next moderator, Dr. Shikha, who will be moderating the next session.
So let me introduce to you Dr. Shikha Rajesh Basi, who is the Deputy Director, Neuro-Ophthalmology Services at Shankar Nethralaya, Chennai, India. She is a member of the Optic Disc Drusen Consortium. Her interests are in OCT and neuro-ophthalmology, optic neuritis, and optic nerve head drusen. She is a recipient of the SD Athavale Award at the APAO AIOS 2013 for her paper on OCT and papilledema and pseudopapilledema with and without drusen. He has been the organizing secretary for many national and international conferences in cataract and neuro-ophthalmology and has given numerous talks in national and international meetings. He's a reviewer of several journals like I, BMC Neurology, PLOS One, International Ophthalmology, and IJO. Over to you, Shikha.
Thank you, Satya. So welcome everybody to the second session. Let me share the screen. I'm not able to share the screen, Satya. You've stopped sharing? You've stopped sharing your screen?
I stopped, yes.
No, I'm not able to share the screen.
Sunil, can you help?
Doctor, I think your screen is stuck. Can you just stop share and reshare?
Okay. I'll cancel because actually when he was presenting, I did try to share. I'll try once more. No, I'm not able to share this.
Okay, shall I open the PowerPoint here?
Yeah, you can.
I'll do that. Just a second.
Yeah, no, just a minute. Are you sharing, Satya, or am I sharing the screen right now?
You are sharing with Dr. Basi.
Okay.
So I'm sharing the screen, no?
Okay,
yeah.
You need to open your presentation, Doctor.
Yeah. So you can see the slides, my slides?
No, actually you need to share the PowerPoint slide.
Yeah, I'm sharing the PowerPoint slides.
Doctor, just open the presentation, then now share. First open your presentation and then share.
Okay, now I'll share again. Sorry about this. now? Am I
Yes.
sharing? Yeah.
That's right.
Yeah, I'm sorry about this. Welcome to the second session. And before I begin the case presentations, let me introduce you to the panelists. We have Dr. Revati Ramesh, who is a senior consultant with Dr. Tony Fernandez Eye Hospital at Kochi. She's had her education at Chennai at Stanley Medical College, and thereafter she moved to Kerala and she set up the Neuro-Ophthalmology department at Dr. Tony Fernandez Eye Hospital. It's a pleasure and an honor to have you with us, Dr. Revati. Welcome to the NOSIC 3. We also have Dr. Ramesh Kekonia, who is the Network Director, Capacity Building, External Organizations at the prestigious LBPI Institute. And he's also holding a lot of important other posts like Director of Child Sight Institute. He's the Director of Center for Technology Innovation. He's the head of Jasti V. Ramanamma Children's Eye Care Center at LBPI. And he's the Executive Bureau Director of the World Society of Pediatric Ophthalmology and Strabismus. He's the Founder Executive Bureau Member of Pediatric Ophthalmology and Strabismus Network of India. He's had his Pediatric Ophthalmology and Strabismus Fellowship at Jules Stein Eye Institute, California. And he's received a lot of achievement awards from the American Academy of Ophthalmology. Dr. Kekonia has published 150 articles in peer-reviewed journals, and he's contributed to 25 textbooks. It's an honor and a pleasure to have you in the second session. Welcome to the session. Next, we have Dr. Nikhil Chaudhary, and Dr. Chaudhary is presently a senior consultant with Center for Sight Eye Hospital at Hyderabad, but he's been a glaucoma and neuro-ophthalmology consultant at Shankar Nethralaya, Chennai, as well as LV Prasad Eye Institute at Hyderabad. And he has been a co-investigator of a couple of large population-based glaucoma studies, and he's made several international and national presentations and published in peer-reviewed journals, and he's a co-author of Shankar Nethralaya's Atlas of Neuro-Ophthalmology. And while he was working in the rural network of LVPI, he has developed a model of glaucoma care for the underdeveloped regions. Welcome, Nikhil. Now, with that, we'll move on to the case presentations and to present the first case. It's such a pleasure to introduce and invite Dr. Simao. Dr. Luciano Simao is the Associate Professor of Ophthalmology, and he's also the Head of Neuro-Ophthalmology Service, and he's Faculty Clinical Medicine at Minas Gerais at Brazil, and he has completed fellowship training in neuro-ophthalmology at Federal University of Minas Gerais, and he's done his observer fellowship at Wills Eye Hospital in Philadelphia, United States. Subsequently, he received a doctorate of medicine from the University of Minas Gerais, and he has published some papers in peer-reviewed articles, and he's co-authored some books on ophthalmology for residents. He has given numerous lectures in the national meetings, and he's a specialty reviewer to ABO and to RBO. So over to you, Dr. Simao, to present your interesting case. So I'll stop sharing.
Hello. I would like to start to thank the scientific committee for being here for the third time at the global meeting. And my objectives here are to describe an atypical case of visual loss and also to correlate underlying medical condition to ocular disease. And here we have a case of 58-year-old woman with a history of incidental perception of visual loss in the left eye,
while she closes her right eye during makeup in October 22. Past medical history is relevant for hypertension, and the diagnosis of esthesioneuroblastoma of nasal cavity in February 21. Surgery was done in March and also in November 21 for the recurrence of the lesion, followed by a radiotherapy between December 21 and January 22. She had no chemotherapy, and she also underwent normal checkups, otorhinolaryngology and ophthalmic, and except for the finding of anosmia. Past ocular history none, medications for hypertension or allergies none, and family history not contributory. She uses occasional alcohol and no smoking nor recreational drugs. Her first neuro-ophthalmic evaluation was done after 2 months of perception of visual loss in OS. Her visual acuity was normal on the left and counting fingers at 3 feet on the left. Color vision was full on the right and new in the left. Pupils were equal in size, reactive, and revealed the left RAPD. Motility, slit exam, and IOP were normal, but the fundus revealed the temporal pallor of the left optic nerve. According to her OCT findings, you can see the decrease of peripapillary retinal nerve fiber layer on the left, especially on the temporal margin of the disc, and normal findings on the right. Her Goldman visual fields revealed the normal finding on the right and a deep depression of the perception of inferior visual field on the left. And her MRI image revealed a gadolinium enhancement of the prechiasmatic left optic nerve and normal findings on the right. And we will have an evaluation for optic neuropathy at this point, ancillary tests of a neuroimaging revealing a left optic nerve abnormalities with no signs of recurrence of malignant lesion, and blood tests and CSF were all remarkable. After discussion with neurology, we decided to underwent IV steroids for 5 days, but with no improvement of vision on the left. At this point, we have the differential diagnosis. It might be metastasis, a subclinic stage, paraneoplastic optic neuropathy, radiation-induced optic neuropathy, RIA, atypical optic neuritis, and other that I was not aware of. However, in February 23, when she was relaxed on Brazilian carnival holiday on the balcony, reading a book, she noticed that the right eye was not seeing well. So she underwent another neuro-ophthalmic examination in February 23. Her visual acuity was 20/25, slow and eccentric, and on the left was stable. Color vision was 13 out of 15 slow on the right and new on the left. The pupils were equal in size, reactive, and showed the left RPD. Other examinations were normal, but the fundus revealed on the right normal optic disc, and on the left we could see a pallor of the whole optic disc. You see here in her OCT findings that on the right, she had a decrease of retinal nerve fiber layer, especially on the temporal border of the disc, and a deep depression of the retinal nerve fiber layer measurements on the left. Interestingly, her Goldman visual fields showed the same pattern of loss of the superior field bilaterally, with a deep depression of the inferior visual field on the left. And her new MRI imaging revealed now prechiasmatic enhancement of the right optic nerve and the atrophy of the left. And after revision, clinical history and ancillary tests were not showing a specific cause for the case, radiation-induced optic neuropathy was our final clinical impression as an incidental finding on MRI of the discrete enhancement of prechiasmatic optic nerve with T2 hyperintensivity. And it's worth mentioning that she underwent 30 sessions of radiotherapy with a total dose of 54 grays on the border of the lesion and also 60 grays at the site of the lesion. And her first visual loss was perceived after 9 months of the radiotherapy that was done close to her optic apparatus. We decided to do another cycle of IV steroids plus oral taper, and she underwent 40 sessions of hyperbaric oxygen therapy, HBO therapy, pentoxifylline, and also vitamin E. And her visual functions after 10 sections of HBOT was stable. However, after 25 sessions of HBOT, she noticed visual decline on the right, and that was the reason that we keep with the HBO therapy. And after 40 sessions, she got a better visual function on the right. Here we have progress decrease of retinal nerve fiber layer during follow-up bilaterally. And here I have a question. Should patients with Ryan receive any treatment? Because there are no randomized masked controlled clinical trials or class 1 evidence that show that the use of all these agents have been published with scattered success. And also HBO therapy seems to be a reasonable therapeutic option, as the etiology of Ryan is based on vascular and ischemic issue. Here we have a suggestion of the paper, of a protocol to follow, and the pros, as there are no major side effects associated to HBO, have here ocular and systemic, like seizures and sudden death that occurs at a very low rate of frequency. And it's expected that HBO has more improved in more cases of posterior Ryan. And the cons you have here, there is no class 1 study that shows HBO is beneficial. And also there is no effect in an anterior form of Ryan that may show a better prognosis, and there's no need to treatment, and the high cost per session for the treatment of at least 30 sessions. Here we have OCT findings of the patient in March 23, that she started with the decline of vision on the right, and it may help us explain the hypothesis for Ryan that it is associated to vascular injury with the decrease of vascular density on the left. And here I have a very elegant and new released paper that calls our attention to the new oncology immunotherapies that are promoting longer survival rates, and also the more common possibility to find the diverse effects from radiotherapy. And Ryan is considered a feared complication, as it is a rapid onset and severe and bilateral visual loss clinical presentation. And so it's essential to monitor high-risk patients with early recognition to initiate treatment, prevent severe loss of vision to a narrow therapeutic window. This therapeutic window is based on the use of those agents, steroids, HIV therapy, and the others. And additionally, we have now several randomized clinical trials that may show safety and efficacy of bevacizumab in CNS radiation toxicity. But the authors concluded that no consistent beneficial treatments for Ryan are none. Here we have a clinical presentation of Ryan with a rapid onset, bilateral and severe visual loss. Monitor high risks factors with early diagnosis may preclude reversible or severe final visual loss, or at least stabilization of the vision. And no proven treatments are none, and maybe HBO therapy in early phases may be beneficial, and also VEGF as bevacizumab may show promising results. Thanks for listening. I'm here for the Q&A questions.
Thank you, Luciano. I take this opportunity to put it on record that I find your presentations and your clinical acumen excellent. I have interacted with you many times, in at various platforms, but really like your presentations and even your clinical acumen. So with that, I think I'll invite Dr. Revati Ramesh to discuss, the case with you. And we'll have a final word about each case from Andy. Since Dr. Lee is with us, I think we got to utilize his presence after every case, at least in my session. So yeah, Dr. Revati, could you just go ahead with the questions?
Oh, we're not seeing.
You're not audible. I think you're muted.
Yeah.
Yeah. Dr. Luciano, the treatment you had mentioned was steroids and HBO. Did you start them simultaneously or sequentially?
Yeah, we decided to start it simultaneously, and luckily we got the patient done this in the first week of the perception of vision loss, and that was a concern that I associate to at least the first part of the HBO therapy being successful.
Did your patient have any adverse event due to this hyperbaric oxygen?
Oh,
any
actually,
adverse reaction?
Yeah, she had temporary hearing loss and no other adverse effects from the therapy, and that was advised by the HBO team, and she was quite good after it.
Yeah, I think in your patient, metastasis from the earlier esthesioneuroblastoma was also a concern, wasn't it?
Oh, definitely, yeah. Yeah, as we have imaging that didn't show any recurrence of lesion, and we feel more comfortable to indicate the HBO therapy, and that's a concern because as we were talking before, MRI imaging may be normal or be related or being considered as normal, and we have to recheck all the images so that to be very confident that the report is all right,
So having decided on the treatment for this, what is the time frame that you would advise for the treatment? If you're going ahead with HBO?
For HBO, as far as I know, the sooner is the better, So as she had the posterior Ryan, and it's it is expected to have more results with the HBO, so we decided the 4 sessions. Actually, we also thought about bevacizumab, but the intravenous, but as far as I know, we don't have such experience here in my town with Ryan, and that's why we postponed the bevacizumab for another time, if need be. I hope not.
At this point, I think Dr. Himalini Samant has posted a question that why does Rion take so much of time to, develop?
Yeah, oh, that's a great question. And so we have a lot of hypotheses, and maybe the glial cells that have a role in axonal conduction has a slow turnover, and that's why the start of the radiotherapy and the start in between and the time that we start radiotherapy and the symptoms may take a long delay because of that situation about the slow turnover of these cells. But we also see 3 stages of radio of Ryan. One can be acute, and so we expect a delay for getting the diagnosis, but actually we have these 3 stages. The acute one is during the treatment and until 3 weeks after completion. We have another early stage that can be between 3 weeks and 6 months, and the late one will be more than 6 months. So we can deal with Ryan at any part of the treatment, but sure, it's more expected to see it in the late stage.
Great. And we have a couple of other questions also. Himalini is asking, is it always bilateral? And Ambika is asking, how many sessions of hyperbaric oxygen is ideal?
Yes, it's usually bilateral, but as you see, the first eye was involved, and she noticed when she was doing her makeup, and it was an incidental finding, but at that time, 7 months has gone between the end of the radiotherapy and the symptoms. And another fact that she underwent ophthalmologic consultation in July. So the ophthalmologist saw her and didn't see any problems. So the case may be related to the late stage of Ryan, and the posterior one, it's very challenging because we don't, as we saw, we don't have much proven treatment for that.
And how many you've? I think we've done
how many
all...
sessions? Yeah, she had 30 sessions. That was done in 2 months, and actually don't have a safe dose for Ryan for radiotherapy to cause Ryan, but it's expected at least less 55 grays.
I think she's asking about the therapy, hyperbaric oxygen.
Yeah, because the suggested protocol is at least 30 sessions of 90 minutes each. So after she noticed that her vision was declining after 25 sessions, I have a difficult situation, or I go to bevacizumab or continue with the sessions of HBO therapy. And then I decided to continue the HBO therapy. And luckily, she was quite good, was better than the stage before, but she didn't regain her perfect vision on the right, and the left stayed stable. And I have a question for the audience, a food for thought. Does anybody here have this answer? Is it the final of the movie?
I think we'll have Dr. Andrew Lee's comments.
Yeah.
Final.
So in our work with MD Anderson Cancer Center, our first line is steroids and then bevacizumab. We just have a hard time getting the hyperbaric oxygen logistically set up in advance and getting it on time. But I think that there's something probably different between radiation brain necrosis, where the data suggests that bevacizumab is better than Ryan. And maybe that's because bevacizumab also is causing vascular pruning in its anti-VEGF mechanism. And so for optic neuropathy, it may be more ischemic optic neuropathy and less the typical radiation necrosis that we see histopathology on radiation brain necrosis. So it's really hit or miss, and there's no good treatment, so we give all the treatments.
Yeah. And when you treat, the patients usually go well and keep stable.
No, normally it's bad. So
yeah.
And
Yeah,
when sometimes I think I'm just treating myself more than the patient. Yeah, bevacizumab for the doctor's psychiatric well-being.
Yeah, actually, I saw her the last time on in July. So let's see how we're gonna end. By the end of the next month, I will see her, and luckily she'll be stable, at least stable.
I always tell the patients to hope for the best, but prepare for the worst. And if there's any improvement or stabilization, we take full credit for whatever voodoo we did. So I always prepare them for the worst. And if that happens, I say, oh, sorry. But if they get anything back and or even just stabilize, I take full credit for saving them.
Okay. Good advice.
Thank you, Luciano. Thank you, Dr. Lee, for your comments. And with that, I think we'll move to the second case. And for that, let me share the screen again. And okay, so am I sharing the screen?
Yes.
Yeah. So now I invite Dr. Heidi Martinez to give her talk. Dr. Heidi is Chief of Practical Works at Eye Ophthalmology Cathedra of Undergraduate and Postgraduate Training of Fellows in Neuro-Ophthalmology. She is the founder of the Neuro-Ophthalmology Section Hospital, San Martin, University of Buenos Aires, and she was the head of the unit until July 2021. She is a full member of Argentine Society of Ophthalmology and Argentine Council of Ophthalmology. She's a Professor Superior Course of Neuro-Ophthalmology SAO, Professor and Coordinator Neuro-Ophthalmology Superior Course CAO, and she has authored several articles, works and posters in national and international congresses. She is the author of chapter of neuro-ophthalmology in various books of ophthalmology and endocrinology. She is the author and coordinator of book of Distance Master's Degree of Argentine Council of Ophthalmology in its last 3 editions. It's an honor to have you with us, Dr. Martinez, and welcome, and kindly present your case. I'll stop sharing.
Hi everybody. Thank you for your kind presentation, and most of all, Satya, for your wonderful organization. I'm going to show you one case, really 2 cases, that the title is What's Happening with My Child. First case is a boy, 12 years old, that began with transient neurological seizure, aphasia, tonic-clonic sensation, all transient, no focal neurological focus. But how did he get here? His mother said that in the last 2 years, his boy, a clever student, has begun to have trouble with his schoolwork and mood disorders. And she knew that something was happening with him, a healthy boy, but all the examinations were normal. Then neurological symptoms increased, And here we can see the MRI with the high intensity T2 and flare that seems vasculitis. So he began with the treatment, but 4 years later, neurological complement increased, most frequent absent seizure, tonic-clonic seizure were generalized, and in 10 years, she was really not able to speak, to read, not to handle on himself, and it was evident the progressive and cognitive and physical decline. And here we can see the sequence of the MRI complaint here, 25-year-old, 19-year-old, 25, 26-year-old. You can see all the brain has been involved, including occipital lobe. In this case, a brain biopsy was done, and here we have the findings, typical of vasculitis. In this case, lymphocytic inflammatory process, but also you can see the alteration of the vessel, blood extravasation, neural degeneration. And here is his visual field when he was 26-year-old, but he couldn't do it really. The cognitive decline was extreme. Here we have a second case, a woman, 28 years old, that began with seizures, and months later, she developed a left hemiparesis. Here you can see the stroke, perigallosal right artery compromised, and here she began with treatment. But 1 year later, she developed a left hemianopsia. Here you can see the visual field, and here the compromise of the posterior cellular artery, another stroke. So again, we perform a biopsy that showed the inflammatory infiltrate. Again, it's in vasculitis. All his evaluation was normal, and he continues on treatment. So we have here two different cases, very different cases with the same diagnosis, that is vasculitis. We know vasculitis is an inflammation of the wall of the vessels that disturb the blood flow. When they have systemic vasculitis, usually they begin with a specific symptom like tiredness or fever, simulating flu state, and then began weight loss and systemic deterioration. But in the middle, we have the compromise of target organ, mainly lung, kidney, skin, musculoskeletal, also neurologic. We can describe 11 main types of vasculitis according to age, and the primary CNS vasculitis is one of the middle age. And if you classify according to the size of the vessel, it can be large, medium, or small vessels, both. Also, the CNS can be primary or secondary. Primary is not a specific disease. It is a descriptive term of what is happening in the brain. And what happens is that we don't have, we are little or no over generalized inflammation, so we don't have those generalized symptoms, flu, fever, asthenia, that make us think that something serious is happening. Secondary vasculitis is when the brain becomes involved in a systemic vasculitis, and mainly when you see a stroke in the young people, like in this Takayasu that began with homonymous quadrantanopsia, you must think that it can be vasculitis, or result for other pathologies, infectious, autoimmune, genetic paraneoplastic, drug-induced. All these forms are very rare. It's a scarce pathology, but always they are serious and potentially life-threatening. We have no trial to establish a definite diagnostic criteria for this pathology. In 1988, Calabrese and Malek established this criteria, general criteria, when you have acquired neurological impairment of no origin and angiography or biopsy showing vasculitis, and of course, you discard another possible etiology of this disease. The disease is rare and very proteoform, and also we don't have a characteristical clinical picture. It can be acute or subacute, like in the second case, chronically progressive, like in the first case, and also relapsing remitting. The first symptoms are not typical, headache, and then began a slow cognitive dysfunction. Then ataxia, and in other cases, the stroke, mainly ischemic. Myelitis is not frequent in this pathology. Regarding the diagnosis, we don't have a serological test or autoantibody, autoimmunity that can affirm that we are with a primary vasculitis. But we must make exhaustive blood tests for the other etiologies, and usually lumen puncture is done, and the CSF is not specific, pleocytosis or elevated protein levels, but nothing specific of vasculitis. So we are discussing about two things. Must we make brain biopsy? Must we make angiography? Brain biopsy for many authors is the gold standard. They say that you can only speak about definite primary vasculitis if you have a brain biopsy. If not, you must talk about probable primary vasculitis. But the discussion is that this procedure is invasive and what you find can be unspecific. But I think that with the improvement of stereotaxic technique, it's not so risky as we used to think. And maybe it's the only way to make a differential diagnosis with some pathologies like infection or amyloidosis-related anxieties recently described. What happened with images? Okay, we must make MRI, an MRA, and if we have a normal MRI, practically discard the diagnosis. But with MRA and the improvement of the techniques, I feel that angiography, catheter angiography, is not so usually done nowadays. Based on images, we have two different characteristics. Small vessel disease, the first case, where biopsy is usually positive and the angiography is negative, and this patient seems to respond better to the initial therapy, but had more risk of relapse. And the other is large vessel disease, where the biopsy can be negative and the angiography positive, and this patient usually is in the second picture, a stroke picture. And what about treatment? We don't have also any trial that can establish a secure treatment. When we only have glucocorticosteroids, the outcome usually was fatal. But with the addition of cyclophosphamide, it improved a lot. We began with glucocorticoids. You can use intravenous or oral, depending on the severity of the disease. Then we changed to azathioprine or methotrexate, always in addition with cyclophosphamide. Mycophenolate doesn't seem to do so well in this pathology. And of course, we have also at the hand rituximab. There are a case report, not trials again, using rituximab when the evolution was bad, and they seem to fit well. And we must be always looking for relapsing. So we must repeat MRI every 3 or 4 months after introducing induction therapy, and then every 6 or 12 months if we clinically no suspect a relapse. But again, we don't have established trial treatment. If you have discarded all other etiologies, the main differential diagnosis is the vasoconstriction syndrome, because it began with cephalea and with neurological acute symptoms. And here the image is helpful because we can see the vasoconstriction, the sausage and string typical of this. And of course, this has a better outcome. Usually in 3 months it resolves. And also you can use the trigger that algorithm based on this article that made a meta-analysis to speak about major and minor clinical and immunological features. And here you can see it. But Again, this is always a very, very difficult diagnosis to reach, a difficult patient to handle, and difficult to make a multicenter trial because the scarcity of this pathology. While waiting your question or your comments and waiting to hear your experience.
Great presentation. Thank you. Now I invite Dr. Nikhil Chaudhary to discuss the case. Your comments.
Thank you. Thank you, Dr. Satya, for getting me here. And these are very different cases, more complex cases. And maybe it depends on the setting where we are, like myself, Dr. Shikha or Ramesh. We are in primary ophthalmic institutions. So this looks very different to us. So maybe let me ask you something more familiar to us. So may I ask you that during the long course of these cases, when were the eyes involved and what were the manifestations?
Yes. In the first case, when we performed the low visual field isometry, cognitive decline was total and he couldn't perform it. But during the first year, there were no visual impairments. So we were sure that his trouble with schoolwork or attention were not of visual origin. Later began with the neurological symptoms and then a rapidly progressive decline of vision. You can see in the images the occipital lobe completely destroyed. In the second case, all his examination was normal, 20/20, fundus normal, OCT, visual field normal, of course, till the homonymous hemianopsia. Yes, but he still remained 20/20 and with no other visual complaint except a stroke.
Okay, and how did you come to this diagnosis of biopsy? I'm sure you are working with your neurologist, but how did you come to, again, a difficult decision of biopsy, and how was it done in these patients?
Okay. This is a rare and complex pathology. We must make a real teamwork, not only with neurologists, also with infectologists, immunologists, medical generalists, expert in images, all working in a team and discussing the cases. How we decide to make biopsy? In the first case, really, we feel that biopsy was not essential. Case was clear, but his mother was desperate. He was worsening despite the treatment, adequate treatment. So we make the biopsy trying to find another etiology that will allow us to make another treatment. In the second case, you see that she has a first stroke, initiate treatment, and a second stroke. So we want to be sure, we performed the biopsy on December 22 after the second stroke. We want to be sure of what we are dealing with, and we are doing the right treatment. Biopsy, we are afraid of biopsy usually, but many trials establish that it's not so risky concerning to death or concerning to disability. And stereotactic biopsy guided by images is pretty sure, I feel.
Yeah, so I have never come across this case, but I went through the literature, and what struck me most that there are several articles which have looked at the diagnostic ability of catheter angiography against the gold standard of biopsy, and the sensitivity and specificity is just in the range of 25 to 35%. We think that cerebral angiography is a gold standard for several vascular conditions, but this looks different, where the diagnostic ability is very low. And even if you do a biopsy, the yield or the diagnostic utility is in the range of 50 to 75%. So it looks very complex condition.
Yes. It's complex and
Dr.
it faces
Swati is asking.
different. Yes.
Yeah, and there's a question from the other panelists that can vasculitis present as arthritic ischemic optic neuropathy, cranial nerve palsy? These patients could, since I think Nikhil asked that what are the eye findings in these patients. So she's asking, can these cases present as arthritic ischemic optic neuropathy or cranial nerve palsies like in giant cell arthritis in the elderly?
Okay. Regarding the images and the angiography, images have improved so much nowadays that and you can have the wall vessel images that can show you the enhances of the wall and can make a more real state about the state of the vasculitis, the activity of the vasculitis. Also help to guide the biopsy. So you can perform angiography, of course, and in this pathology, you want to use all the tools you have. But I believe that images, MRA and wall MRA are enough, and they allow us to make the differential diagnosis with atherosclerotic changes or dissection and other pathologies. Of course, here you have the trouble that you need a real expertise on images. If you have a real expert on images, you can rely on him. And of course, the software must be the adequate one.
I think with that, Dr. Andrew Lee, your comments on these complex cases?
Yeah, so it's the alphabet soup thing again. Primary versus secondary, angiitis of central nervous system, childhood versus adult, progressive versus non-progressive, granulomatous versus non-granulomatous. So it's like the whole alphabet soup, a non-granulomatous, childhood, progressive, primary angiitis of central nervous system. Otherwise, we get caught up with the whole just calling everything vasculitis, and that's where we kind of get into trouble. We have to go through the whole litany thing. So for us, the brain biopsy, which used to be super scary, I think it's just more palatable for us if we use the whole thing, the image-guided, stereotactic, fine needle biopsy, and leave that word brain out of there so that we can be more comfortable with it, because it's totally outside our comfort zone, of course, because we're used to biopsying temporal arteries and not brains.
So, Andy, what we all are trying to know is how can this child with this long diagnosis possibly present to an ophthalmologist? I mean, like you would have seen so many cases in your long career. So how you remember any child who had presented with this kind of diagnosis to an eye clinic?
Yeah, I think Dr. Martinez's cases are kind of the way they present to us. They have homonymous seminopsias, cortical vision loss in the setting of stroke in a kid or progressive neuropsych manifestations in a kid. That's kind of how it comes to us. It can have ischemic optic neuropathy because optic nerve is brain. And so even though we call it primary angiitis and say it's brain, it's really eye and brain, but not the whole eye, just the optic, the brain part of the eye. So all the CNS portions of the eye can show up to us, but usually it's just like this.
And what's difficult in this case is also to discover other etiologies. This is the most difficult thing. So we must work in team with generalists and infectologists and immunologists. Sometimes we think we are dealing with the primary case to other pathology that is not so clear at the site in a time when neurological symptoms began.
Yeah, I think that's the main reason to do the biopsy. the main reason to do the biopsy is to add those extra words, non-granulomatous, primary,
Yes.
because the treatment would change if it's granulomatous
Yes.
versus secondary. So even though it seems like, why are you doing a biopsy when we know it's vasculitis? We already know it's vasculitis, that from the imaging. The issue is, why do you have vasculitis? And of course, we're the ophthalmologists and the neuro-ophthalmologists, but the treatment is slightly different if it's any of those secondary ones, which you saw Dr. Martinez's list of all the different types of vasculitis. There are different treatments. In the past, we didn't have different treatments. We just had steroids and Cytoxan and try and suppress your immune system. But now we have monoclonal antibodies that are more directed. And so even though we don't have a specific target, TNF-alpha, infliximab-based treatments are going to be different than B-cell depleting strategies, which is going to be different than IL-6 or complement-directed strategies. So I feel like eventually neuroimmunology is going to catch up to primary angiitis and CNS. And we're seeing that evolution in the other types of vasculitis. And I think the same thing's going to happen with this. So even though right now we don't need a biopsy to say it's vasculitis, it's more to get rid of those other things than it is to say it's primary on a basis of a biopsy. The biopsy is to not prove it's primary, it's to prove it's not those other things.
Yeah, can I add something? We are thinking in a single entity, but maybe this is there are many entities here. We don't know the origin of this vasculitis, so maybe we are going to find causes like amyloidosis, related vasculitis that we don't know years ago, and maybe we are going to find another entities and isolate from this general picture and explain what's happening.
Thank you. That was a great case and great discussion. Thank you, Dr. Martinez, Dr. Lee. So with that,
Thank you, Dr. Lee.
We'll move to the next case. And now I invite Dr. Luciana Iacono to present her case. Dr. Iacono is a neuro-ophthalmologist consultant at Hospital de Clínicas José de San Martín, Buenos Aires City, Argentina, and she's head of the service, Dra Lydia Serrato. I hope I'm pronouncing all this properly. Ophthalmological and neuro-ophthalmological practice at private office in the city of Veraztegui and Buenos Aires, Argentina. And she's basically into teaching and supervising activities. In 2018, she has done her international observership with Dr. Gordon Plant at Moorfields. And in 2018, she had her international active membership of NANOS. And in 2018, she had her recertification of ophthalmology specialist degree, Medical School of University, Buenos Aires. So it's such a pleasure to have you in NOSIC 3. I think it's your first time in NOSIC, and over to you to present your case.
Thank you so much. It's a pleasure for me to be here. I'm going to share screen. So I would like to, you could see now my screen? Could you see?
Yes, we can. You can make it full screen.
Yes. Well, I would like to thank the organizers who invited me to the third Global Neuro-Ophthalmology Case Festival 2023. I'm going to start my presentation once in a blue moon. Here you can see the rest of the authors that are also part of the team. I have no financial disclosures. This case is about a 72-year-old Caucasian female who consulted me for a second opinion about bilateral progressive impairment of her visual acuity during the last 10 years. Her past medical history showed high hypopituitarism, pituitary adenoma, open-angle glaucoma, and she was taking hydrocortisone and levothyroxine and drops of timolol and dorzolamide. So in 2008, she was diagnosed with pseudoexfoliative glaucoma. Here you can see the ancillary test, the optical coherence tomography, the visual fields, and here you can see the appearance of the optic nerves at that time. So in 2015, her visual field got worse. The intraocular pressure was still normal with medication. So an MRI was performed and a pituitary adenoma was diagnosed in a T1 sagittal section of an MRI with gadolinium and without gadolinium. So when I saw the patient this year, her best corrected acuity was 20/40 in right eye and 20/200 in left eye. The color vision was preserved in right eye. At the slit lamp examination, she showed pseudoexfoliation in both eyes. The intraocular pressure was 12/12. The pupils were hypochoric and hyperreactive in both eyes, and our RAPD was present in left eye. She also had a mild abduction deficit in her left eye, and the fundus examination shows pale optic disc with increased CD ratio in both eyes. So then another optical coherence tomography was performed, another visual field, and they really got worse. So now you can see the ganglion cells complex that are affected in both eyes. So another MRI showed a heterogeneous lesion involving the gland, the pituitary gland, the stack, the chiasm, and also the both cavernous sinuses and sphenoidal mucosa, and we saw also the gadolinium enhancing. So the patient was referred to neurosurgery, and surgical resection and transsphenoidal surgical resection was performed according to the neurosurgery criteria. So the biopsy showed lymphoid and plasmacytic infiltration in the pituitary gland, the dura mater, and sphenoid mucosa. Here you can see in finger number 1 of the biopsy a dense infiltration of typical plasmocytes into underlying fibrous tissue. In the figure of the middle, you can see positive immunolabeling for common leukocyte antigen, CD45. And in the third one, you can see positive immunolabeling for CD138, highlighting the dense plasmacytic infiltrate. So here we have the positive immunolabeling for IgG4, and here you can see it at higher magnification. So once the biopsy was performed, a CT PET scan showed an increased tracer uptake on the left optic nerve, the involvement of the spleen, and involvement of the medial and inferior rectus muscles, bilaterally and with left side predominance. I'm sorry. 1 minute. So the patient's IgG4 titers were normal in serum. So differential diagnosis of IgG-related ophthalmic disease were ruled out, like lymphoma, thyroid-related orbitopathy, idiopathic orbital inflammation, and many others. So there are many reports that shows that corticosteroids is the first-line therapy for IgG4 related disease, and that patients respond promptly to glucocorticosteroids. So the patients start treatment with meprednisone 60 milligrams per day, but unluckily after 4 weeks, the best corrected visual acuity was in right eye 200 and hand motion in left eye, and the visual field and the OCT got worse. And she started intravenous rituximab. So far, the patient's ocular condition has not improved, but she remained clinically stable. So what is IgG4 related disease? It's a chronic multifactorial inflammatory disorder that causes tumor-affected lesions with a dense lymphoplasmacytic infiltrate reaching IgG4 plasma cells and fibrosis. The systemic disease affects almost all organs. In 2011, the International Symposium on IgG4 related disease adopted the term. So we have diagnosis criteria for the pathology. Number one, the swelling or masses in single or multiple organs. Number two, IgG concentrations more than 135. And number three, histological examinations that shows lymphocytes, plasmacytes infiltration and fibrosis. So you can have a definite, probable or a possible IgG4 related disease according to the criterion met. So the patient had a probably IgG4 related disease. She met criteria number one, seen a CT PET scan, and criteria number three, seen at the biopsy. So what about IgG related ocular disease? The most common site of affection is the lacrimal gland. It could be unilateral, bilateral. It causes the swelling of the upper eyelids, and it could cause ptosis. On the right side of the screen, you can see a unilateral case. On the left side of the screen, you can see a bilateral case. The extraocular muscles could also be affected, leading to extraocular myositis. It frequently develops after the dacryoadenitis. It could cause diplopia. The frontal nerves could also be affected. The most common nerve affected is the infraorbital nerve, 9.2 to 39%, producing a sensory impairment in the area of innervation. A compressive optic neuropathy could also produce this pathology. The presumed causes reported are infraorbital nerve enlargement, localized orbital mass, extraocular muscles enlargement, diffuse orbital fat lesion, localized optic mass, and infiltrate or inflammatory process. So IgG-related hypophysitis is really a rare condition. There were 34 cases published in English up to 2015. The MRI showed pituitary and stalk enlargement, and the clinical manifestations could be anterior hypopituitarism, central diabetes insipidus, and panhypopituitarism. So when I saw the patient in 2023, this year, her visual acuity in left eye was 20/200. I think it was due to the compromise of the optic nerve, in addition to the hypophysitis, the hermile abduction deficit in left eye. Perhaps it was due to the involvement of the medial rectus seen as CT PET scan, and the hypopituitarism, of course, is a clinical manifestation of the hypophysitis. So why I decided to call this presentation Once in a Blue Moon? Because IgG4 related hypophysitis is really a rare condition. In this patient, the IgG titers in serum were not elevated. She did not respond to corticosteroids, and IgG4 related ocular disease, in this case, affected only optic nerves and muscles. Thank you so much.
Thank you for sharing such a rare and interesting case with us. And when did you suspect hypopituitarism? When? I mean, the patient presented, you said that the patient to you, though to me it was looking like a bitemporal hemianopia at some point of time, but you said the visual field effects were because of the optic nerve lesion, right? But you started thinking in terms of pituitary deficit. The patient had some, you were thinking in terms of hypopituitarism. So what led you to think about all that?
Clinically, she had adrenal insufficiency. She had a hypothyroidism and central hypogonadism, somatotroph and lactotroph deficiency. And yes, that was the reason I think she had a.
That's when you thought. So how did it go? You said that she was losing vision gradually over years. It was not the one-time thing. It was a gradual loss of vision. And along with that, she developed, it's a male that you're presenting, right? This case is and that of a male, right? So he presented with a gradual decrease of vision and hypopituitarism. When did you think that an MRI is required? I mean, like, how did it go? How did you reach the conclusion of sending the patient for a resection of the that mass? I mean, like, what was the timeline? What was the timeline?
Was the chiasm there was a compression of the chiasm. So
that
I think
this is a very interesting case. What I'm trying to point out is usually when there is an inflammation of the pituitary, logically, unless it's become kind of large and it's become a mass that is pressing on the chiasm, wouldn't think of resecting it. Fine. So yeah. So what was the logic? Whether we should have done a biopsy or a resection? In fact, it's a question open to all the panelists, other panelists, and to Dr. Andrew Lee also. That it's a very rare case. She said that there have been only 34 cases. Now till 2015, it was probably 34. Now I think it's become 59 case reports of hypophysitis, inflammation of the pituitary because of IgG4 disease. And it's a very beautifully well documented case. So usually these cases have a very indolent course. And because of that, the inflammation keeps getting replaced by fibrosis. So it sort of starts becoming, from inflammation over the years, it starts becoming a tumor. That is actually a conglomerate of fibrous tissue. So here in your case, the neurosurgeon has resected the pituitary because it's probably the lesion is pressing on the chiasm. So what I'm trying to find out is, was the chiasm swollen, the optic nerve, it was inflamed because of the IgG4 disease, or because of the typical pituitary lesion pressing on the chiasm causing bitemporal hemianopia, the patient presented to you? So that's what I'm trying to, if you could share your slides again, we could have the expert comments, because the MRI features will be able to tell us. Veena, are you there with us? Dr. Veena Narona?
Yeah, Shikha.
Yeah, I would like to have your comments on Dr.
Yeah, if you see the first MRI itself.
Can you share?
I couldn't go. Okay, so sorry, but okay. Here. Okay. So you want to see the MRI?
The first MRI, the first, yeah.
It'll be a good learning process to have Dr. Veena's comment.
This one or the first one?
No, yeah. The first one. Yeah, that one, yeah. So if you have a look at this MRI.
Make it full screen.
Yes.
Okay, so if you see the MRI on the contrast, you can see that the stalk is thickened. There is enhancement in the stalk as well as in the part of the chiasm. So this itself is an indicator that there's some kind of a hypophysitis going on.
Yes. Okay.
So this is in 2015.
Yes.
And then the subsequent one, it just shows that the disease has just progressed to the surrounding tissues, involving the sphenoid sinus, etc. Yeah. So this just indicates that it's a very chronic lesion because there is some amount of fibrosis that has set in. You can see the enhancement in the center, and the periphery is all, not much of enhancement is seen.
So Veena, this all dark area is actually the fibrosis around the central.
Yeah,
area.
even the part of the sphenoid sinus and all that. That just indicates that it's a chronic disease process.
Okay, another question. Now the chiasm is it's inflamed or it's pressed, it's compressed.
I think in the SAG, it looks like as though it is involved. In the coronal, I'm not able to comment because the chiasm is not seen properly.
Okay.
Fine. So,
thank you.
So we thank you, Dr. Veena, for your expert.
Thank you, Shika.
Yeah. So here, why it was important to be clear about it is that the surgery in that case was justified. If the neurosurgeon has removed it, and because it was pressing on the chiasm, and thereafter picked up hypophysitis. Though on MRI it could have, there were features of an inflammatory process going on over the years. Here it was kind of justified. Maybe in the initial stage when the patient had presented in 2015 a course of steroids at that time, or some immunomodulation, immunosuppression at that time could have helped. Dr. Andy Lee's comments.
Yeah, so this is the alphabet soup thing again. So lymphocytic adenohypophysitis, LAH, and then you got LINH, lymphocytic infundibular neurohypophysitis, and then you got the combined version. So it can be the front pituitary, the back pituitary, both pituitaries, and the stalk. Once it's in the stalk, it's like a super uncommon thing for pituitary adenoma to do that. So that suggests it's infiltrative. And then on the imaging study, pituitary adenoma is like a big ball with a supercellular extension that presses on the chiasm and it gets worn like a hat. So when you see the mass is like infiltrating, then really we should be thinking about infiltrative lymphocytes, and that has its own differential. But many things that we used to call idiopathic are IgG4 now. And like every specialty in medicine has this thing. So Riedel thyroiditis or Kuttner's tumor or Ormond's disease, every single specialty in the whole world had what they used to call idiopathic, including our idiopathic orbital inflammatory pseudotumor. So it's just like the MOG story, right? Things that we called idiopathic, like Cryon, turned out to be MOG. Idiopathic hypertrophic pachymeningitis, that's probably IgG4. So I go back and test all the people who I misdiagnosed as idiopathic in the past with the new antibodies. And again, it makes a difference because treatment, we have better treatments now, and monoclonal antibody therapy and the inhibitors are going to take over for these steroid failures. And there's going to be a new announcement coming through on the phase 3 for inebilizumab for this, not just for NMO spectrum disorder, but for this condition, IgG4. Stay tuned.
So there is a question in the chat box about what is the sensitivity and specificity of the IgG4 test.
It sucks. And even if it's positive, that's not part of the diagnostic criteria, as you saw from Dr. Iacono's slide. It's a pathologic IgG4 diagnosis. You can do it because if it's high, it helps suggest it. But if it's negative, biopsy. If it's positive, biopsy.
Okay.
Yes.
There are a couple of other questions too, that what is the role of CSF IgG4 levels, and for how long IgG4 will be positive in any, during the course of the disease? Anybody can answer these questions.
Thank you.
Serum sucks and CSF sucks even more. So they both suck.
So it's the biopsy actually that can confirm the diagnosis. And I mean, for how long it remains positive, I think it's anybody's guess.
Well, it depends on the B cell depletion that you're doing and the downstream plasmacyte and plasmablast production of immunoglobulin. So I suppose it is a marker that whatever you're doing is helping, because the immunoglobulin will go down, but it'll stay positive as long as the disease is active.
So that means if it's a chronic disease, probably it, it has a possibility of it going down over a period of time.
Okay.
Can germinoma present like this? I think already Lucian has written that he's had a case of germinoma with stalk involvement.
Yeah, you don't know what's in that stalk. You just know probably not pituitary adenoma. So again, the argument for biopsy.
Thank you. Thank you for your comments, Dr. Lee, and a great presentation, Dr. Aikomo. Thank you. Thank you for sharing this interesting rare case with us.
Okay, thank you.
So with that, we'll go to the last case of the session, and I'll invite Dr. Andrew Lee to present his case. And before that, let me introduce Dr. Andrew Lee, who actually doesn't need any introduction. He's such a big name in neuro-ophthalmology world over. He is Herb and John Lyman Centennial Chair of Ophthalmology, founding chairman, Blanton Eye Institute, Department of Ophthalmology at Houston Methodist Hospital in Houston, Texas. He is a professor of ophthalmology, neurology, and neurosurgery at Weill Cornell Medicine, and an adjunct professor of ophthalmology at Baylor College of Medicine, Texas, A&M College of Medicine, University of Iowa and University of Buffalo, and clinical professor at University of Texas, medical branch in Galveston, Texas, and the UT MD Anderson Cancer Center. He is a past president and chairman of the board of the North American Neuro-Ophthalmology Society, NANOS, and he's currently the senior vice president for advocacy at NANOS. Dr. Lee has been the invited speaker at over 400 national and international conferences, and he has written over 500 peer-reviewed publications and 14 full textbooks, and has given 15 named lectures. So it's really an honor to have you with us in this session and program. And I invite you, Dr. Lee, to present your interesting case.
Well, thank you so much for having me. Can you see the slides there? Yes, the slides are shown?
Yes.
Yes, we can see the slides, but it's not full. Is it full screen?
How about now? It's in presentation mode now? Yes?
Yes,
we're good?
Please.
All right, so I'm going to talk to you about whack-a-mole. And just so you know what whack-a-mole is, it's a game where the mole comes out of the hole and then you whack them with this hammer. It's a game. So this is a 51-year-old white female. She has 2 autoimmune diagnoses, multiple sclerosis and thyroid eye disease. Her past history was that she had been on multiple MS medications, and I'm going to show you those meds. And then she got Graves' disease, for which she had a thyroidectomy and is now on replacement levothyroxine for hypothyroidism. She presented with typical thyroid eye disease symptoms and signs: diplopia, orbital pain, dry eye, ocular surface issues, blurred vision. She developed a steroid responsive and then steroid dependent course, but was developing significant steroid related side effects. And oculoplastics and Orbit wanted to do orbital decompression, then strabismus surgery and lid surgery, which is the typical order for the procedures. And then she presented to us for a second opinion. So these were the multiple MS medications that she had been tried on: Betaseron, Avonex, Rebif, Rituxan, Tysabri, and Lemtruda. And someone has already asked about one of those medicines. And this is just to translate for you with the Rosetta Stone. what these medicines actually are. And I call your attention to the monoclonal antibodies. So once you have mAbs in there, you got to think about adverse effects related to the mAbs. So she had the Graves' disease. She had secondary steroid-related osteopenia. Her past surgical history was negative. Her mother had MS. She didn't smoke. She's a social drinker, and she had a bunch of other medicines which are not related to this presentation. She, at age 18, had bilateral, then sequential optic neuritis consistent with multiple sclerosis. It resolved to optic atrophy, and her vision was 20/20. And she had serial visual fields, which were essentially normal. She had been treated back then with ACTH. In 1989, she developed a partial sensory transverse myelitis. She had secondary MS-related trigeminal neuralgia. She had diplopia, which was thought to have been an INO probably. And she had some residual right and left-sided weakness, which was mild. And she had the prior optic neuritis in the past. Serial imaging studies showed progressive worsening periventricular white matter lesions consistent with multiple sclerosis that met the modified McDonald criteria for dissemination in both space and time. And she was treated with those multiple medications for MS of the relapsing remitting type and had her attacks treated with IV steroids. So you can see she's got this long course of MS, typical MS relapsing remitting course, 1989 all the way up to 2018, when she was transitioned off of natalizumab and switched to alemtuzumab.
It looks silly if you have the same talk like in 20 places.
Alemtuzumab. So when I saw her, she was coming to me for not that MS thing, but for intermittent diplopia, and a CT scan that showed very typical thyroid eye disease findings with enlargement of the bilateral superior, medial, and a little bit of lateral rectus, as well as sparing of the tendons and bilateral proptosis. Her thyroid was stable on replacement levothyroxine, but she had positive TPO and TSIG antibodies consistent with autoimmune hypothyroidism after hyperthyroidism from Graves' disease. So up until this point, there's nothing spectacular about this case. And we saw her, she was 20/25 and 20/20. She had residual RAPD from her prior optic neuritis that was old. Her pressures were normal. She had an esotropia, which is the expected thing, and an orbital ultrasound showed it was from medial rectus muscle being restricted from thyroid eye disease. Her color vision was a little bit down, but not a lot. She had the bilateral proptosis. Her slit lamp and fundus exam were otherwise normal. She had a visual field, which was essentially normal. And you see she's got this little bit of nerve fiber layer loss from the prior optic neuritis in the past. And so the reason I'm presenting this case is because normally you just say, well, if you have one autoimmune disease, you're more likely to get another autoimmune disease, and you just have two autoimmune diseases, thyroid eye disease and MS. That's a known association. And then you've got this competing hypothesis, which is, could MS be related to thyroid eye disease as a treatment side effect? And so just to summarize what's happened to her up until this point, she had relapsing remitting MS. She was on alemtuzumab. She had serial MRIs that showed McDonald criteria dissemination in time and space, both in her brain and spine, supratentorial and infratentorial white matter lesions, all consistent with MS. She developed this orbital presentation, diplopia, proptosis, treated with steroids, was found to have thyroid eye disease, and was treated with levothyroxine. So of course, someone already latched on to the fact in the chat that was she on alemtuzumab, which is the Lemtruda, and that one you need to know because Dr. Google knows that alemtuzumab can cause thyroid dysfunction and can look just like thyroid eye disease that we're used to seeing, including Graves' disease. And so even though it's tempting just to say it's two autoimmune diseases, it really was alemtuzumab induced. And so alemtuzumab, you need to know that the monoclonal antibody mAb, the ZU means it's humanized, and the 2 means its original target was for tumor cells, and the alem doesn't mean anything, but its trade name is Lemtrada. And so one of the things that I find fascinating about this case is the Lemtrada, alemtuzumab, targets both T and B cells, but spares components of the innate immunity and the hematopoietic precursor cells. Its mechanism is depletion of antibody-dependent cytolysis mediated by natural killer cells, NK cells, and neutrophils, and complement-mediated cytolysis. And there's going to be repopulation of the lymphocytes. So it's going to be depletion and then repopulation. And in the new production of the T cells and the B cells in the repopulation phase, you might get an asymmetric repopulation. So it doesn't come back in the same way. And so my main point of presenting this case is that you should know that autoimmune disorders are associated with this particular agent, but really, I think it's probably going to be a lot of other agents in the future. And the one to know is alemtuzumab. Graves' disease is the predominant one that it causes in 60 to 70% of patients, but you can see there's these other autoimmune things that are present. And so there have been a number of editorials written about years of thyroid monitoring are going to be needed even after single treatment with this drug, alemtuzumab. And so it's definitely going to be a lifelong problem for our patients who received alemtuzumab. And the other thing that's interesting about it is they may have received that drug a long time ago. So there's not a close temporal relationship between the thyroid and the drug. In fact, they may already have been discontinued from the drug. And which brings us to whack-a-mole. The treatment of fire, in this case, is to treat fire with fire. We are mitigating the alemtuzumab-associated autoimmunity in multiple sclerosis B-cell depletion strategy with whack-a-mole. So what happened was depopulation, then repopulation, but the repopulation was asymmetric and it caused another autoimmune disease to emerge. And so we're going to whack down that other mole. And so this is just a summary slide to show you that the way these drugs work now, the monoclonal antibodies, in this case, lymphocyte suppression, the B cell depletion is what happens, and that's where we're getting our effect. And so you've got the secondary autoimmune disorder developed because the other cell line is coming back faster. And so B cells and T cells knocked down, but then T cell function and B cell function not matched, and that can unleash underlying autoimmune disease, and in this case, thyroid eye disease. So to mitigate the risk of the secondary autoimmune disorder, whack-a-mole, when the other cell population is coming up, we hit it with rituximab. So the T cell, B cell asymmetry can be knocked down with a B cell depleting strategy, whack-a-mole. I didn't invent that term. That was from my friend, Elliot Froman. So here's what happened to the person. She received maximal medical therapy starting in 11 of 2020 and had a steroid responsive course, but then whack-a-mole, because she was about to have surgery, rituximab was given to try and B cell deplete the thing down. And after the rituximab, everything went away. And that means it spared this patient a surgery. You might also be familiar with the other monoclonal strategy for thyroid eye disease, which is teprotumumab. So you might have been tempted to give teprotumumab here, but that is a different strategy. That is IGF-1 receptors on fibroblasts. So I'm not sure that that would have been the right strategy here, because we know what the alemtuzumab can do is cause this disproportionate B cell and T cell repopulation. And so this is a very common presentation of a very uncommon problem, which is she had relapsing remitting multiple sclerosis, and it was from the treatment of the disease, not the disease. And amazingly, that alemtuzumab, the Lemtrada, had been given 2018. That was years before I saw this patient. So even though the patient comes to you and is just going to say, I have MS and I was treated with a bunch of medicines, you need to know what those medicines were, even if they're not on that medicine right now. And for thyroid eye disease, the one you're going to ask about is alemtuzumab, Lemtrada. And because she had this steroid responsive, steroid dependent course, we did the whack-a-mole and gave her the rituximab, which is the B cell depleting strategy for CD20. And just with medical therapy, it prevented the need for all the series of surgeries that were coming her way. orbital decompression. That's going to cause the strabismus to be worse. That's going to cause the lid to be worse. So you're talking about not just one surgery, 3 surgeries, orbital decompression, strabismus surgery, and lid surgery, all treated with a monoclonal antibody. And teprotumumab is doing the same thing. By way of disclosure, I am a consultant for some of these companies, including Horizon, but doesn't have anything to do with alemtuzumab. So really my take-home points on this case is, I tell our residents, any ophthalmic manifestation in a patient who has a disease, whether that disease is cancer or MS, could be the disease, but it could be the treatment of the disease. It could also be a side effect of the treatment of the disease. It could also be a side effect of the side effect of the treatment of the disease. It could also be a side effect of the side effect of the side effect of the treatment of the side effect of the disease. And that means sometimes the doctor is what's causing this. You cannot just let the person say, I'm on MS medicines. I try to avoid the trade names because I want to know, is this a MAB? Is this a Zumab? Is this a Lizumab or Tuzumab? What is this thing? And Dr. Google knows. So the patient had already Dr. Googled this, and she knew that this was a side effect of her medicine. And so you need to know a little bit about whack-a-mole. Happy to turn it back over to you, Shika.
Thank you. Thank you for sharing actually a very a case of difficult disease for the patient and the doctor as well. I would invite Dr. K. Kunia to discuss this case with you, Dr. Lee.
Thank you, Shika. Thank you, Andrew Lee, for that wonderful case. I think it highlights how important the history is, and just by seeing the case, looking at the pattern, don't diagnose as Graves' disease or thyroid eye disease. I just had 2-3 questions. In India, we work as private institutes. We work along with neurologists, not like we have next door neurologist, because most of us are in eye institute or private ophthalmology institute. I just wanted to know your long-term MS patients, do they have any other associated autoimmune disease over a period of time? You might be having a 20-year follow-up of a patient. We hardly see them. That's why we don't have much experience. That's the first question I just wanted to ask you.
Yeah, so a lot of patients have other autoimmune diseases. So it's just so common. And once you have one autoimmune disease, you're actually more likely to have another one. So the most common is thyroid and myasthenia. And everyone here is very familiar with that, where patients have both type 2 antibody-mediated disorders, thyroid and myasthenia. So we're all used to knowing and telling our residents, look, if you got a thyroid patient with ptosis or a thyroid patient with exotropia rather than esotropia, those are the patients who actually have a second autoimmune disease, myasthenia gravis, and the reverse also. If you have myasthenia and proptosis or myasthenia plus lid retraction, you should be thinking about concomitant thyroid and myasthenia. And so that's been my conventional teaching all for years. But then this patient comes along because the monoclonal antibodies now, you got to think about, is it 2 autoimmune diseases, or does Dr. Google know something that you don't, which is that particular monoclonal antibody causes a second autoimmune to develop. And so one of the questions in the chat was that will AI or ChatGPT replace us? I don't think it'll replace us, but you should definitely ask ChatGPT. In this patient who has multiple sclerosis and has thyroid eye disease, could it be her medicines? And ChatGPT would know that this was alemtuzumab. It would know it right away.
I think Dr. Bebani has a point. As a neurologist, I mean, like, is it a non-issue for the neurologist? Thyroid eye disease. What if thyroid eye disease? It can be managed. Continue the drug. So he wants to know, would you, if the patient was, is
Maybe.
it an issue?
I mean, every choice is, which is worse, the disease or the treatment of the disease. In my particular patient, she had failed all the other treatments before anyway. So it wasn't really that big a surprise to her. But all the problems that she got from the thyroid eye disease, she would gladly give those back. But we can't take it back now. The alemtuzumab from 2018, you're stuck with this now. So it's not like the other side effects, which can kind of just go away if you stop the drug. So even after you de-challenge the patient, the actual de-challenge is actually what's causing the problem too, because once you stop it, the repopulation is going to occur. And that asymmetric repopulation of the B cell versus the T cell is what causes the release of the thyroid eye disease and probably the other autoimmune conditions in the alemtuzumab related autoimmune diseases. So it's very strange. It totally puts on its head the things we would normally say about cause and effect. Like normally you would say, when was that medicine? 2 years ago. You would not be thinking, oh, 2 years ago, that definitely causes it 2 years later. And so it's similar to the radiation story, right? The radiation optic neuropathy, immediate, intermediate, and then there's this delayed thing. Their radiation therapy was years ago, and now they have radiation optic neuropathy. So that time interval between cause and effect, you can't rely upon it for radiation, and you can't rely upon it for these monoclonal antibody-induced adverse effects.
So have you seen any case where, the patient was on the drug and, you had to manage the thyroid eye disease and the drug was continued? Or is it that,
No.
it's an indication for stopping the drug? That's what
it is an indication for stopping it. And in our country, there are both medical and medical legal reasons for doing that. You better have a darn good reason for keep doing it if you think it's the cause. So really, that's going to require an entire informed consent discussion, risk benefit with the patient. So if the patient is going to choose to continue medicine despite thyroid eye disease, they better sign a bunch of papers, because thyroid eye disease has a lot of different manifestations that don't look anything like MS. So even if the person's had years and years of multiple sclerosis, they're probably not, as someone in the note commented, prepared for the psychological burden of thyroid eye disease, the cosmetic changes, the proptosis, and 3 surgeries. So 3 surgeries. So the real,
so it's not.
It is an indication to stop it. Yeah,
it's a big issue to stop the drug. Thank you.
Yeah,
Thank
I
you.
would stop.
Thank you. We've had a wonderful session. With that, I hand over the mic again to Dr. Satya Karna to take the program forward.
So thank you, Shikha, and let's move on to the next session. Let me introduce the panelists first. We have Dr. Ambika, who is a senior consultant and head of Neuro-Ophthalmology department at Shankar Nethralaya, Chennai. She is also the vice president of Indian Neuro-Ophthalmology Society. She has authored several publications in ophthalmology journals. She is also an author of the Shankar Nethralaya Atlas of Neuro-Ophthalmology and the SN Atlas of Neuroimaging and He won the best paper in AIS 2014 and the best paper award in ICT RIMS in 2015. She has participated as invited speaker at national and international ophthalmology, neurology, and neurosurgical conferences. Her areas of interest are optic neuritis and demyelination, ocular myasthenia gravis, IIH, LHON mitochondrial optic neuropathies, and neuroimaging. Next, we have Dr. Rohit Saxena, who is professor and in charge of strabismus and neuro-ophthalmology at Dr. RP Center for Ophthalmic Sciences, AIIMS, New Delhi. He is the secretary of the Indian Neuro-Ophthalmology Society. He has 260 indexed publications. He is an editor of 3 books, including a video atlas in strabismus surgery, and authored more than 50 chapters in various national and international books on strabismus and neuro-ophthalmology. He has been invited as faculty and attended more than 25 international conferences, including conducting instructional courses. He regularly conducts an IC at the All India Ophthalmology Society meetings. He has 33 international awards. Many of them are listed here. Next, we have Dr. Mahesh Kumar, who is head of Department of Neuro-Ophthalmology at Arvind Eye Hospital, Madurai, India. He trained under Professor Nachiyar, and he has been in the Neuro-Ophthalmology Department of Arvind Eye Hospital ever since for the last 20 years. He has edited a neuro-ophthalmology textbook for postgraduate students, and he is co-author of an atlas of imaging in neuro-ophthalmology and has several publications in national and international journals. He is a popular invited speaker in state, national, and international meetings. Next, we have Dr. Swati Fuljale, who is an additional professor of ophthalmology, again at the Dr. R.P. Center, All India Institute, Delhi. Her areas of interest are neuro-ophthalmology and strabismus. She is a joint secretary of the Indian Neuro-Ophthalmology Society. She was awarded the AIOS Singapore National Eye Center Fellowship in Neuro-Ophthalmology. She is a section editor of the Neuro-Ophthalmology for Indian Journal of Ophthalmology, and she's also the managing editor of the Indian Journal of Neuro-Ophthalmology, a new publication. She has 80 peer-reviewed publications and 25 book chapters in various journals. Next, we have Dr. Durga Priyadarshini. She is a consultant at Department of Neuro-Ophthalmology, Shankar Nethralaya, Chennai. She did her Neuro-Ophthalmology Fellowship from Shankar Nethralaya and has been working there for the past 9 years. She has presented several scientific papers and posters in national conferences. And recently, one of her papers on optic neuritis in Indian population, for which she was the corresponding author, is published in IGO and received the IGO Silver Award for the year 2022. She has actively been a part of the organizing team of neuro-ophthalmology and cataract conferences at Shankar Nethralaya. And let me introduce the first speaker for this session, Dr. John Chen, who is a professor of ophthalmology and neurology at Mayo Clinic, Rochester, USA. He is the fellowship director for neuro-ophthalmology at Mayo Clinic, and he is on multiple committees for the American Academy of Ophthalmology and a board member for NANOS. He has over 200 peer-reviewed publications. He has received several research awards and is currently RO1 funded through the NIH. He has given over 200 oral presentations, including multiple named lectureships and visiting professorships on his interests in ophthalmic imaging, idiopathic intracranial hypertension, and optic neuritis, especially NMOSD and MOG antibody-associated disease. He also received the Achievement Award from AAO, Resident and Fellow Teaching Awards at the University of Iowa. So I invite Dr. John Chen to now start his presentation.
Great. Well, thank you so much for that introduction. I think Drew Carey has a conflict right now. I think he reached out to you thinking, could he present now first, and then I could present next? Would that be okay to just change the order just a touch?
Yeah, that would be fine. Whom did you mention?
I was just over, I saw it over the text. Is that true? Is that true, Drew?
Yeah, I would really appreciate that. Thank you, John.
Oh, Andrew.
Yes, if that's okay. Sorry
Well,
for the
Let
mix up.
me introduce you. Just give me a minute. Yeah, fine. Okay, I'll just introduce you. Yeah, okay. So Dr. Andrew Carey is Assistant Professor of Ophthalmology and Neurology at Johns Hopkins University School of Medicine, Wilmer Eye Institute in Baltimore, USA. He has given lectures at multiple international meetings, published over 30 journal articles, 6 book chapters, and edited 1 textbook. He also hosts 2 podcasts in ophthalmology and sits on the editorial boards for Ophthalmology Journal, Blue Journal, and the Journal of Neuro-Ophthalmology. He sees patients with neuro-ophthalmic disease, medical retinal disease, and genetic eye disease. He's nominated as the best consulting physician in Johns Hopkins National Capital Region and been granted the Secretarial Award from the AAO. Over to you, Dr. Andrew.
Thank you for inviting me. It's a true honor to participate in this wonderful conference, and thank you for allowing me to present early. So I'm going to present a case as vision loss in a cancer patient, or also known as I'm a survivor, and we'll move forward with the case. I don't have any financial conflicts. We'll describe some potential vision-threatening complications during the course of treatment of skull-based cancers. Understand some mechanisms of optic neuropathy, classify patterns of vision loss, and hopefully by the end discuss treatments of potential vision-threatening complications. So this is kind of a long case, and we're going to move through the very beginning a little bit quickly. But it begins back in December of 2011 when the patient developed loss of smell and horizontal binocular double vision, worse in left gaze. This led to an MRI scan and a biopsy that showed a grade 3 to 4 olfactory neuroblastoma. He completed chemo and radiation therapy about 6 months later. And a year later was his first eye exam in our department, at which time he was 20/20 in the right eye with a normal exam on the right. The left eye was count fingers with a very dense RAPD. He had an elevation deficit and the disc was markedly pale. About 2 to 3 months later, he was noted to have a recurrence of his cancer with level 2 neck and lymph node metastases, and underwent repeat adjuvant chemo and XRT after dissection. Was relatively stable for about 5 years when he presented to me for a neuro-ophthalmologic evaluation. And the right eye was stable. The left eye demonstrated 3 millimeters of proptosis and elevation deficit. And his MRI showed a recurrence in the left orbit that was proven with biopsy. And he underwent again, adjuvant chemo radiation and was started on pembrolizumab, which is an anti-PD-L1 inhibitor for the program cell death ligand 1. The left eye unfortunately progressed to no light perception despite treatment. In September of 2020, he returned to me, and at this time he had a new left trigeminal deficit in the V1 branch on his exam, and his MRI at this time demonstrated recurrence of his maxillary sinus. He underwent again adjuvant chemo radiation after surgery. And this is when we're going to kind of start the interesting portion of the case, in case you were falling asleep, for the first 10 years of this patient's cancer. And he came in to see me, and it had been a little over a year. He was not the best at follow-up, but he had, extensive visits for cancer treatments and monitoring that were certainly a burden to him time-wise. And he had reported that for the past 2 months, he had pulsatile tinnitus triggered by bending over and exercise, and a sharp stabbing headache in the right brow that occurred 2 to 3 times a week and typically lasted 1 to 2 hours. He denied any transient visual obscurations, and he was blind in the left eye, so he was not experiencing any double vision. And for the past week or so, he felt that he had some numbness in his upper lip and teeth on the right. His visual acuity in the right eye was 20/20, and his colors were normal. This is his OCT of the optic nerve and ganglion cell layer here. His RNFL was thickened at 149 microns, worse superiorly, and his ganglion cell was diffusely thin. And you can see on the en-face image of the OCT that there's a pretty obvious 360-degree elevation of the optic disc and blurring of the margins and a little bit of obscuration of blood vessels. So this would be about a grade 3 optic disc edema. On the top, we have his previous Humphrey visual field, which was essentially normal in that right eye. And this is his Humphrey visual field at this visit, which shows a mild double arcuate scotoma. So at this point in time, it was felt that he had new disc edema with good visual function and headache, as well as pulsatile tinnitus that was worse bending over and with exercise. And so the top of my differential at this point in time was possibly this could be papilledema from tumor recurrence or protein shedding. Of course, he had a paled nerve in the other side, so this would be considered Foster-Kennedy syndrome in the setting of his pulsatile tinnitus and headache. Other considerations at this point in time would be optic disc edema from optic nerve infiltration. Usually, we would be seeing, fairly rapid decline in vision and worse visual acuity, but certainly possible. He could have meningitis. He has been treated with chemotherapies and radiation, which predisposes him to infections. And he is on this pembrolizumab, which instead of being immunosuppressive is actually predisposes people to autoimmune conditions, inflammatory disease, and has been associated with optic neuritis. So that was certainly a concern in this patient, although the visual acuity was really good. So at this point in time, the plan was to get an MRI scan, brain in orbits with and without contrast. And at our institution, we usually do skull-based protocol in this situation, a lumbar puncture to look for signs of recurrent malignancy if there was not clear tumor recurrence on the MRI, and discussed treatment options with his oncology team. So this is his MRI scan. On the left panel, we have a KISS sequence, which is kind of like a super T2. And we can see that there's posterior globe flattening bilaterally and a little bit of optic disc elevation on the right. And there's a little bit of optic nerve enhancement anteriorly in the optic nerve head on the right. And in the middle panel, which is our T1 fat sat axial. And in the right panel, we have our sagittal KISS, and we can see that there is vertical tortuosity of the optic nerve head, or sorry, of the orbital optic nerve, all signs suggestive of elevated intracranial pressure in this patient. So after discussing with radiation oncology, they said, we don't think we can do more radiation safely. He's had a lot, and it would put him above safe values for exposure to his only seeing eye. Medical oncology said, we've done everything we can for this guy. The only thing we can do is continue his current treatments. We're hoping this immunotherapy is slowing the growth of tumor. There's not even a phase 1A clinical trial that he could be enrolled in. So he came back to see me, and 2 months later, his visual acuity field and OCT were stable. We decided to start him on Diamox at this point in time. And he came back a month later, and he was having decline in his visual acuity with a new central scotoma and a new third nerve palsy. And this continued to get worse the next month. So I called radiation oncology, and I said, he's going blind without radiation. You might as well do the radiation treatment. And these are his visual fields from March, 2 weeks later and 2 weeks after that. And so there was, clear progression of his central scotoma. So he did undergo his radiation treatment and finished that in April. And he returned in May, and his visual acuity was stable at 20/40, and his disc edema had resolved. His RNFL thickness is now down to 77, and he had mild pallor on exam. His ganglion cell was already near the floor in that eye. And he's, his central scotoma in May after completing his radiation was perhaps a little bit worse, but he still had usable visual acuity and peripheral vision. He did not return until a year later, at which point he thought his vision was stable, but on examination, his visual acuity was down to 2300. The disc was pale and flat, and this is what his visual fields looked like. He had enlargement of the central scotoma extending inferior temporally, and had him come back for close follow-up and an MRI scan. And we can see that this scotoma was perhaps getting worse and it involved into a complete temporal hemianopia at this point in time. So there was concern that he was having a worsening optic neuropathy with a temporal scotoma. And at this point in time in this patient, with his complex history, there was concern, could he have a new tumor recurrence? Could this be compressing the chiasm or optic tract? Could this again be anti-PD-L1 associated optic neuropathy or optic neuritis? Could this be the radiation optic neuropathy that the radiation oncologist was worried about? Or could this be some type of infection? And so he went for MRI scan. And here on the MRI scan, we have the T1 fat sat, and you can see there's enhancement of the optic nerve. I'll go backwards here in the canal and prechiasmal segment, and a little bit on the right side as well. And these appear to be radiation necrosis changes in the inferior frontal lobe. And we'll show it again on the coronal here. So left as in more than the right eye. And then there's some radiation changes superiorly. It appears that this enhancement extends into the chiasm. So this is now in July of this year. And so at this point in time, I called his medical oncologist and I said, I think we need to start bevacizumab treatments. And he said, does that mean you're going to do it and you're going to inject it into his eye? And I said, that would be a lot easier, but unfortunately, this is the intracranial optic nerve involved. And I don't think intravitreal bevacizumab will have nearly enough penetration and potency to treat his prechiasmal optic nerve. And he needed systemic bevacizumab in the format of intravenous infusions. I said, usual protocols are 5 to 10 milligrams per kilogram given every 2 to 3 weeks for 4 to 6 cycles. And so, I think the take-home points from this case is cancer patients are difficult. There's so many different ways they can have vision-threatening complications. It can include tumor progression, infiltration, compression of the optic nerves, chiasm, other optic pathways. They can develop elevated intracranial pressure from the tumor just taking up space, the tumor compressing the CSF drainage pathways, or from tumor shedding protein into the spinal fluid that then clogs the arachnoid villi and drainage, kind of what we see in patients with uveitic glaucoma, but this is inflammatory elevated intracranial pressure. The patients on chemotherapies are at increased risk of infections, and they may present atypically and not have the typical pain, swelling, fevers that we see in our immunocompetent patients. And then they can have complications from treatment. In surgery, they can have ischemic injury, they can have direct injury to the optic nerves, they can have autoimmune diseases from their checkpoint inhibitors, they can develop retinopathy and uveitis from checkpoint inhibitors, and they can develop radiation toxicity. So these are all things that we really need to keep in mind when we're seeing these patients, and make sure they're getting thorough workups. And some of these complications require more urgent treatment than others and carry more systemic risk than others. So some teaching points about radiation optic neuropathy. The greatest risk factor is the maximum point dose. They usually talk about this as the dose to 1 cc. And if it's greater than 50 gray to the optic nerve, or a single fraction dose greater than 2 gray, this increases their risk of developing radiation optic neuropathy. And there's an apparently high risk from whole brain radiation. It's only 30 gray total, but it's typically 10 fractions of 3 gray each. And it's probably that 3 gray per fraction that really increases the risk of radiation optic neuropathy in these patients with whole brain radiation. With the modern techniques of radiation, where they give intensity modulated radiation therapy, also called IMRT, they may be lower risk than the older techniques, but they still pose some risk to the optic nerves. It's unclear if proton therapy is greater risk than photon therapy. It's a newer protocol, and it has a different biology than treating with photons, and we don't really have enough data about it. And then there are some people that get a mix of proton therapy and photon therapy. The usual onset is 6 months to 5 years after treatment, with a mean of 2 years. Patients getting re-irradiation are going to be higher risk for developing radiation optic neuropathy, and they may present more acutely. The prechiasmal optic nerve is really the highest risk location, and that appearance of thickening and enhancement in the prechiasmal optic nerve that we saw in this patient's MRI is really classic for radiation optic neuropathy. And intravenous bevacizumab, which was originally tested in radiation brain necrosis, is probably the treatment with the best effect for our patients with radiation optic neuropathy. It's unlikely that they're going to recover vision. Probably the best thing we're going to do is prevent further vision loss. And so diagnosing the patients early and treating them early is really crucial. We don't want to delay bevacizumab while we're trying other treatments, because if they progress, that's vision that we could have saved that now we can't. These are some references from some of the research we've done and publications from Johns Hopkins on radiation optic neuropathy.
Thank you, Dr. Carey, for that excellent case. An unfortunate gentleman having repeated recurrences, and he had to undergo a repeated radiotherapy, and finally he had lost vision. And so there are certain questions in this. Did he present to any ophthalmologist before presenting to you at the onset of the symptoms? Did he have any eye examination? He did have double vision, you had mentioned, but any other visual acuity and other things, was there any record of it?
He did see 2 outside neuro-ophthalmologists, one initially when he had the double vision, and who had ordered the MRI, and then had presented to an outside institution for second opinion on treatment options for his tumor therapy, for his esthesioneuroblastoma before coming to our institution. There were not a lot of eye exams. I think he saw one other eye doctor at our institution before he came to see neuro-ophthalmology at Johns Hopkins. But it was not a consistent follow-up. Yeah, it was the neuro-ophthalmologist who saw him for the double vision who ordered the MRI that led the outside neuro-ophthalmologist and that led to the diagnosis of the esthesioneuroblastoma.
Okay. So in this case, as you have said, there could have been several reasons why his vision could have gone down, like it could have been the checkpoint inhibitor therapy and so forth. So in this case, specifically, the imaging finding has helped us to diagnose the radiation-induced optic neuropathy with its specific features. In order to rule out other causes like checkpoint inhibitor side effects, are there any imaging findings that could have helped us, or we don't have any specific imaging findings in those conditions?
Yeah, I think the immune checkpoint inhibitor associated optic neuritis or optic neuropathy is it's a newly recognized condition. You know, these treatments have not been around that long, and neuro-ophthalmic complications are not frequent. They occur in maybe 0.5% of patients, and the optic neuropathy might occur in 0.05% of the patients. It was first recognized that they can develop optic neuropathy in around 2016. Most patients will not have MRI findings. About 70% of them will have a normal MRI scan, so no retrobulbar optic nerve enhancement. Most of the patients will have optic disc edema, probably greater than 90%, and oftentimes it's bilateral. And it's unclear if it's a primary optic neuritis or if this is a papillitis associated with uveitis. About half of patients will have some obvious overt simultaneous ocular inflammation, whether it's an anterior anterior chamber reaction or signs of choroiditis or CME. So I think if you're seeing, retrobulbar optic nerve enhancement in a patient with a history of radiation, you should really think it's most likely going to be radiation damage rather than checkpoint therapy inhibitor.
There have been some questions from the other panelists, like how did your patient respond to bevacizumab in this case? Yeah,
I saw him after his second infusion, and he had a mild improvement in vision. I think he went from maybe 2400 to 2200. That's debatable if that's a true improvement. The central scotoma was a little bit smaller on the field. Overall, he felt that his vision was a little bit better and that he was functioning better. I think, as I said, most of the patients you're not really going to see improvement. So not going more blind in his case, in my opinion, is a big win. And I think there was another question about timing. The best timing is as soon as they have any vision impairment. I think if there's no more optic nerve enhancement, you've probably missed any potential window for treatment. If the patient's no light perception, you've probably missed a window for treatment, although I might try. I guess you could try it because there's not much to lose if that's the only eye the patient has. As far as hyperbaric oxygen, we don't use a lot of it at Johns Hopkins Wilmer. I think the best evidence is probably within the first 48, 72 hours to use it. You probably don't get much vision improvement with that either. And I think the challenge is probably 48 to 72 hours of the patient being aware of the vision loss is probably not 48 to 72 hours of optic neuropathy. The patients oftentimes are not, may not be aware of it, especially if it's only in one eye. By the time they're coming in, they're probably have severe vision impairment and are at the longer end of the course. Occasionally, these patients are getting frequent MRI scans for their cancer monitoring, and you'll see optic nerve enhancement on the MRI scan before they have vision impairment. If you're monitoring them closely, we're working on developing a monitoring protocol for these patients that are at high risk due to their total dose. And then the question becomes, is that leptomeningeal disease or is it radiation damage? And we're working with our radiologist to look at diffusion imaging to see if we can determine is it signs of ischemic changes that you might get in radiation optic neuropathy, as opposed to something like more cellular from an infiltrative disease. Yeah, I think those are the major questions that came up.
In case we don't have immediate access to bevacizumab injections or hyperbaric oxygen, does IV methylprednisolone offer a immediate solution of sort?
It's probably better than nothing. I think certainly in some of the trials with for radiation brain toxicity, they have done bevacizumab versus IV steroids, or bevacizumab as rescue therapy for patients where IV steroids fail, and the bevacizumab does seem to be superior in both those settings. I think most of us, before bevacizumab came around as a potential treatment for this, we used it, and I don't think any of us had a lot of relief. I don't think we felt like the patients improved much with it. It's probably better than nothing, as long as they're not at risk for complications. They don't have an active infection. They're not in decompensated heart failure. I think that's reasonable. I think there's a question or comment about pentoxaphylline. I think a lot of that data for pentoxaphylline is from cutaneous radiation toxicity. It takes a long time for pentoxaphylline to build up in the system. In soft tissue disease, you don't really see an improvement for about 3 months. I wouldn't really want to wait 3 months if it was my optic nerves. And it is contraindicated in patients who are hypercoagulable or on or high risk of bleeding, and a lot of these patients are, and so it may be contraindicated in those patients, especially if they have radiation brain toxicity. We don't want them hemorrhaging into their necrotic lesions in the brain. We do use bevacizumab for isolated optic nerve, radiation optic nerve disease, if they don't have to have brain involvement.
Thank you, Dr. Carey, for the extensive case discussion and the extensive explanations on the different modalities. So over to Satya.
Yeah, thank you, Andrew. Thank you, Mahesh. So can I now invite Dr. John Chen to share his screen?
Okay. Can you all see my screen?
Yes, we can.
Wonderful. Well, again, thank you for the invitation to speak and the introduction earlier. I thought I'd share this case that I thought was very interesting because there's a lot of twists and turns with it. And then we'll also talk about new treatments for this disease, so end with some hope for this rare disease. It's a case of a masquerader. So this is a 19-year-old female from Arizona who presented with headaches and transient visual obscurations. She had post-hospital tinnitus, and on exam, we saw a good amount of bilateral disc edema, grade 3 to 4, as you can see here. And the vision was 20/20 in both eyes. And the visual fields were intact, large blind spots. And so anytime you have bilateral disc edema with intact vision, we're immediately thinking that this is going to be papilledema from raised intracranial pressure. And of course, in a 19-year-old female, we're thinking that this is probably just going to be run-of-the-mill IIH. But of course, we need the workup. So we start off with the MRI and MRV. And what we found is nothing too surprising. The MRI showed no mass lesions, no obstructive hydrocephalus. There's some bilateral transverse sinus stenosis, but no thrombosis. And again, we're thinking, well, this is probably going to be a run-of-the-mill IIH. So let's get the lumbar puncture. Lumbar puncture showed our elevated opening pressure of 46, just as expected, But this is where there's a little bit of a twist. So here, when we looked at the CSF constituents, we saw that the patient had 25 white blood cells with a normal cutoff of 5. So this is clearly not IIH. This is raised intracranial pressure from some other process. So at the time, the patient was just treated with antibiotics and acyclovir for presumed meningitis just while we're trying to get it sorted out. The patient was started on acetazolamide 500 milligrams twice a day, and the patient had an ID consultation with CSF testing for multiple infectious etiologies, which came back essentially normal. Unfortunately, a couple weeks later, the patient had worsening headaches, confusion, some more transient visual obscurations, some dysarthria and ataxia, so they represented to the ED. At that point, the infectious disease workup came back and it was unremarkable. And so this patient was admitted for further work with management. The first thing is one of the things that we did is a repeat eye exam, which was unchanged, still grade 3 to 4 papilledema with pretty intact vision. And of course, with the new neurologic symptoms, we need a new scan. And before, when the scan was normal, now we're seeing some abnormalities. There's some T2 changes in the right basal ganglia. There's also some diffuse patchy T2 changes and enhancement in the sulci. And you can see here that leptomeningeal enhancement that this patient had. So clearly something's brewing. The patient got a repeat lumbar puncture and the opening pressure was still elevated at 34, but now we've got even worsening pleocytosis now to 271 white blood cells. Before it was just 23. We also got a PET scan that was completely negative. So what do we know about this patient? Well, we know the patient is a 19-year-old female from Arizona. She's representing with worsening symptoms that seems unresponsive to empiric oral antibiotics and acyclovir and acetazolamide. Now with the MRI showing leptomeningeal enhancement, the lumbar puncture showing increased pleocytosis, but the workup has been negative. So what are some next steps and what are some things on the differential diagnosis that the panel might kind of think about right here? Any thoughts? Well, I can tell you what we ended up doing. You know, at this point, again, we had 2 spinal taps. We had a PET scan that was negative. We got an MRI that was clearly abnormal. We got a brain biopsy at that point. I know it's a large step, but this patient was going downhill. Unfortunately, it was non-diagnostic. We saw fibrotic arachnoid with scant lymphocytes and macrophages, but no diagnosis was made there. And we all put our heads together. And then, you know, the thought was, you know, this patient's from Arizona. And therefore, there was actually a strong thought, maybe this is coccidioidomycosis meningitis. This is that valley fever from the fungus Coccidioides that lives in the soil of southwestern United States. And so that was the thought of what this patient could potentially have. The patient was placed on antifungal treatment because when you have CNS coccidioidomycosis, it actually requires lifelong antifungal therapy. And so the patient was placed on fluconazole and amphotericin and eventually on long-term fluconazole. And so we thought we had our diagnosis and we thought she would get better. Really, the papilledema was hard to control, so ultimately we placed a VP shunt for that medication refractory papilledema. But there's some caveats to what we thought was a very smart diagnosis. One is we really couldn't isolate fungus. We had coccidiosis, CSF PCR that was negative 3 times. The biopsy was negative. They did have improved symptoms. The patient did have improved symptoms with the VP shunt, but the pleocytosis persisted despite the antifungal therapies. So it was really kind of unclear still what was going on. 1 year later, though, she developed new onset lower extremity weakness and paresthesias. At this point, we have an image of the MRI of the spine, and what we see is these clearly enhancing nodules involving the caudoquina nerve roots with leptomeningeal enhancement of the distal thoracic cord and conus. And of course, now we've got another source to biopsy. That's gonna be our next step. So we did a lumbar lumpectomy with biopsy, and it showed atypical histiocytic infiltrate, positive with cyclin D1, factor VIIIa markers with negative CD1A and BRAF. And so this is not our patient, but this is kind of a representative of what our patient had. Essentially, they're these foamy histiocytes with some admixed Tootin giant cells And sometimes these patients have a positivity for factor 13A in soft tissue. And so now with this biopsy, now we actually have our diagnosis of this very rare entity. And this patient had Erdheim-Chester disease. So let's talk about Erdheim-Chester disease. It's a rare form of non-Langerhans cell histiocytosis. It typically affects adults between the age of 50s and 70s, and really can affect any organ, as you can see in this diagram here, including the brain and the eyes. And one of the kind of hallmarks of Erdheim-Chester is typically you get long bone involvement with osteosclerosis. Actually, that's what made our case actually quite difficult to diagnose. We actually had a PET scan right off the bat that didn't show any long bone involvement. About 50% of patients have this V600E BRAF mutation. That's important because that helps with potentially what you can use to treat them with. And the diagnosis is weighed with biopsy, often showing these histiocytes, Teuton cells, and positive CD68. It can be a fatal disease with a 5-year survival of about 68%. In terms of treatment, the first line is often interferon alpha, and there's also PEG interferon alpha 2A. There's cladribine, and those are kind of some of the traditional medications that we start with. If a patient has a BRAF mutation, the BRAF inhibitors are very successful. The other treatments are anakinra, which is interleukin-1, tocilizumab, an IL-6 inhibitor, infliximab, an anti-TNF, and cobimetinib, a MEK inhibitor. Corticosteroids and radiation therapy have limited effect. And so these are kind of the main treatments. It's rare that there's not huge randomized clinical trials for this disease because of how rare it is. So for our patient, the patient was treated with interferon alpha and a MEK inhibitor and high-dose methotrexate, and she failed each of these one by one. And, it was a pretty scary situation where, we were happy we had made the diagnosis, and yet she wasn't responding. And we know a mortality rate, survival, about, 30 to 40% of patients can pass away within 5 years. Because of progressive disease, we actually elected to do a repeat spinal cord biopsy to do some more molecular diagnosis. And we found that she had a CSF1R mutation. And what's exciting about that is there is now this new treatment called pexidartinib, which is a monoclonal antibody targeting CSF1R. And again, there's just case reports for that in Erdheim-Chester, but this patient had complete remission after already failing kind of the traditional medications. And you can see here, this patient on follow-up had a resolution of the papilledema. So this patient had a really, really good outcome. And so there's that hope that we have from this patient. So again, some takeaways that I thought were interesting with the twists and turns. Anytime you see and suspect papilledema, you want to have a broad differential diagnosis. Really, the only way you can make that IIH diagnosis is that MRI, MRV, and spinal tap. And when you do that lumbar puncture, you're looking for that CSF constituents. You want to make sure there's no signs of pleocytosis or elevated protein. And again, I'm sure there's actually an interesting debate right now whether do you even need a lumbar puncture in patients that you think are just going to be IIH. This would be an example, a very rare example of where lumbar puncture actually was helpful in making a diagnosis. Of course, not all meningitis is infectious, although this patient looked infective and we're essentially thinking coccidiomycosis. It ended up being Erdheim-Chester. And then the hope from this case is that we now have molecular guided therapy for Erdheim-Chester. If they have BRAF inhibitors, if they have a BRAF mutation, we have BRAF inhibitors, and if they have CF1R mutation, we have pexidartinib. And so it provides some hope for these cases. And I think that's what I wanted to present today, and I'd be happy to answer any questions you might have.
So I have a question for you. Looking at this case, do you think an MRI spine at the first presentation itself for papilledema would have helped reach the etiology?
That's a very good question. So anytime we have papilledema and we have a spinal tap that shows elevated protein, a lot of cells, especially if there's a clean MRI. I'll always get that MRI spine looking for some tumor that's kind of releasing a bunch of cells and protein. For here, we didn't get it because the patient had clear MRI brain findings, and we thought that's where it was coming from. So that's why we didn't get it right off the bat. Second, she had no symptoms that would suggest any disease in the spine. Third, we actually had a PET scan that actually was negative, and it didn't show any hypermetabolic activity in the spinal area. I suspect if we got the MRI of the spine at initial presentation, it would have been negative, because later on, when she had the spinal lesions and those symptoms, we got a new PET and it did light up in the spine. So I think if we got it right off the bat, it would have been negative, but it would have been interesting to see if maybe there was something subtle there that we could have biopsied at initial presentation.
So there's a question from Ambika: how frequently is Erdheim-Chester disease seen in young age?
Yeah, it's one of these things where typically it's going to be older patients. But again, it's rare. It's one of those zebras among zebras. And I've seen them as young as, I think we just had it like an 18-year-old who had it. And so it can happen in young patients too. But usually you're thinking, that 50-year-old, 60-year-old. Obviously, this patient was only 19. So now I guess we've had a couple now that are this young. So it can definitely happen.
Okay. And then, though a question not related to you, but question from Raib, whether coccidiomycosis is common in India. So any of the institution-based ophthalmologists or neurologists could answer this. I haven't seen much. Anyone?
My guess would be not very common. So in terms of when you kind of think about coccidiomycoses, we think of Southwest US, parts of South America and Mexico. And so actually, because this person came from Arizona, we actually thought we were pretty brilliant in coming up with this diagnosis of coccidiomycoses. Again, I don't see it much in Minnesota because obviously I'm in the Midwest, not in Southwest Arizona, where, it's pretty common in the soil and they see it much more. But, we put our heads together and we thought this could make perfect sense. It loves to cause, raised intracranial pressure, pleocytosis, and it can be notoriously hard to diagnose, even with, multiple spinal taps. So at first we thought we made a pretty brilliant diagnosis, but clearly it's one that didn't respond to treatment, and that's how we ultimately came up with another diagnosis.
I have a very basic clinical question. How far are we these days with OCT angiography in finding out, or at least suspecting, a particular etiology when we image disc edema? Can we make out if it's ischemic, or is it inflammatory, or it's just raised intracranial pressure?
No, that's a good question. So when OCT angiography first came out, I thought it was going to be brilliant because it would be able to distinguish between ischemia and inflammation, just like you said. The drawback is essentially with OCT angiography, all we're measuring is perfused capillaries. We're not actually measuring that blood flow through the capillaries. And so essentially in the acute setting, it's essentially fairly normal. And then afterwards, any optic neuropathy will cause loss of capillaries. And so it's not very specific. It's just another structural biomarker as opposed to being able to actually gauge true blood flow. And that's what we would need, is the true blood flow. And unfortunately, that doesn't answer it for us.
So you mean if we look at disc edema with OCT angiography, we cannot make out whether the lesion lies just behind lamina, lies in the intraorbital optic nerve, or even behind that?
Yeah, essentially, some of the capillaries are going to be enlarged. You're going to have a good amount of artifact just from the disc edema itself. So you're going to have to be stuck with some of that artifacts. I think some of the early publications saying that, NAION was associated with decreased capillaries, or papilledema was associated with decreased capillaries early on. I think a lot of that's just artifact. When you have that much signal and swelling, it's hard to image those individual capillaries and make it look like there's a decrease in capillaries.
I've actually asked this question in advance. There are a couple of cases coming up, which are actually disc edema and confused etiology. So We'll see.
That's great.
Yeah. Any other questions from anyone?
I saw there's one more comment here talking about orbital more commonly seen for ophthalmologists, and that's very true. I think ophthalmologists will often see that orbital mass, the good part is it's an easy biopsy. You can make the diagnosis there. So yeah, irritable Chester likes to cause orbital masses. That's one of the things that are pretty common. But it can affect any part of the brain or body. So it's one of those masqueraders, a zebra, but a masquerader.
Yes. Anyone else? Any questions? Okay. Thank you, John.
Thank you, everyone.
Thank you. And now I'd like to invite Dr. Amanda Henderson. Who is the Associate Professor in Ophthalmology and Neurology and the Chief of the Division of Neuro-Ophthalmology at the Wilmer Eye Institute at Johns Hopkins University School of Medicine in Baltimore, Maryland. She is involved in clinical and translational research with particular interests in optic neuropathies. She has published over 40 peer-reviewed publications as well as a book entitled Controversies in Neuro-Ophthalmic Management. She is also the Neuro-Ophthalmology Fellowship Director and Associate Ophthalmology Residency Program Director at Wilmer. She holds leadership positions on education-related committees in the American Academy of Ophthalmology and the NANOS. Over to you, Dr. Amanda.
All right. Thanks, Satya, for that excellent introduction. And thanks for the opportunity and the honor to join this great group of neuro-ophthalmologists from around the world. Let me share my screen here. And let's see if I can get this in full screen mode. Is everyone seeing my slides in full screen?
Yes.
Okay, very good. All right, well, we'll get started with this case of poor vision in a child. I did sort of design this as a bit of a back and forth discussion with Dr. Ambika and anyone else on the panel, so I will reach out a few times during the presentation for input. So our case is a 6-year-old boy who presents with 1 year of declining vision. He was followed by an optometrist as well as a pediatric ophthalmologist for the last couple years and had been given a diagnosis of refractive amblyopia, which was treated initially with glasses, and more recently, just a few months prior to his presentation to us, he had been advised to start patching due to a lack of improvement of the vision with his refractive correction. So he had a refraction that was done 5 months prior to his presentation to us. And so you can see that he has some fairly significant astigmatism, but it's pretty similar in the two eyes. So he came to our clinic for the first time with both of his parents, and his mom reported that he had to sit at the front of the classroom at school to be able to see anything that was going on, and that anytime they wanted him to be able to see letters, he had to use at least size 28 font, even with his glasses on. No one had noticed any significant strabismus. No one had seen eye crossing, including his teachers and his parents. So when we saw him, his acuity was 2200 in the right eye and 2080 in the left eye, and that did appear to be declined by a line or two from his last appointment with his pediatric ophthalmologist, which was 3 months prior to his visit with us. He had sluggish pupillary reactions in both eyes, but no relative afferent pupillary defect. He correctly identified 4 out of 5 gross colors with the right eye and 5 out of 5 with the left, but wasn't really able to identify the Ishihara color plates. He had full motility and his alignment was ortho. His slit lamp exam was overall fairly unremarkable until we looked at the iris, and it did look like he had what appeared to be a single Lisch nodule temporally on the right iris, and his pediatric ophthalmologist had not noted such a thing at his last visit 3 months prior. So on his dilated exam, you can see a photo of his optic nerves here, as well as the OCT images that seem to correlate with the clinical picture here. So there's no normative database for a 6-year-old on the serous OCT, but you can see his retinal nerve fiber layer is certainly on the thin side, with an average of 68 microns in the right eye and 63 in the left eye. And both of his ganglion cell complexes are quite thin, with an average of 60 in both the right and the left eye. And so I thought I'd get Dr. Ambika and the rest of the experts' thoughts on this. What would be on your differential, and perhaps most importantly, what would you do next?
Well, you have a child with bilateral poor vision, which probably is worsening from the initial consultation. And you see a pale disc with a sluggish pupil in both eyes, which probably an asymmetric involvement. The next step will be to image, but probably we would like to probe more on the history of, apart from the vision loss, did he have any other developmental problems, or would be interested in knowing any cognitive changes which the parents have noticed in the recent, along with the vision loss?
No, it's a great question. As far as cognitive changes, he was 6 years old, so he was in kindergarten at this point in time. It seemed like he was a little bit behind his peers, but at that age, there hadn't been any major developmental delays. He wasn't in any special classes or anything like that.
And no recent viral illness or so?
No recent significant illnesses.
With this condition, probably we might go on for imaging, and I think you can show up the next
Absolutely.
slide.
That is what we did. I certainly agree with that. So I'm going to show a few cuts from his MRI scan, which was done based on these findings. And so you can see these are T1 post-contrast sequences on the coronal and on the axial, that both of his prechiasmatic optic nerves are markedly enlarged and thickened. And you can see that over here as well. As we go a little bit posteriorly on the MRI, you can see that enlargement extends to involve the optic chiasm. And there's this fairly significant locus of nodular enhancement there in the chiasm as well. And then a bit more posterior on the coronal, the right optic tract also seems to be involved in this process, also quite enlarged and enhancing quite a bit as well. And so at this point, I think we're all getting a little bit worried that he has multiple findings that could be consistent with neurofibromatosis type 1. So I'd like to take a minute just to talk about the diagnostic criteria for neurofibromatosis type 1, which were revised just a couple years ago in 2021. And that revision was particularly relevant to us as ophthalmologists because although Lisch nodules have long been on the diagnostic criteria, the choroidal abnormalities were added to the diagnostic criteria in this most recent revision. So when we think about the diagnostic criteria for NF1, patients must either have 2 or more of the things we see here if there's no known family history of NF1 in a parent. However, if they have a known family history in a parent, and we know this is a dominantly inherited condition, then they only have to have one of these findings to confirm the diagnosis. And these findings include some skin findings, café au lait macules, as well as axillary or inguinal freckling, the presence of 2 or more neurofibromas of any type or 1 plexiform neurofibroma, the presence of an optic pathway glioma, the presence of 2 or more Lisch nodules, which you can see up here in the photo on the top right, or 2 or more choroidal abnormalities, which you can see here on the photo on the bottom right. And these choroidal abnormalities can be identified on near infrared imaging. So this is like the en-face image we get with an OCT. So we're typically getting these images in clinic for a lot of our patients, at least. The other criteria are a distinctive bone lesion or a known pathogenic NF variant gene mutation. So when we think about our patient at this point in time, We know that he has an optic pathway glioma. He only had one Lish nodule, and that seemed to be a new development based on his recent ophthalmic evaluations. But we did send him for further evaluation at the neurofibromatosis clinic and a dermatologic exam, and he was found to have axillary freckling as well. So at this point, he did meet the criteria for an F1. So our diagnosis as far as the vision is concerned is an optic pathway glioma affecting both prechiasmatic optic nerves, the optic chiasm, and the right optic tract in the setting of NF1. And so I have a few questions for the panel, and then we'll talk a little about the rest of the case. Would you pursue treatment for the glioma at this point? And if so, what kind of treatments might you consider?
See, if there is a ongoing visual loss, I think then we cannot wait and watch. So there is definitive progression of the vision loss, which you have documented. In that case, probably we can consider for a management for the most sought chemotherapy will be the first one. And I guess so, you would have also pursued the same.
All right, so let's talk a little about optic pathway glioma in the setting of NF1, and then we'll talk about the conclusion of this particular case. So we know that NF1 is caused by loss of function alterations in the NF1 gene.
Second bruschetta, and then I'll take a green curry.
And that gene is a negative regulator of the MAPK pathway. And when you have an alteration in that gene, that leads to abnormal MAPK activation as well as activation of the BRAF oncogene. And then these children unfortunately develop many of the tumors that we were talking about in the last couple slides. We know that optic pathway glioma occurs in 15 to 20% of children with NF1. However, most of these gliomas, unlike some other gliomas that may happen outside of the setting of NF1, most of these NF1 associated gliomas have an indolent course and don't have to be treated. However, as Dr. Ambika mentioned, when visual decline is noted, particularly if it's progressing, then therapy may be indicated for these tumors. So what do we use for therapy? Well, I think one issue to address is, in general, biopsy or surgical resection is not pursued for these tumors unless there is a really bulky component that seems to be compressing other parts of the brain. Because in general, the risk of biopsy and causing vision loss is going to be much higher than the risk of assuming, if you will, that this is a low-grade optic pathway glioma in this setting of NF1. So what kind of treatments are available for these gliomas, knowing that surgery is not really the curative treatment here? Well, chemotherapy has been a mainstay of treatment in children with optic pathway gliomas in the setting of NF1 when treatment is indicated. And usually that first-line chemotherapy is a combination of vincristine and carboplatin. In one large series, 46% of NF patients with optic pathway gliomas that indicated treatment had a partial tumor response. And in fact, that was a higher rate than those who had non-NF associated tumors. But unfortunately, 15% of NF patients still had progression of their optic pathway gliomas, even with the vincristine carboplatin treatment. Additionally, it has been shown that visual outcomes do not always mirror the radiologic response in these patients. And in fact, many patients who have a radiologic response of their tumor still don't have improvement in their vision and may in fact continue to have visual decline. And so clearly, with the limited response rate, limited visual recovery, as well as the known toxicities that can be associated with chemotherapy, there are some limitations to treating these children. Radiation is generally avoided for a couple of reasons in this particular group of patients. Reason number one, of course, is that we know they have activation of an oncogene. And so secondary malignancies in the setting of radiation really become a big concern in this group, as well as the fact that they tend to be quite young. And so long-term radiation-related adverse effects, particularly vascular kinds of effects, are really a concern in this population as well. So there is lots of interesting work being done in this area, which is why I thought this would be an interesting case to talk about. And this is in the area of targeted therapies, which several other cases this morning have already discussed targeted therapies for various diseases. And there have been targeted therapies that appear to be effective in the setting of optic pathway glioma secondary to NF1. One of these therapies is selumetinib, which is a MEK inhibitor, or a mitogen activated protein kinase inhibitor. MEK is this downstream protein kinase, and targeting this protein kinase can prevent reactivation of that MAPK pathway in the presence of BRAF or RAS mutations. And we talked about the activation of the MAPK pathway in the setting of NF1. So that's sort of the theory behind why this would be effective. There was a recent phase 2 clinical trial in children with recurrent, refractory, or progressive low-grade gliomas in the setting of NF1, and 40% of these patients sustained a partial response. So it's a fairly similar radiologic response rate to the standard of care chemotherapy treatment. However, there's currently a phase 3 trial that's specifically looking at visual outcomes to see if perhaps these more targeted therapies could produce better visual outcomes than the current standard of care chemotherapy regimen. So we don't really know the answer to that yet, but that is an ongoing and actively recruiting trial. There have also been a few other agents looked at in this setting, including bevacizumab, which would be like an IV, a systemic bevacizumab, which don't have as strong of data as the MEK inhibitors, but also are being evaluated in this setting. So let's go back and talk about how our patient progressed. And so because of his progressive visual decline, the plan was made to proceed with treatment. We're fortunate at Hopkins that we have an NF center, and so we really take a multidisciplinary approach to treat these patients with a team of ophthalmology, pediatric oncology, neurology, and sometimes plastic surgery, depending on their other tumor burden. And so the patient was evaluated with pediatric oncology, and they discussed, the standard of care chemotherapy regimen versus the clinical trial for the MEK inhibitor selumetinib. Now, this was back in 2019, and so this actually was the phase 2 trial that was enrolling. And in the setting of, the lack of evidence at that point in time, the patient and his parents ultimately decided to go with the standard of care chemotherapy regimen. His treatment course was complicated by some toxicities, including the development of a neuropathy, which was treated with gabapentin. And fortunately, that did resolve after he completed his chemotherapy course. So as far as his vision is concerned, he had some decline in vision after we initially saw him until the chemotherapy sort of got started, just a little decline, 2200 in the right eye and 2100 in the left. And then after the chemotherapy started, his visual acuity initially continued dropping to 2300 and essentially stable at 2100 in the left eye. However, during the course of treatment, and actually at the last time I saw him, which was about 2 years after the completion of his chemotherapy cycles, he was 2150 in the right eye and 2050 in the left. So in fact, did seem to have some improvement since his initial presentation to us during and after the treatment. And he was ultimately genetically confirmed to have neurofibromatosis in addition to meeting the clinical criteria. And so sort of the summary here, the take-home points, if you will, is that as ophthalmologists, in treating patients with neurofibromatosis type 1 or in patients with suspected neurofibromatosis type 1, we have a couple of important roles. In patients with known NF1 and optic pathway glioma, we have a really important role to help monitor for visual decline, because just because these patients have a tumor doesn't mean the tumor needs to be treated. And in fact, we might spare them lots of toxicity if they have a stable glioma that doesn't have to be treated and we can just monitor their vision. However, we also play an important role to say, this child is losing vision and we really need to get this tumor treated to prevent further vision loss. The other important role we play in these situations is we're able to identify both Lisch nodules and choroidal abnormalities that can help lead to the initial diagnosis of NF1, even sometimes in patients who there isn't a lot of suspicion for that up front. In addition to our role, I thought this was an interesting time to talk about treatment options that include the standard chemotherapy regimen for these tumors, as well as more recently emerging targeted therapies like selumetinib. So that's, I will turn it back over to Dr. Ambika for any discussion.
Yeah. Thank you, Dr. Amanda. That was a wonderful case, and it's quite common pediatric optic pathway lesion which we would come across. And as there are some couple of questions, see, like if the only way we follow these patients is the visual decline we use as a criteria to proceed with the treatment when we see an optic pathway glioma. What do you do for pre-verbal children? When you see an optic pathway glioma, how do you monitor them? Because when do you take the call that this has to be treated? So how do you monitor these cases?
Sure. Pre-verbal children or children, either very young children or children who have a developmental delay of some kind in the setting of an F1 are of course very difficult to monitor if you can't get a good acuity. I mean, there are ways to measure acuity in these childs, like teller cards, to at least come up with some sort of estimate of the acuity. I think, you know, in these sorts of cases, and I should probably defer to my pediatric ophthalmology colleagues in some of these cases, but they're really the experts. But I think we just have to do the best we can to determine whether there's any visual decline.
Is there any role of OCT or imaging characters which you would use as a cues to proceed to the treatment? Because I do agree with the children of that age group, OCT is also not that easy to get a good fixation out of them. So that's
absolutely
difficult.
I think, you know, OCT, I love OCT for many things. I use it all the time. And I certainly think it's a good adjunct monitoring tool in these patients, particularly when there may be some variability in the visual testing in children, even those that are verbal, just to see if there's any structural lesions that are correlating with, you know, with the vision decline. However, I think we try not to make our primary recommendations for whether or not to treat with chemotherapy or targeted therapies based on structural imaging alone. So I think it's a nice adjunct if it can be done. And, you know, I think in a 6-year-old, it can be done. In an infant, unless you have a portable OCT, you know, it can be a bit harder. But I think it really shouldn't be the primary criterion if we're able to get any sort of visual function data. I think someone in the chat mentioned VEP. And certainly if it's a pre-verbal child, you know, VEP is an option. We do, you know, you can do sedated VEPs in those children, or now some groups, including including us at Hopkins, have a handheld VEP that can at least give some sort of estimate of visual function in these children.
Would you add a hormonal assay or endocrine workup in these patients? Would you consider getting that?
I think this is part of the multidisciplinary team I mentioned. I would not typically be the one doing that workup in these children, but I think it absolutely is indicated for them to see someone who is very familiar with the systemic effects of neurofibromatosis and all the monitoring that's required. Again, we're very fortunate that we have a center devoted to that, and so we have enough experts. But I think all of us as ophthalmologists need to have an idea of, you know, what neurologist or oncologist would be familiar with the overall presentation and complications of NF1 to manage these children systemically. I don't think we as ophthalmologists should be the ones having to do that, but I think referral to the appropriate experts is of course important.
Okay. Was there any change on the imaging post-treatment? There's a question in the chat box.
There was no significant change in the size of the tumor. There was some decrease in the amount of enhancement of the tumor, which we would probably expect over time with or without treatment. We do know that visual sequela from these optic pathway gliomas seems to correlate more with the size of the tumor on MRI than it does with the enhancement of the tumor on the MRI, but that was really the major change we saw after the treatment.
I just have one final question. What's your take on proton therapy for OPG?
I think in these young children, we certainly don't have strong data for that yet due to the concern for long-term sequela. I work with my radiation oncologist in adults who have optic pathway glioma to determine what they would recommend. I think in general, with optic pathway gliomas, we're more often treating with either chemo or a targeted therapy, and less often with radiation directly to an optic nerve, which of course, as we've talked about this morning, I think, or this evening for you guys several times, can lead to long-term radiation-induced optic neuropathies.
Okay, are there any other questions from other panelists? If no, thank you, Dr. Amanda. Over to you, Satya.
Thank you.
Thank you. Let me invite Dr. Lulu Burston, Associate Professor in Neuro-Ophthalmology at the Western University in London, Canada. Dr. Burston is also the president of the Professional Staff Organization for St. Joseph's Hospital and sits on the hospital board. She has served on several board subcommittees, including the Quality Committee, the Healthcare Ethics and People and Mission. She likes to dabble in research and currently has 40 publications listed on PubMed. She teaches both ophthalmology and neurology residents and has won the Ophthalmology Surgical Teaching Award in 2016 and the Ophthalmology Clinical Teaching Award in 2023. In her former life, Dr. Burston was a chemical engineer and brings to neuro-ophthalmology her love of problem solving that she learned as an engineer. Over to you, Dr. Lulu. I need to unmute.
Okay, am I in?
Yes, you are. We can see the slides and hear.
All right, so thank you so much for including me in this conference. I feel so honored to be presenting alongside some real giants in neuro-ophthalmology. So I'm going to present a complex case of simple atrophy. So this is a 42-year-old woman who presented with a year and a half complaining of just problems with her depth perception, some problems with her color vision, difficulty particularly at night. She's feeling otherwise well. She denies any other symptoms, no focal neurologic deficits. She does have an interesting past medical history. So about 20 years ago, when she was 20, she was diagnosed with Guillain-Barré syndrome. So she presented in a fairly typical manner with ascending weakness as well as diplopia. She was quite unwell and required a brief stay in the ICU, but then recovered with no residual deficits. She has no family history of any known ophthalmic conditions, no autoimmune disorders, no known cancer. She has 3 siblings, all of whom are healthy with no eye problems. She has 4 children, all of whom are healthy with no ocular disease either. So on exam, her visual acuity is 20/25 in the right, 20/20 in the left, normal pressure. There was a right RAPD. Her color vision was markedly decreased. She didn't get any of the Ishihara color plates, and she was not known previously to be colorblind. Extraocular movements were full, a line was orthophoric, and her slit lamp examination of the anterior segment was completely normal. Her fundus examination, however, showed profound pallor of the right optic disc and mild pallor of the left optic disc. So we did visual field testing, and despite her excellent acuity, she had fairly diffuse and significant field defect, worse on the right than the left. You can see that her foveal threshold is preserved in both eyes. They were relatively reliable fields considering the depth of the defect, so I believe that this was all real. We got an OCT, which showed significant thinning diffusely and bilaterally. Worse on the right than the left, which would go along with her right RAPD. So because the Humphrey visual fields were so poor, I did do a Goldman visual field as well, and they were remarkably good, again, considering how profound her vision loss was on the Humphreys. So you can see there was no particular pattern of vision loss. There was no central scotoma or homonymous hemianopia, so just diffusely reduced on the Humphreys. So she had all the investigations that we could throw at her. So she had a number of MRIs, including the head, spine, and orbits. The only abnormality was that the optic nerves and the chiasm were small with high T2 signal. She had a lumbar puncture, which was normal. She had lots of blood work for infectious diseases, normal. NMO and MOG were negative. She had some genetic testing, so LHON and a CMT panel were negative. Testing for any toxic heavy metals, all negative. She was seen by neuromuscular neurology because of this history of Guillain-Barré, and she was found to have a very unremarkable neurologic examination. So other than cranial nerve 2, cranial nerves were normal. She had normal power, maybe some increased tone, maybe a slightly wide-based gait, but normal coordination, normal sensation, and normal reflexes. So the only abnormality we could find on all of this testing was a known pathogenic SPG7 mutation, specifically this ALA510 variant, but she was heterozygous for this mutation. Now, this particular mutation is a known pathogenic mutation for spastic paraplegia type 7, which is typically inherited in an autosomal recessive pattern, which means that she would be expected to be homozygous for this mutation in order to demonstrate any abnormalities. So I've been following her for many years now. So when she first came to me, if you remember, her vision was 20/25, 20/20. So a year later, the right eye dropped to 20/40. And then on her most recent exam this year, her right eye has gone all the way down to hand motions. Left eye started out as 20/20, but over the years has also declined. And her most recent exam a few months ago was 2400. I kept doing visual fields. They didn't really change very much. One could argue that the most recent fields, I think those are from probably 2019, showed that it had gotten worse, more depth of depression, but the pattern remained the same. And her optic discs are very pale, as we had seen just initially. I repeated her OCT, and again, she already had a bit of a floor effect, so the RNFL thinning hasn't progressed much despite the progressive field loss, progressive acuity loss. And then I did repeat her Goldman visual fields, which started to show all these patchy areas of loss. So you can see the right eye up here on the right, left eye, and then the binocular field below. So a little bit about HSP7. So this results from a pathogenic mutation in the SPG7 gene, which encodes paraplegian. Patients usually present with bilateral weakness and spasticity, as well as reduced vibration sense. Typical onset is around the age of our patient, so between age 30 to 45. It's a rare disease, and it's typically inherited in an autosomal recessive manner, with carriers being asymptomatic. However, autosomal dominant pattern of inheritance has been reported, and there is variable penetration and variable tissue specificity. So the mutation that our patient had is the most common mutation for this disorder, and the phenotype can be very variable, even in patients who have the same mutation or who come from the same family. There have been a pure and a complex phenotype described. So the pure phenotype is what I mentioned before. So the spastic paraplegia, hyperreflexia, reduced vibration sense, whereas the complex phenotype can have a lot more manifestations. So certainly that includes an optic neuropathy, but also ophthalmoplegia, ptosis, nystagmus, dysphagia, cognitive impairment, motor and sensory neuropathy, really a whole gamut of possibilities. So when optic neuropathy is included as part of the complex SPG7 phenotype, patients have been described to have vision loss, color vision loss, optic disc pallor, and RNFL thinning. And in patients who have no symptoms, this subclinical RNFL thinning has been detected on OCT. Vision loss usually is detected either at the time of or late in the disease course, but occasionally has been reported to precede the paraplegia, even by a few years. So why would this happen? So why would this mutation cause optic neuropathy? Well, the SPG7 gene does encode the mitochondrial matricial AAA protease, which is involved in the OPA1 protease cleavage. So that is the same gene pathway that's involved in dominant optic atrophy. So there is a possible pathogenic mechanism why this particular mutation would result in optic atrophy. So the big question here is this enough? Are we convinced that this is the cause? I mean, she's had a very good workup. She's seen multiple specialists. We have found nothing else to explain her atrophy. But no one has ever described vision loss without any kind of manifestations of SPG7 before. And I have been following her for a number of years, and she never developed any of these other features, the spasticity or the loss of vibration sense, other than maybe that very slight wide base gait. So is this enough? Well, when we don't know the answer to something, I feel like we're very fortunate in neuro-ophthalmology to have this worldwide database of colleagues who can help out. So with the help of NanoSnet, we've actually managed to compile a small case series. So with Carter Bell and Scott Grossman from New York University, from Melissa Coe and Devin McKay from Indiana University, we now have 4 additional cases, so 5 total cases of patients who have vision loss, optic atrophy, and an SPG7 mutation without the rest of that clinical phenotype. And of these 5 cases, so 3 of them have this preceding history of Guillain-Barré with excellent recovery. 3 of them have the exact same mutation as mine and are also heterozygous. So putting them all together, I feel very confident that we've actually come up with the correct diagnosis. So key points from this case, in patients who have progressive vision loss with optic atrophy, consider genetic testing beyond just LHON, and consider including SPG7. And so not all patients who have SPG7 mutations will have the full clinical phenotype. They don't always fit into that nice, neat box of a pure phenotype. And certainly in patients who have HSP7, we know that they can have subclinical optic atrophy. So consider a neurophthalmic assessment of those patients. Things that I've already learned today that I'd like to add. So one thing that seems to be a bit of a recurring theme is how much we all love OCT. I think it is such a wonderful and useful tool. So I'd certainly encourage using OCT in any case where you might be suspicious, because it can certainly help point you in the right direction and confirm your suspicion that maybe there's something a little bit more going on. And then the other point that I loved from earlier on in the session, I think in the very first sessions, someone presented a case that had typical findings of a disease that had not yet been described. So just because something hasn't been reported yet doesn't mean it's not real. So I encourage us to keep collaborating, working together, and hopefully we'll discover more and more new things. So just here's a couple of my references, and that's the end of my presentation.
Thank you, Dr. Bernstein. That was an excellent presentation and something which we actually learned definitely. I just had a couple of questions because it's obviously, as you said, a new thing is sometimes hard to digest initially. So one question is that the preceding history of GBS, Guillain-Barré syndrome, and the weakness of the limbs, would it be associated with this? Or, I mean, you really think it was just incidental and may not have anything to do with the disease process or the genetic problem that the patient has?
So I think that's a very tough question to answer in retrospect. So this was 20 years ago. I was not practicing 20 years ago. So on the one hand, she had such a remarkable recovery, and that would be very unusual for your typical HSP7. But on the other hand, when we talked to other people who had similar experiences, as I said, 3 of these patients had this past diagnosis of Guillain-Barré, so that makes me suspicious that they probably are related. Maybe it wasn't quite the right diagnosis 20 years ago. So I think we just really need to be on the lookout and trying to piece these things together over time. So I suspect it was related, but I don't think I've got the full story yet.
So the one who was treating didn't have the benefit of your presentation to know that they could be related. So, all the tests were negative. So, I mean, really, yeah, you've gone through the entire test to look for any cause of optic atrophy, which essentially, we would be working up. So you do a whole genome analysis in this patient or in a patient whom you cannot identify any disease, or this was a targeted evaluation that you did?
This was targeted. So we do have, we've got a mitochondrial panel that we send. We have a Charcot-Marie-Tooth panel we send, and we also just have an SPG7 panel that we can send. So that was an intentional thing that we looked for.
Oh, okay, so great. There was a definite thought behind, because like I've said before, it's something that we rarely would have thought, and we would have still, continued down the line for eliminating other causes of optic neuropathy. You worked up like nutritional, of course, in India is something that we would look for, and of course, genetic is something that we should be increasingly doing, but of course, the cost and the fact that getting a whole genome analysis can be a challenge. So that was interesting to know that you targeted this patient based on 4 HSP7. So that was interesting. I don't see any questions in chat, and even during the course, the patient never developed any other features that we see in a complex HSP7. So no nystagmus, no any other systemic involvement that is known ophthalmic or non-ophthalmic. That was, and even in the other cases that you've said now that in collaboration you've picked up, even those patients have just isolated optic neuropathy.
So my case certainly has the longest follow-up so far of all the ones we've collected. And she does have that slightly wide-based gait. She does have that very, very subtle spasticity, but at the very beginning, we thought, well, she's got this history of Guillain-Barré. This is probably just a subtle leftover, and it hasn't progressed over the time that I've known her. So she has remained very stable. So nothing else has really cropped up. But she did have that, which is why I think it probably was related. But her eye exam, no nystagmus, no ptosis, no ophthalmoplegia. Really, the only thing that has gone downhill over the last, I guess it's been 7 years that I followed her, has just been the vision.
So just the approach is what concerns that essentially we have a patient with severe optic nerve damage, as you've shown on the OCT at the very onset itself. And while her Goldman looked pretty much okay, the HVF was affected. Could that be an initial learning curve, or like there was significant fall in the threshold, because the Goldman looked pretty much good?
Well, I love the Goldman for patients that I'm worried about, because I feel like you can coach them into giving you sort of the field that you want. So if you want them to do well and you take your time and really instruct them and are very, very patient, you can get a much better field. So for her, she was trying to carry on her life. She wanted to keep driving. And so that is one of the reasons why I think we got such a good Goldman, because I was very patient and persistent. I think it was real. She could see, just not very well. So I think you could, because it is such a subjective kind of test, I think you can really coach people one direction or the other.
Yeah, and HVFs in the beginning can be quite a challenge. So that can be so. So again, like I said, it's a pretty hard thought to have that, you're thinking so extreme. for a patient who's coming with bilateral optic neuropathy, severely affected, but the vision initially was not so bad and it deteriorates over time. So probably if you can't find anything, then you need to look at genetics as a possible, solution to your answer. I think that's one learning I thought of. Satya, any comments from you or the panel? I think there are some chat points you could ask.
There's a mention about the Goldman visual fields, and I think All India Institute has a machine, right?
Yeah, we do.
And how often do you really use it?
So that's what was one of the reasons why we use it. One is when we suspect that the field effect is not corroborating with what we're expecting. So probably just a learning curve. So instead of getting a patient go through repeatedly on a Humphrey, or if a patient doesn't understand, or sometimes that the patient is just not able to sit through such a test. So as Dr. Bernstein is talking about, you can have patience, you can stop the test of Goldman. You can be empathetic to the patient's problems, patients with other neurological problems also. So that's the most important. But of course, if there's severe visual field effect, or if you're looking for early peripheral involvement, constriction of fields, that would be the major indications I would go for Goldman. So I don't think there's anything else. Okay, any other comments you would have?
So the one comment was, what is the indication for genetic analysis? Yeah. I mean, the one thing about genetics is that there's no urgency. So in my case, the first thing I'm looking for is something treatable. And only when I've ruled out everything that's treatable, I mean, the patient, she wants answers. She wants to know, why is this happening to me? So this is something that you can save for down the road, because there's nothing we can do about it. Someday we will have treatment. But for now, I feel like the indication is that I have ruled out absolutely everything I can treat. We just need the patient to feel better, that she's not crazy, that there really is something that we can put our finger on. So I think that's really important too, that even though I can't treat this, I'm giving her an answer with confidence.
Just a curious question. I mean, at any time during the course she was with you, did you give her IV steroids before, of course, your genetic test? I mean, like, we would have probably, given her steroids, even thought in terms of a seronegative, NMO, or, maybe even tried Plex. So, of course, try to be as aggressive as possible as the vision is deteriorating. So was any interventions tried or, evaluated as a potential intervention in this patient?
I did give her a very brief course of steroids. Some wise neuro-ophthalmologist said, don't ever let a patient go blind without a course of steroids. So it's always worth trying, but it didn't do anything. And because I didn't have any good reason to continue, we stopped. I did not go as far as doing Plex, because that becomes more and more invasive. And again, without a good reason for it, I couldn't justify doing it.
Sure.
Someone just asked about cost. Fortunately, as a Canadian, I have blessedly no idea. I just send the test and it happens. Yeah, it's covered by our national insurance program, so I don't even think about it.
The cost in India is tremendous. I mean, now, of course, some time back we had challenges even getting it done, but now there are adequate labs that can give the result to you. I think of course, converting into dollars would be an absolute pitfall and disaster, but I think it costs somewhere close to 18 to 20,000. Satya, any?
Not really.
So it's costing about 18 to 20,000 as far as I know. But as I said, converting into dollars, you would start thinking it's peanuts. But for us, it makes a fair amount of cost. So, but still a challenge. So thanks, Dr. Bernstein. I think that was very interesting and very enlightening. And yes, something, as you mentioned, when you don't know the answers, I think you need to look at genetics to help you now, and increasingly as we have the options available, probably. Satya.
Yeah, thank you, Lulu, and thank you, Rohit. So let's move on to the next case. And let me introduce Dr. Kathleen DeGray, who is the Distinguished Professor of Neurology and Professor of Ophthalmology at the John Moran Eye Center, University of Utah, USA. She was the past president of the North American Neuro-Ophthalmology Society and also the past president of the American Headache Society. She sits on the editorial board for the Journal of Neuro-Ophthalmology. She has over 200 publications and has co-authored several textbooks. She worked to establish the Neuro-Ophthalmology Virtual Educational Library, novel, and she has received the Distinguished Service Award from NANOS, the Linda Amos Distinguished Service to Women Award, the Martha Hughes Cannon Award, the Rosenblatt Award, and the Lifetime Achievement in Headache Medicine Award. Over to you, Dr. Kathleen. You can share your slides.
Okay, you can see my slides and my screen,
Yes.
and you can hear me. Great.
Yes.
To be part of this amazing meeting. So my case is a 11-year-old girl who has eye pain and headache. She started out with a flu-like illness and maybe some pins and needles. She had a headache for 2 to 3 weeks. And so she went to the emergency room several times and had evaluation there. And she was treated with a migraine cocktail with no relief. She had visual blur-outs of her vision in her right eye more than the left. And she also had some dizziness. Her past medical history is really non-contributory except for attention deficit disorder. She does have a family history of a parent's mother with thyroiditis and an uncle with the same, and she's only on a medication for her ADD. She's referred to neuro-ophthalmology for vision-threatening papilledema because somebody finally looked in the back of her eyes and saw that she had disc swelling. And here are her discs. Her general exam was notable for being somewhat obese. Her acuity was 20/20 on both eyes. She had a very small relative afferent pupillary defect in the right eye. Her color vision was actually normal. Her stereo vision was normal. And you can see that—
Can I just stop, Dr. Kathleen? Your slides are not moving.
Oh, okay.
So while it's getting very interesting, but...
Okay, let's see here. Let me unshare and then share again. Okay, are they, let's see here. Are you seeing the visual field now?
Yes.
Okay. Hopefully this is good.
You need to make it full screen. I think a connection is lost. We can make
Yeah, I think so. You can't see her on the screen.
Yeah. Okay.
She has joined back.
Yes.
I'm not sure what is going on here, but things suddenly stopped. So hopefully, all right.
Yes, we can see your PowerPoint.
Okay, hopefully this will keep going. You can see the visual fields?
Yes.
Great. So you can see that she's got kind of an inferior arcuate in the right eye. Remember, this is the eye that had a small relative afferent pupillary defect. And you could argue bilateral blind spot enlargement. And can you see now her OCT?
Yes.
Okay. So on the OCT, you can see that she definitely has disc swelling bilaterally, more so on the right than the left. And that's what we saw clinically too. So we, of course, had an MRI scan to look at, and she did have dilated nerve sheaths and some mild flattening of the globe posteriorly, but the rest of her MRI scan was normal. And so the question is this idiopathic intracranial hypertension, garden variety in a young girl who is overweight with vision-threatening papilledema, or does she have some other condition that could be going on? So we sent her for more imaging, especially an MR with gadolinium and fat saturation of the orbits. And what we found was this longitudinally extensive enhancement of the right optic nerve. And you could see this on the axial, and you can see it also on the coronal. And you can also see that she has some leptomeningeal enhancement as well. So, of course, we did a spinal fluid examination, and she had a markedly elevated opening pressure of 440 millimeters of CSF with an elevated protein, maybe a slightly low glucose, and a lot of white cells, 437 white cells. And of course, this engendered a complete infectious disease workup for numerous entities which were completely negative. So she had a negative infectious disease workup. But another test was performed, and I would like to encourage the audience to tell me if you can think of another test that might be helpful here.
Yeah, particularly in view of that imaging finding, thickening of optic nerve there and enhancement, probably doing MOG and NMO antibodies is a good idea there.
Thank you very much. And that's what we did. So we did MOG antibody titers. We sent it to our local laboratory and also to the Mayo laboratory, and it was definitely positive. So this is an interesting case. The more we learn about MOG antibody, we learn that there's many different syndromes that can occur with it. Optic neuritis is the most common, and MOG cases make up a large number of these optic neuritis, especially if they're recurrent. But you can see myelitis, encephalitis, and in kids, this acute disseminated encephalomyelitis or ADEM. But interestingly, aseptic meningitis has also been associated with MOG antibody as well. And sometimes we have to distinguish between real papilledema, bilateral disc swelling due to increased pressure, but also MOG can affect the anterior optic nerve and give swelling as well. And interestingly, MOG antibody has been seen with or after many infections like mycoplasma, SARS-CoV-2, Epstein-Barr virus, and even vaccinations for COVID have reported MOG antibody associated with. And I also think it's important to see MOG associated disease in children versus the adult variety. So in children, it's usually optic neuritis and ADEM, or these brain lesions, and less commonly transverse myelitis. And in adults, of course, optic neuritis is the most common, myelitis next most common, and we don't often see ADEM. But I'd like to add this pseudotumor-like syndrome of MOG antibody as well. And I had never seen this before, where people presented with high intracranial pressure and this aseptic meningitis. And yet in the literature, there are several cases. Some are in young kids, as young as 6, and in adults as old as 50. And you can see that the opening pressure in all these cases is variable in the low 200s, but up to 650. And many of them have increased white cells. There was a case that said that they had very few white cells. So I think, though, it tells us that the spinal fluid examination is really critical in all these patients that we think have idiopathic intracranial hypertension. Treatment for this MOG-associated optic neuritis with a pseudotumor cerebri-like syndrome includes the IV methylprednisolone. Acetazolamide may be added when there's intracranial hypertension. Many of the cases that have had this pseudotumor-like syndrome have been placed on acetazolamide. A few cases have been treated with rituximab, mycophenolate, IVIG, and plasma exchange. Our patient really did well. She was treated with IV methylprednisolone for 3 days with an oral taper. And the last time we saw her, she had normal acuity, no afferent pupillary defect, normal color vision, and her OCT has gone from showing bilateral disc swelling to basically normal nerve fiber layer with maybe a little bit of reduction in nerve fiber layer on her right side, and her visual fields were also normal. So my take-home messages from this case is when somebody presents with idiopathic intracranial hypertension, but they have atypical findings. So one of the things that bothered me about her was, her swelling was really quite mild, and yet she had fairly significant visual loss in the right eye. This led us to go further in getting an MR of the orbits. And then also when we saw that longitudinally extensive optic nerve lesion, the suspicion for MOG antibody syndrome came up. And you really do need cerebral spinal fluid examination. I know lots of people are advocating if it's a typical person who's obese and they look like IIH, just forget the spinal fluid. But I think there's so many cases that we can get fooled on. Even people who are very seasoned neuro-ophthalmologists can get fooled. And the other thing is when children come in the door, I'm always a little bit worried because they present differently than adults, and we need to keep our differential diagnosis broader. And in general, this condition has a fairly good outcome with treatment. And with that, I'm going to stop sharing, and we can discuss this case.
Yeah, thank you, Dr. Digre, for that wonderful presentation. You indeed answer a lot of queries there. But I do have a couple of questions here. So in these patients of raised ICT, do we always have LT longitudinal involvement of optic nerve? Is it always there?
No, unfortunately. I mean, this case was so nice because I had that nice finding, but and many cases in the literature do show the optic nerve enhancing, but on occasion there isn't. And so I think you have to keep in mind that that spinal fluid told me that something more also was going on. Even if I hadn't had that MRI scan showing that optic nerve with that spinal fluid, I had to go further to find out the answer.
So in view of that spinal fluid analysis for pleocytosis, because it has been reported with NMO also, so would you advocate that you can do NMO testing also in these cases or any other cause of meningitis?
So in our centers, we almost reflexively do NMO and MOG together when we've got these weird optic neuropathies. So yes, I would probably do, well, we did do both. And NMO is negative.
Okay. And we also have some questions there in the chat box. So does this recurs, just like optic neuritis, the recurrence rate, as we all know, is very high in MOG cases. Does this raised ICT also recurs in cases of MOG positive patient?
In ICT, you mean?
Intracranial tension or intracranial pressure?
Oh, okay, intracranial hypertension. Not all MOG cases have high pressure at all. In fact, in the cases where we've done spinal fluid exams on MOG patients, most of them have a normal pressure.
Okay. So you would like to keep them on chronic steroids, just like we do for optic neuritis, for a long-term oral steroid therapy?
Well, in her situation and in many situations, the IV methylprednisolone really did treat it, and then we put her on a taper. So she was probably on steroids for about 6 weeks. She had the IV steroids and then a taper over a month, and she's had no recurrence. She's been pretty, and she's been very stable since. We've been following her, and she's been doing really well.
Thank you. Thank you.
I'd like to ask John Chen, if you're still on. John, how many of these cases have you seen with raised intracranial pressure, papilledema, and this aseptic kind of meningitis picture?
Well, that's a really good question, Kathleen. Actually, we're looking at that right now. We looked at 109 patients with lumbar punctures with recorded opening pressures, and 29 had elevated, with the definition of 250 or 280. So that's about 25%. Among those 25% that had elevated opening pressure, I'd say 80% had pleocytosis. So just like you said, you're going to be tipped off because there's going to be elevated cellus protein. I'd say about a third had bilateral optic neuritis. It was more of an optic neuritis picture than papilledema because they had vision loss, just like your case, Kathleen. And then there were actually a couple patients out of the 29 that had bilateral papilledema without enhanced with the optic nerve. I mean, it looked more like just raised intracranial pressure. And then there was about 50% that had they had opening pressures of, 310, but actually didn't have papilledema, didn't have, those signs of raised pressure. So sometimes, maybe just the pleocytosis may lead to elevated ICP that's asymptomatic. But yeah, overall, maybe 25% raised pressure.
Yeah. I really think that's important for us as neuro-ophthalmologists to know about it, that they can have this very unusual presentation. And I think it's a warning that we can't be glib about not doing spinal fluid exams. Every time you think you know something really, really well, you can get burned. And I think this case and the other case that was presented earlier, I mean, we've got to do spinal taps on these people. I'm sorry, but they need an opening pressure and they need to have their fluid looked at to make sure it's normal. And in the chat, my patient did go on acetazolamide because she did have those headaches, remember? And that really did seem to bring her pressure, her headaches went away. And I think another thing that, John, I hope you look at in your group of the people who had raised intracranial pressure, if any of them were overweight or obese, because a lot in the literature were reported to also have that be overweight or obese that had the raised intracranial pressure. So I don't know if there's a little interaction there that could also be occurring.
No, absolutely. I mean, patients could always have ticks and fleas. They could have MOGAD and and raised intracranial pressure from, obesity, being female, that kind of deal, for sure.
But I do think that the cells in the spinal fluid are, when you come up with a negative workup, put MOG in, and some of these other weird things, but we've got to maybe be thinking more about MOG. Antibody testing and some of these aseptic meningitides that we in the past have had no idea what it was.
Yeah, so I think that's a major take-home lesson. Yes, spinal tap is mandatory, and if you have pleocytosis particularly, you need to work up for all the suspicious investigation you should do. Right. Thank you, Dr. Jegre. Thank you. It was always a pleasure to listen to you.
Thank you so much.
Thank you, Kathleen. Thank you, John. Thank you, Swati. So now we go on to the next speaker. For today. And next we have Dr. Fiona Costello, who is professor of departments of clinical neurosciences and surgery and a clinical scientist at Hotchkiss Brain Institute in the University of Calgary, Canada. She is a chair to the Roy and Joan Allen Investigatorship for Vision Research and is working to establish a translational vision research program at the Hotchkiss Brain Institute. She is currently an editorial board member with several academic journals, including the Journal of Neuro-Ophthalmology, the Journal of Neurology, and Neurology. She has also worked in leadership roles with the Canadian Neurological Society, the Canadian Neurological Sciences Federation, the NANOS, the International Women in MS Network, and the Americas Committee for Treatment and Research in Multiple Sclerosis. Over to you, Dr. Fiona.
Okay. Can you all see my slides?
Not yet.
Okay. No? All right.
No.
After all this time, you'd think I know how to do this. Nope.
Yeah, no, this is the background slide.
Yeah.
Need to
What
share
is-
the.
Now?
Yes, we can see
You can
the.
see them? Perfect. Okay, you can see them?
Yes, yes.
Awesome. Okay, so I know everybody's tired, and my talk, I hope, will be brief. Durga's the boss, and maybe we'll try and make this as an add-on to Kathleen's talk because it's an extension on the same theme, hopefully in a way that will provoke discussion. And I'm grateful to be here, standing on the shoulders of giants, and honored to be part of this wonderful group. I learned a lot from the cases thus far. And so my case is it's a little bit country and a little bit rock and roll, like somewhat similar to Kathleen's, but a different age patient. So I have a 30-year-old lady, Durga, who presents with a recent history of eye pain and headaches. Now, she's actually had some increase in her headaches over the past year or so. And like many folks during the pandemic, she gained a little bit of weight. But more recently, like over the last week, she's had some blurred vision in both eyes, and she reports pain with eye movement. She's had no recent travel and no recent infectious symptoms. Her only relevant past medical history is anxiety, and she's had, importantly, no other toxic exposures or medication ingestions. Now, when seen, her acuity is mildly down at 20/40. She has no RAPD, as she has a bilateral problem, and normal motility. And these are the visual fields that she presents with. And I know what you're all thinking. She's got a little bit of a decreased foveal sensitivity in both eyes, a slightly constricted pattern. It wasn't an easy test for the patient. It took her almost 10 minutes in the right eye. She lost the will to live. She did a little bit better in the left eye, but kind of lost the will to live during this test, as it was the better part of 10 minutes. And she has this sort of pattern of constriction, if you'll all agree. And shown here, and I'll explode this picture a little bit, she has mild optic disc swelling, which I think would be difficult for a neurologist to pick up with direct ophthalmoscopy at bedside, but the pictures do us a big service and show us that she's got some mild blurring of the margins and slight elevation of the nerves. And for those who doubt that, we have our friend, the optical coherence tomography test that was done, and it showed commensurate peripapillary RNFL measurements of about 168 in the right eye and 155 in the left eye. There was no immediate macular ganglion cell interplexiform layer testing done, and I think that's something that to learn from going forward that may come up in the chat. But with this in mind, we're all asking ourselves, what would you investigate at this time? Because we really need to know the mechanism of this patient's vision loss to know how dire this might be and what treatments to orchestrate. And I think what I'll do is, it's hard for me to see the chat, is maybe just feel free to interrupt, or I'll just kind of keep marching on and we'll get to the discussion.
I would like to know the color vision of the patient.
Good question. So the color vision's mildly down. It's like 3 out of 7 HRR plates in both eyes. Any other questions?
For the visual acuity and the disc, the fields, they are not correlating.
Absolutely correct, right? Absolutely correct. But we have no RAPD. We have diminished mild visual acuity, maybe a more prominent color vision deficit, and these fields as shown. But it is what it is. So what investigations shall we arrange at this point?
Was a BP done?
Pardon me?
Was a visually evoked potential done?
No, it was not.
BP check?
Blood pressure is normal, 120/70.
Yeah, we should go ahead and image her.
Okay. So is this kind of standard practice where in my neck of the woods, the patient initially presented with a CT of the head with venography, which was read as normal. She had a lumbar puncture, different than Kathleen's case. The CSF was completely normal. but she does have an elevated opening pressure of 38 centimeters of water. This is her MRI scan, and I think you can appreciate here that she has some enhancement along the intraorbital portion of both optic nerves. You can see some sort of jutting of this optic disc into the vitreous here in the right eye. And there is a bilateral enhancement of both optic nerves. Does everybody agree with that?
Yes.
Yeah, interesting. And you know what was reported on this MRI? And I throw this into the bullpen for thought. And this actually, I think, kind of really, through a very, very good neurology team looking after this case. It was reported that these findings can be seen in the setting of idiopathic intracranial hypertension. And I'll wait for comments on that. So what do people think? Is this IIH, and what bothers you? If you
didn't show us the T2 images.
No, this is all you got. That's enough here to make a decision. Okay, let me rephrase it. Should you see this? Should you see optic nerve enhancement in IIH?
No.
Yeah, maybe signals at the apex of the optic nerves. Sometimes we've seen in IIH. I'd like to take Dr. Veena ma'am's opinion on this, because I've seen her commenting on IIH patients with optic nerve signals at the apex and of the optic nerve, but I haven't seen enhancement of the optic nerves in IIH. Dr. Veena?
Not there.
She's not there.
It's okay. I'll tell you what, in the literature, if you read, and I think it's really important for, I think for anybody on, the call, anybody in the conversation, is not to believe everything you read. And I think that when you're early on in your career, you believe the radiologist's report, and I'm not disrespecting radiologists. I think they're doing their best, but we always have to be challenging our own hypotheses. We have to challenge what we're told, because we have the benefit of a very robust clinical evaluation. We're privy to way more information. And so there were a few things that bothered me about this case that made me not want to dismiss this finding. And I don't entirely believe the literature that tells me sometimes you'll see optic nerve enhancement with IIH, maybe, okay. I think it's been reported that you can see sheath enhancement with IIH, but like you are all thinking, I wonder how many of those cases didn't have IIH and they were just sort of a square peg jammed in a round hole, because IIH is a diagnosis of exclusion. And to Kathleen's earlier point, if you don't rigorously work up the patient, for example, with a lumbar puncture, you could label something IIH that isn't. And then there are other syndromes that could mimic IIH, but are in fact not IH. And there's some very sort of, I think, important findings that sort of struck me about this case. And who here agrees with me? I felt that the vision loss was more than I can attribute to the barely there disc edema of IIH. Does everybody agree with this? I'll go back to the nerves. I think this is the most important clue. If this is IIH, does this explain the degree of this patient's vision loss? A color vision deficit in both eyes, 20/40 vision. And I mean, I'll even give the patient the benefit of the doubt and say that she found the fields tough. Okay, so that was actually what prompted me to kind of move on with this case. I think that's the most important thing. Everything else could confuse you. Okay. So this patient then, that's what bothered me. So 1 week later, she represents after being discharged on Diamox 500 milligrams twice a day. And I'll ask you this. This is another question for the group. If this was IIH, should we escalate therapy? Like, would you be comfortable just treating this patient with Diamox were she to have central vision loss in both eyes in those fields? I also throw that to the group. Any takers? Because I'll say I would be very worried about central vision loss in an IIH. Yeah, sorry, go ahead, Revati.
Central vision loss is not something we see with IIH, especially with the week. Within a week, if she's presenting with central vision loss, I would go back and look at my diagnosis again.
Oh, this is excellent. I think the process of thinking it through. So Lulu's right, like central vision loss to this extent without massive papilledema, which would be dire, like we'd have to put a lumbar drain or fenestrate this patient, right? Or another explanation like subretinal fluid through the macula. It would really bother me. I think that could have thrown people if there was fluid in the macula, you could get a little bit of color vision loss, but I did not feel that I could reconcile the extent of vision loss based on the proposed mechanism. But then the patient, unfortunately, evolved in a way that took this case in a different direction. So she comes back on her Diamox and she's worse. She's now count fingers in the right eye, and she has this picture in the left eye. What do people think?
Her with steroids.
Yeah, you're worried, right? Now, bear in mind, there are people who would say, and it was said that this patient met criteria for IAH. She had normal CSF. She had bilateral with papilledema. She had bilateral disc swelling. Some people, not me, will side with the fact that you can have optic nerve sheath enhancement with IAH. It's reported. I'm not saying you should necessarily believe it, but I throw it out there. And so this is her now. So you can see everyone that there's much more substantial optic disc swelling. There's some chorioretinal folds here and peripapillary wrinkles. This is a much more prominent picture. Everybody agree? The disc swelling is worse.
Yes.
And if you don't agree, the OCT will help you. And it's tells us that the measurements now are 223 in the right eye, 278 in the left eye, with some evolving ganglion layer changes. Now, bear in mind, this is a process about 3 to 4 weeks in the making. And this patient is now count fingers in the right eye. Okay. Next question. This could throw a lot of people. Oh my God, this is fulminant IIH. Should we fenestrate the patient?
No.
Why not? Should we put a lumbar drain in the patient? You can imagine this would be quite difficult, right? For the inpatient service, this is worrisome because they will have read all those papers from the idiopathic intracranial hypertension treatment trial that you see chorioretinal folds and peripapillary wrinkles in IIH. Is IIH gone bad? Is that it?
Did we miss the MRV and the lumbar puncture?
The lumbar puncture was normal in terms of CSF analysis with an opening pressure of 38 centimeters of water. But another diagnostic procedure was performed. What do you think it is? You guys know this.
Animal MOG.
Absolutely. So in this case, the patient had serum MOG IgG with a cell-based assay showing high positive values. But a little bit different than Kathleen's case. I think this patient had 2 diagnoses. And I actually think, to the earlier discussion, in those with, say, normal CSF constituents that John mentioned, I think there's a lot of indolent IIH out there. And I see it coexist with many things. And I think my take-home message is a patient may have a single unifying diagnosis that unites all the features of their case in the spirit of parsimony, but to quote Hickam Dickham, so John Hickam was a doctor who said a patient may also have as many diagnoses as he damn well pleases. His words, not mine. I would argue that this patient meets diagnostic criteria recently proposed by Banwell and colleagues in Lancet Neurology for MOGAD with a clear clinical event, bilateral severe optic neuritis, which progressed to count fingers vision in the right eye. The patient also had not an equivocal, but high serum MOG IgG result and had MRI features with the benefit of hindsight that fit with the diagnosis. Bilateral optic nerve enhancement, and John has taught us this from the AJO that we see sheath enhancement sometimes extending into the orbital contents, and that we can get longitudinal lesions within the orbit. And the patient had optic disc edema. And so in this case, I would challenge the literature in saying, yes, there are patients, I believe, to Kathleen's point, that have a syndrome of optic neuritis with raised intracranial pressure. I'll certainly buy that because we know that patients can have raised intracranial pressure with any inflammatory CNS process. I think that children with ADEM, especially those under 11, are likely to have MOGAD and may have more than one clinical presentation of the same. I think you can get unusual signs in IIH. I'm open-minded, but I also think that we're going to see more and more people presenting with more than one diagnosis, and that we shouldn't assume that 2 + 2 = 18, because the patient can have as many diagnoses as they please. Thank you.
Thank you, Dr. Fiona. It was an excellent case. I have a few questions. So did your patient have any associated encephalitis or encephalopathy picture?
No encephalitis, absolutely no features of that.
And what is your experience of overlap syndrome, such as concurrent MOG-IgG antibodies with encephalitis?
So I have seen, I'm a neurologist, so I do see a lot of overlap syndromes. I haven't seen the NMDA receptor encephalitis MOGAD syndrome myself. What I've seen is optic neuritis and then an AIDP picture, which you can get, or an acute inflammatory demyelinating polyneuropathy. I've seen sequential involvement of a longitudinal transverse myelitis with MOGAD, and then I've seen an autoimmune encephalitis. I've seen flame syndromes, as well as optic neuritis. So I think the point I would say there is MOG is a long game, and don't expect to define the characteristics of your patient based on one visit, because what might start as a Creon-like picture could later become a more mixed picture with other features. And what might start as an ADEM picture might become an ADEM plus picture with more optic neuritis.
And Dr. Ambika has commented the MRI is not suggestive in your patient. Only positive findings for IIH was the BMI being high with a the bilateral disc edema, but the MRI was not suggestive of IIH.
I totally agree. And I think that I don't believe that optic nerve sheath enhancement or optic nerve enhancement are features of IIH in my own experience, and I've seen hundreds and hundreds and hundreds, as of many people on this call, of IIH patients. I also see a lot of MOG. And so I think we have to challenge the literature, because this is what's out there. And this is honestly what threw the team for a loop, because they were able to find, and it was cited in the radiology report, that this is an expected feature of IIH, albeit not typical.
And how frequently do you see fulminant IIH, and how do we differentiate in this clinical setting of optic neuritis? And I think you've covered this, but how do we differentiate optic neuritis and papilledema?
Yeah, now I would argue, really good. So we'll go back to that. I would say John's agreeing with me, not disagreeing with me, because a dog can have ticks and fleas, meaning that there's 2 reasons for that dog to scratch. And having ticks doesn't mean you're immune to fleas. And so what I would look for is, I always try and say to myself, can I explain the mechanism of the vision loss based on, can I explain the vision loss based on my mechanism? So in fulminant IIH, I'm expecting to see really quite significant disc edema, or I might see a mixed picture of evolving atrophy and less robust optic disc edema. The OCT will often show me disc edema and evolving ganglion layer, thinning. I'll want features of transient visual obscurations, pulsatile tinnitus, and this patient in retrospect did actually have a longer standing history of pulsatile tinnitus. I want to be able to show an opening pressure. I want to meet the diagnostic criteria, and I want to show benefit with the treatment. If I had a patient, and that was my point, if I had a patient with vision loss that I truly thought was due to IIH at presentation, I would have treated the patient really aggressively. And the other take-home pearl is, when in doubt, use both. We use high-dose steroids all the time as a salvage therapy to get patients to a CSF diversion procedure. So what I would say about Kathleen's case is, while you're waiting for the investigation to roll out, and to echo Lulu's earlier comments, you can work up the ICP angle while treating an inflammatory angle if you think your patient has an inflammatory basis of raised ICP. And kids with MOGAD may in fact have that, because they're also predisposed to ADEM. So I think the short answer is there's really no downsides of treating with steroids in a control setting if you're not sure. I don't know if people agree or not.
So did your patient receive steroids?
So the patient was readmitted to hospital and then did in fact receive steroids and then went on to Plex. Because if we don't in my institution, even with MOGAD, see a pretty quick response to steroids, you know, when you've got someone teetering on the nice edge with the ganglion layer thinning that we saw in that right eye, we'll go right to Plex. And I know what you're all asking is how did she do? And so now she's 20/20 with resolved fields with a little bit of optic atrophy in the right eye.
Great. So how long do you wait for Plex? Immediately when you see GCC thinning? Or
That's a $1 million question. Yeah, there's no right answer, but I'll tell you what I do. I'll see what other people do. So firstly, I'm nervous. I have a patient. I mean, because in Canada, it's going to take me a week to get the MOGAD IgG or the aquaporin 4 IgG. We know MOG is often exquisitely sensitive, but honestly, it really depends on how worried am I that this patient is going to suffer irreversible vision loss if I dither. And so if I'm confident that I'm early and I just need to give it a few days, I might sit on a pulse of steroids for 3 to 5 days. If I'm really not, like in this case where I feel that the patient's maybe had like a relapse now, I went to Plex after 2 days. But it's very, very much a patient-centric decision based on the merits of the case and my particular fears for that patient about risk of vision loss. How do other people feel about that? I don't think there's like, I give it at 3.3 days. There's no such answer because all of these cases are different.
And what is the predictive value of, what is your take on predictive value of MOG antibody?
Yeah, you're poking the snake here. Okay, so we could divide the room. So we know from the Banwell proposed criteria that we should get MOG at baseline, ideally before starting immunotherapy. In my world, what I'll do is I'll draw the serum and then I'll start the treatment simultaneously, you know? Secondly, because you get a false negative if you have a patient on immunosuppressant therapy. Do I think that's going to occur day 1 of treatment? Not really. But I get the MOG IgG. Then what I do and what I should do is I should recheck it about 3 months later or at the time of relapse. Classically, the teaching is that a high positive titer should predict, especially if it remains high over a year, will likely predict more propensity towards relapses. Whereas if that completely dissipates and becomes normal, maybe the patient has over a year less chance of relapse. But the truth is, we don't know. Because the patient can seroconvert from negative to positive at the time of a relapse. And also many of these patients are immunosuppressed after their first or second presentation. So you might be getting a false negative. So I think that I personally am going to be repeating titers, but it's only so I can learn from myself what I can predict in my lab, because we also all have different labs. And so I want to know what I can predict in my lab and what correlates with increased chance of relapse versus monophasic disease, which is by literature reports supposed to be the case for 40% of MOG patients. But to call something truly monophasic, you have to follow the patient for their entire life and see if they have another relapse. Do people agree or not agree?
Other panelists, may Dr. Johnson or would you like to add, please?
I completely agree. You know, it's hard to know. A lot of patients will stay positive and they don't have relapses and they become negative. Then I tell them instead of a 50% chance of relapse, maybe there's only a 10 to 20% chance. But we do it. It's partly academic. If they become negative, I feel a touch better, but it doesn't really change my management. I guess one more thing that we can chat about is if they're really classic MOGAD phenotype and they're negative in the serum, the CSF may actually pick up maybe an additional 10%. So it's very different from NMO where the aquaporin 4 CSF is completely worthless. The MOG CSF may be helpful in certain scenarios. The drawback is getting a reliable lab to do it. I know at Mayo, we have a lab that is good, but it's not commercially available yet, probably until another 3 months. But if you have a patient, you can send it to us for research purposes and we can test it. But I know there's other CSF labs out there for MOG, and I think it will be helpful.
Well, I'll split hairs a little bit because in the Banwell paper, and there were Mayo folks on it, John, like they're not strongly advocating for it. In our lab, the CSF MOG will not be positive in a pure optic neuritis patient, but will be positive in an ADEM patient. And I'm searching for my longitudinal extensive transverse myelitis patients to see what the percentage hit rate is. But we have different labs. So I'm happy to send and see if it's positive or not, if there's consistency across labs, because I think it's a really important question. When in doubt, though, and I think the spirit of your comment is something I agree with 100%. When in doubt, you have to go for whatever tissue like diagnosis you can find. And if I feel that I have a seronegative MOG, I'll definitely do it if I'm really convinced and the patient's suffering. I think it's really interesting. I would have thought differently about this case if my patient didn't have a classic IIH phenotype and a history that made me think she had IIH in the background and a more acute presentation of MOG. That would make me rethink the data. And I think it's really important that we remember that these are clinical diagnoses. And that's the most important thing. Like low titer MOG, you might have a clinical phenotype that fools you. And so I really actually threw this case at the group because I want to remind everybody just how important the basics are. A good history, a good exam, and really asking yourself, do I really buy what I'm hearing on the report that I just got? Because this doesn't jive with my clinical gut instincts. That is actually my take-home point.
Yeah, I think, and going back to your case, in terms of optic neuritis, you're right. They are much less likely to be isolated CSF MOG. The Japanese group found 0. We find a few. So again, among ophthalmologists, it'll be a little less high yield, but still something we could consider. And I thought having your case and Kathleen's case back to back was amazing. Kathleen's was, great. It was probably MOG driving raised intracranial pressure, and then yours was kind of the ticks and fleas, where the patient has 2 diseases. So it's Occam's razor versus Hickam dictum. Which one's going to win? And either one could be true. So I thought those were amazing cases to go back to back.
You're kind, John, because when I saw Kathleen's case, I was like, oh no, bad enough to be following Kathleen. But then I'm coming in with a version of the same case. But I actually think now that that's why I was trying to spin it a bit differently. But I think there were definite aspects of Kathleen's case that differed from my own. And in the adult population in my neck of the woods, where we have a rising obesity epidemic, we're going to see IIH as a bystander to a lot of other acute processes that affect our patients.
Yeah. Was a great case. Thank you. Very enlightening session. Thank you, sir. And thank you, everybody.
Thank you very much. Thank you, Durga. Thank you, Fiona. So we call it a day or night now, and see you all tomorrow for the next interesting day of the Global Case Festival. Thank you. And